Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi all, periodontal disease or pyorrhea, as we all know, it is inflammation of the supporting structures of the teeth, that is the gum and the bone. Studies have shown that there is a lot of association found between the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there is a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from an adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be an underweight of the baby, which itself is a risk. So, how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So, let's make a motherhood safe. with a healthy child and a safe mother. Thank you.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been all conclusively said that a poor oral poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details and nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details and nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi all, periodontal disease or pyorrhea as we all know, it is inflammation of the supporting structures of the teeth, that is the gum and the bone. Studies have shown that there is a lot of association found between the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there is a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from a adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be a underweight of the baby, which itself is a risk. So how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So let's make a motherhood safe with a healthy child and a safe mother. Thank you.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world, with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge, and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases, and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, It reflects that very less number of patients are being treated for periodontal conditions into our clinical practices, and this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi all, periodontal disease or pyorrhea, as we all know, it is inflammation of the supporting structures of the teeth, that is the gum and the bone. Studies have shown that there is a lot of association found between the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there is a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from a adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be underweight of the baby, which itself is a risk. So, how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So, let us make a motherhood safe with a healthy child and a safe mother. Thank you.
Good morning, Mansi ma'am. Good morning, Jyoti ma'am. Welcome.
Good morning.
Good morning, Dr. GP. Good morning, Dr. Mansi.
Good morning, ma'am.
Ma'am, a slight change in the program was just to update Mansi ma'am.
Yes.
Ma'am, earlier we had planned that we will have all the posters together and the question answers after that.
Right.
But it was leading to some wastage of time. So we are going to have the question answer after every poster. For
Okay.
example, 3-minute poster presentation, and we have another 2-3 minutes for questioning.
Okay, right.
Good morning, Sejal. Are we ready to go?
Yes, sir. Good morning.
Yes, sir.
Yeah, we will start.
So can we start?
Yes, yes, please do.
Yes, please.
Okay. So very good morning and a warm welcome to you all. I extend a warm welcome to you all on this virtual platform of 19th ISP PG Convention on the behalf of entire Indian Society of Periodontology. After yesterday's wonderful session, let's begin for today. We have with us Dr. Mansi Bansal ma'am and Dr. Jyoti Gupta ma'am for chairing the session. Dr. Mansi Bansal ma'am, she is a graduate from King George Medical College, Lucknow, wherein she received silver medal and certificate of honor throughout the study period and did her masters in periodontics from Swami Vivekanand Subharti University. She is actively involved in academics and currently is professor at Institute of Dental Sciences and Technology, Modinagar. She is reviewer of various dental and periodontal journals and was an ex-assistant officer for PubMed Index Journal of Indian Society of Periodontology from 2016 to 2020. She has received scholarship for scientific presentation at Singapore by ICMR New Delhi, and she has many national and international publications and award-winning papers to her credit and maintains an exclusive consultation and practice in New Delhi. We welcome you, ma'am. Second chairperson with us is Dr. Jyoti Gupta ma'am. Ma'am did her graduation from SGRD Amritsar and post-graduation from GDC Amritsar. Presently, she is working as assistant professor in the Department of Periodontics, Dental Institute, Punjab University since 2007. She has attended various national and international conferences and symposiums pertaining to her field of specialization and has chaired many scientific sessions. She has also been an active member of organizing committee of various national symposiums and conventions. Ma'am has to her credit more than 20 research paper publications in international and national journals and a number of paper and poster presentations. She has been extensively involved in the epidemiology related work and has worked as a co-investigator in different research projects from time to time. We would like to invite you, ma'am. Thank you.
Thanks a lot.
Thanks a lot, Son.
Welcome, ma'am. I request both the chairpersons. Yeah, just a second. Yeah.
Shall we start?
Yes.
Yes,
Yeah.
I think we should start.
Okay. The first presenter, Priyanka Ray. You can start presenting the poster.
Am I audible, ma'am?
Yes, you are.
Okay, today we are going to present a case report on comparative study on gingival depigmentation technique using diode laser and conventional scalpel technique. Pigmentation of gingiva can be a cause of much aesthetic concern, so a number of techniques can be used to correct it. So in the following study, two techniques have been used, that is scalpel technique and diode laser, and they're compared in terms of pain, wound healing, and recurrence of pigmentation. The patient here is a 30-year-old male who reported to our department with chief complaint of black gums. On examination, a pigmentation score of 2 was found. The MET index was used for the pigmentation criteria. The patient was otherwise systemically healthy. Depigmentation procedure was performed on maxillary anterior segment from canine to canine region under LA. The right segment, that is 11 to 13 region, was operated using diode laser, while the left segment, that is 21 to 23 region, was operated with scalpel. Both the procedures were done on the same day. Popac was given after the procedure. Analgesics and postoperative instructions were given to the patient. Visual analog scale was used to assess pain. At 1 day postoperatively, patient reported mild pain on site operated with scalpel, while no pain was felt on site operated with laser. Healing was assessed clinically using healing index by Laundry et al. Complete healing was seen on both sides 1 week postoperatively. Recurrence of pigmentation was assessed clinically. No recurrence of pigmentation was seen during the 3 months follow-up. To conclude, it can be said that both scalpel and diode laser give satisfying aesthetic results. However, diode laser has advantage over scalpel technique in terms of providing bloodless fill, patient comfort, minimal or no pain. And a long-term follow-up would be necessary to evaluate recurrence of pigmentation. Thank you, ma'am.
How did you assess healing?
Ma'am, we use the healing criteria by Landry et al.
But you didn't mention in your case report, in your poster.
I was about to say it, ma'am. Actually, I thought we don't have to write that one.
Any other criteria for assessing healing?
Ma'am, we can use hydrogen peroxide also, but then it's not used nowadays because it can cause damage to normal cells also. So,
any other criteria?
Any other criteria? No, ma'am. As such, no, I'm not aware.
How does healing differ in both the cases when you do a scalpel and when you use a laser?
Ma'am, as such, healing by diode laser, it usually takes time. I mean, it takes longer time than pigmentation. But in my case, both of them like healed around same time period. Like in 7 days, both of them healed properly. Like proper healing was seen in both sides.
Is there any disadvantage of using laser?
As such, I have not found any disadvantage other than, yes, ma'am, it is a bit expensive. Other than that, no, ma'am, I haven't found any disadvantage.
Now I'm asking generally, is there any disadvantage of laser over scalpel?
Generally, any disadvantage? No, ma'am, not that I can assess. No, ma'am.
Okay. Jyoti, ma'am?
Yeah, when you took the healing index by the Landry criteria, what was the score in at both the areas?
It was 5.
At both the areas?
Yes, ma'am. At both the areas, it was 5.
Okay. Fine.
Okay, ma'am. Thank you.
ठीक है जी, thank you.
Okay, ma'am. Thank you, ma'am. Ma'am, shall I start?
Please. Yes, please.
Good morning, dear esteemed judges. Today, I, Dr. C.V. Shruti Vyasani, am here to present my case on the topic, apically repositioned flap for exposure of labially impacted maxillary canine, a case report. The canine plays a major role in aesthetics and helps in establishing a proper dental arch form, according to Bas T.B. et al. In 1957. But unfortunately, the maxillary canines are the second most impacted piece in the oral cavity after the mandibular third molars. Therefore, a proper management of an impacted canine is important. The surgical intervention is one of the most common treatment modalities to expose the impacted teeth, especially those which are labially impacted. There are three surgical techniques: the apically repositioned flap, gingivectomy, and closed eruption technique. Amongst all these techniques, a study done by P.J. Sandler et al. In 1999 stated that the apically repositioned flap is one such procedure amongst all these, which is very quick, simple, and a reliable method for exposing most teeth that are impacted labially. This technique also helps us increase the amount of keratinized gingiva. So the case that came to the department, a 14-year-old healthy male reported with buccally erupting left maxillary canine. On intraoral examination, the tooth showed an erupting position labial to the crest of alveolar process. The tooth was present entirely within the soft tissue. We did a brief case discussion, and then the patient was scheduled for the surgical exposure. After administering the patient with LA, the apical extent of the impacted teeth was estimated by transgingival probing. Then a sharp V-shaped dissection was done using 11 number scalpel blade and was given around the coronal tip of the tooth. These vertical incisions were then extended to the 6 mm above the buccal vestibule, and the underlying tooth was exposed both on nasal and distal aspects, and the flap was freed, and then it was sutured back on the apical most border of the exposed tooth, and it was sutured with 303 sutures. After 1 week of suture removal, after post-operative instructions and 1 week of suture removal, we saw that there was uneventful healing seen with absence of bleeding and pain, and aesthetically pleasing results were achieved with adequate width of attached gingiva. So what we saw here is, I would conclude that we definitely need a surgical exposure of any labially impacted teeth before the orthodontic treatment. But in this case, we can see that the coronal two-third of the crown is almost coronal to the mucogingival junction of the oral cavity. So here we can do two methods, either gingivectomy or apically repositioned flap. In this case, as we could not appreciate a good width of attached gingiva before the surgery, so we needed to increase the width of attached gingiva. Thus, we opted for apically repositioned flap, and in such cases, we would recommend that apically repositioned flap is a better technique for the surgical exposure. Thank you.
What is the limitation of apically repositioned flap?
Ma'am, the only limitation is that it may cause either gingival recession, or it may also, the flap if debrided, may also cause some infection, or it may lead to some complications which are generally related with flap. Otherwise, for increasing the width of attached gingiva, this is the best technique, and it is a very simple and quick technique.
No, what I mean to say is, in what condition you will not go in for apically repositioned flap?
Okay, ma'am. So in the case where, as I said that this labial impaction was almost coronal to the mucogingival junction, as we can see. The tooth, coronal two-third is almost coronal. In cases where the tooth is impacted too much into the bone, or it is impacted high above the mucogingival junction, there we cannot access the flap first of all. So there we cannot do the apically repositioned flap. And there we will go for some other technique like closed eruption technique.
What about palatal impactions?
Ma'am, palatal impactions are actually greater than the labial impaction in percentage. And in case of palatal impaction, we can go for many methods. The methods like closed eruption technique is also there. The tunneling technique is also there.
and tunnel traction technique is also there, and open window technique is also there, ma'am. In tunnel traction technique, if there is a deciduous canine, we will guide the permanent canine through the via the deciduous canine, like that. So there are many other techniques also in tunnel traction.
Jyoti ma'am.
That's fine, Dr. Shruti. Fine from my
Okay,
side.
ma'am.
Thank you.
Okay, thank you, ma'am.
Next.
Shall I start now?
Yeah, please.
Good morning, everyone. Today, my topic for my poster presentation is root coverage procedure in the treatment of gingival recession. This is a case series. The gingival recession is the apical migration of the gingival margin to CHA.
Just a minute. This is a presentation from Dr. Sadaf.
Yes,
Can we have your video on, please?
Yeah, it's on, ma'am. Gingival recession is the apical migration of CHA, and the distance between CHA and gingival margin gives the level of recession. In this case report, I'm describing two cases, which is two techniques basically. One is tunnel and pouch technique using CPG, and other is coronary position flap. So the case one defines tunnel and pouch technique. A 19-year-old female patient came to the Department of Periodontology at Saraswati Dental College. The chief complaint was root sensitivity and poor aesthetics on her mandible central incisor. So the recession on intraoral examination, we found that it was Miller's class 2 gingival recession, and we decided to do tunnel technique. To prepare the recipient side, a circular incision was given on both the sides, and a partial dissection was carefully performed in order to create a deep pouch beyond the mucogingival junction, while keeping the tip of the interproximal papilla attached to the teeth below the proximal contact point. Now, to prepare the donor side, a primary palatal flap side with one line incision, which allows the harvesting of thick, sizable scientific tissue, was prepared. Then the primary flap was immediately sutured to prevent the bleeding, and the CPG was placed onto the recipient side with 4-0 suture, and it was directly inserted into the pouch and was then stabilized using the flap, using 5-0 vital sutures. Then a periodontal pack was placed, and then the patient was advised not to brush for 72 hours in the area of the surgery. Then an ice pack was given immediately to post-operatively and asked to restrain from spitting and rinsing for first few hours. The patient was recalled after 24 hours and 3 days, and then after 1 week. The pack was removed and the area of operation appeared normal without any trace of sloughing. The healing progressed eventfully, and the gingival recession was totally covered with beautiful aesthetic results. Then other case 2 is coronally advanced flap, where a 45-year-old patient came to Department of Periodontology with the chief complaint of sensitivity in upper tooth region. During clinical examination, it was found that it was Miller's class 2 gingival recession noticed in relation to the maxillary lateral incisor. Due to the presence of sufficient attached gingiva apical to the recession in the buccal area, surgical planning was directed to the coronally positioned flap in order to obtain the desirable result. Proper isolation of the surgical field was done. With the help of Gracie curate, recession defect was thoroughly scaled, and the operative site was anesthetized. Then after raising the full thickness periostal flap, 2 parallel vertical incision at line angles of the same tooth were given to outline the surgical area. An intracircular incision was made using 15-number blade to connect the 2 vertical incisions. Then flap was reflected to the level of mucogingival junction. To facilitate coronal movement, the base for flap was undermined and separated from the periosteum with scissors. The flap was coronally positioned to cover the recession, and suture were given with 4-0 non-resorbable suture. Oblique releasing incision were also used to close the sutures. Gentle pressure was applied against the flap for 2-3 minutes to secure the good adaptation. Results were satisfactory. Healing was found at the time of the suture removal. After 3 months follow-up, 100% coverage was noted, and there was no post-operative complication were observed. Thank you.
How do we determine the predictability of a root coverage procedure?
Ma'am, it is basically depend on the which type of recession coverage we are doing. Like in Miller's class 1 and class 2, we can predict that it can be 100% root coverage, while in class 3, there is little chances of purely 100% coverage, and while in class 4, we cannot predict. It is
No, what I'm
leading to.
asking is, suppose you have a Miller class 2 recession and you do a CT graph and you do a coronally advanced flap. That's what you have done in your case report. In
Yes,
which
ma'am.
case do you expect more better results? How do you determine predictability?
Better results were actually found in using CTG, because it is leading to us giving us both soft tissue and hard tissue augmentation, ma'am. In case of,
How do you assess the hard tissue?
ma'am, basically radiographically we can assess, but in this case there was no interdental bone loss, so because of which we actually were able to gain good results.
Dr. Jyoti? Dr. Jyoti?
Yes, yes. I got disconnected for some time. Though I could not attend your this presentation part, but one thing I want to ask you: what is some I mean novelty is there in this? I mean, it's a very routine type of case what you had taken up.
Yes, ma'am.
And moreover, I would like to comment you here that the presentation part, I mean, the text part is not at all readable. Either you should have eliminated it and enlarged your photographs, or it should be in a point-wise manner. At least somebody could see anything. Rest apart, I think it's fine. We should move to the next.
Ma'am, can I start? Good morning, ma'am. Can I start?
Yes, please.
Good morning. I'm Priyanka. Today I'm presenting a case report on orthoperio approach, a ray of hope for adult patient with a 1.5 years of follow-up. Coming to the introduction, traditionally adult patients secondary to periodontal deterioration and pathological migration of teeth were denied orthodontic treatment and undergone extraction for the same, leading to anesthetic appearance and loss of function. With the advancement in technology and integrated approach of orthodontists and periodontists with a combination of new regenerative materials like PRF, we can achieve a ray of hope for such adult patients concerned with aesthetics and seek orthodontic treatment. Coming to the case report, a 33 years old female patient reported to the Department of Periodontology with a chief complaint of forwardly placed teeth and swollen gums in her upper front teeth region since 3 months. On examination, there we could see pathologically migrated 1-1 and 2-1. Trauma from occlusion was present, and grade 1 mobility was seen in relation to 1-1 to 1-3 region and 2-1 to 2-3 region. There was a generalized spacing and increased overbite was noted. Hence, with the integrated approach with the orthodontic consultation, a treatment plan for this patient was devised. The sequence of events include SRP was done, and then the patient was put in periodontal maintenance phase. And after 3 to 4 months of patient cooperation and patient motivation, we could achieve the patient to have a good oral hygiene practice, and hence we further started the treatment for this patient, where there was an orthodontic intervention where the orthodontist has placed the wires and braces, and then in periodontology we have done the surgical intervention where we could see that there was a gingival overgrowth palatally in relation to the upper anteriors. So we excised the gingival overgrowth by using electrocautery, and then patient was recalled after 2 weeks for further evaluation. We can see the pre-probing depth of
more than 6 mm in this patient, and hence we did a surgical intervention where the flap was reflected and open flap debridement was done, and we choose PRF for the regenerative material here, and the PRF was placed in the horizontal bony defects, and the sutures were placed and the periopac was placed. We can see the preoperative IOPR here, where we can see bone resorption, and this is the 1 year post-operative IOPR where we could see bone regeneration. So I would like, and also the post-operative probing depth have been considerably reduced to 2 to 3 mm. So we could conclude by saying that periodontally compromised patients, I would like to conclude by saying that patients, periodontally compromised orthodontic patients, can be satisfactorily treated, achieving correction of malocclusion and marked improvement in aesthetics when using integrated ortho-perio approach, emphasizing on patient motivation, education, and a strict maintenance period.
Dr. Priyanka, the orthodontic treatment was initiated before the periodontal treatment here?
No, ma'am. First, we have done a non-surgical phase where SRP was done and oral hygiene instructions was reinstituted in the patient. We waited for 2 to 3 months, and then we have consulted the orthodontist, and we started with the orthodontic. Since the patient has trauma from occlusion, we first did occlusal therapy to relieve the trauma from occlusion, and hence orthodontic treatment was suggested in this patient.
The pre-op pocket depth was how much?
It was up to 6 mm, ma'am. 6 to 7 mm. After the pre-op probing depth was after scaling and root planing. When we measured, it was up to 6 to 7 mm.
7 mm.
6 to 7 mm, ma'am. Yes.
6 to 7 mm. Okay. Okay.
Dr. Priyanka?
Yes, ma'am.
In what all periodontal condition you can give adjunctive orthodontic therapy?
In cases like in such cases, in adult patients where there is adequate bone support, and in pathologically migrated teeth, we can give adjunctive orthodontic treatment.
No, there are certain periodontal conditions, no, in which you can give adjunct orthodontic treatment, and the ortho treatment is beneficial, especially when you're discussing about the adult orthodontics.
Yes, ma'am.
So tell me those conditions.
I cannot.
Is this your case?
Ma'am?
Is this your case you have done?
No, ma'am. This is my senior's case.
Okay.
Yes, ma'am.
Fine. Thank you.
Thank you, ma'am.
Good morning, ma'am. Can I present? Am I audible?
Yes, sir, you are audible.
Thank you. Okay. Good morning, respected moderators, conference coordinators, and my dear friends. I'm here to present my poster where I have compared the results of using IPRF and PRF in combination with alloplastic bone graft material for the treatment of grade 3 furcation in a split mouth study manner. So as we all know, furcation is an area of complex anatomic morphology that may be difficult or impossible to be debrided by routine periodontal instrumentation, as said by Carranza. And the treatment of furcation is still a dilemma, even when we have a wide range of regenerative options in the present advanced clinical scenario. But as periodontists, we are trained to maintain and restore the function, aesthetics, and phonetics for the promotion of oral health. So different treatment modalities are advocated for the treatment of furcation involvement, including the non-surgical maintenance, resective treatments, and regenerative treatments. but there is no clinical standard way of managing it. So the use of PRF has seen a steady increase in popularity since it was first introduced in medicine for the treatment of hard to heal leg ulcers. PRP was the first generation which was used, and PRF was developed, which is the second generation, which was described by Chaukaran. And the most recent development on the field of PRF include the injectable PRF or IPRF, as it's commonly known, where the low centrifugation concept has been used. So in this study, I have compared the treatment outcomes of a grade 3 furcation using a mixture of alloplastic bone graft with PRF at one side and alloplastic bone graft with IPRF on the another side in a split mouth manner in the same patient. So a 35-year-old male patient reported to the dental clinic named Nagesh. He had pain in the lower right and left back teeth since 2 months. Patient was systemically healthy and was a non-smoker. And his dental history revealed that it was his first dental visit. So he had a grade 3 furcation on 4-6 on the right side, and on 3-7. On 4-6, I placed IPRF with bone graft, and on 3-7, I placed a PRF with alloplastic bone graft after the initial therapy and the flap was raised, and the PRF and the bone graft was placed. A little bit of furcation plasty was also performed. The PRF was prepared with a protocol of 2700 RPMs for 10 minutes, and IPRF was prepared in 700 RPM for 3 minutes. Surgery was done on 2 different days with a gap of 7 days. So it was suggested that before that combination treatment including bone graft and GTR would provide the most beneficial regenerative therapy for class 2 furcations. But however, the results obtained in controlled clinical studies demonstrated that the use of bone graft together with barrier membrane was of limited significance. Therefore, the use of replacement graft to improve the result of guided tissue regeneration was not clearly justified. So studies have demonstrated that applications of biomaterials in combination with the bone graft substitutes were found to be effective treatment modality in the management of intrabony defects and grade 2 furcation defects, exhibiting improvement in the clinical parameter and bone fill. So platelets are an important in initiation of wound healing by releasing of growth factors. That's the main advantage of PRF is the fact that it produces without any use of anticoagulants or other unnatural byproducts, because PRP used anticoagulants for this, and it was a time-taking procedure. So PRF gained acceptance very fast, and it also has the angiogenic properties are there. The neutrophils are trapped within it, which will give a phagocytic properties, all these to the PRF. And when we reduce the centrifugation force like in the manufacture of IPRF, the blood is separated into a yellow-orange upper phase and a red lower phase, and it has shown a better release of growth factors when compared to other autologous blood products. So in this study also, I concluded that where the most severely affected was 4-6, but still there was more gain in where I used IPRF. There was more vertical gain when I used IPRF than when I used PRF with the bone graft. Thank you, ma'am.
How did you use IPRF?
Ma'am, IPRF, ma'am, it is a injectable liquid-like form, ma'am. So it has a property of good bonding characteristics with the bone graft. So when we place the bone graft in the grate, that it forms a thick this thing, ma'am. So it is easily packable and it is more easily it will be maintained in that area. So IPRF, I mixed it with the bone graft and placed.
Which bone graft?
Ma'am, Cybograft. It is alloplastic Cybograft was used, ma'am. And the other area I parted with the graft and placed the PRF membrane on the contralateral side.
What is the difference between IPRF plus and IPRF? You have written in your conclusion in the site where IPRF plus alloplast bone graft and then IPRF. What is the difference?
Ma'am, IPRF and PRF is used, ma'am.
No, in the second line of your conclusion you have written was...
Ma'am, it is IPRF plus alloplast bone graft. Both together is what I meant, ma'am. Sorry. Ma'am, IPRF and bone graft was used. That was the meaning of that plus.
Okay. Otherwise, what do you mean by IPRF plus?
No.
There's also a platelet concentrate with IPRF plus also. Okay.
Okay.
What is IPRF plus?
Ma'am, where the centrifugation is reduced again from 700, ma'am. Ma'am, in here I have used only IPRF, ma'am. It is IPRF and the bone graft is what I meant by the plus. Sorry about that.
Do you know any other formulations like you have used IPRF over here? Otherwise, there are available LPRF and APRFs
Yes, ma'am.
also. What is the
Ma'am,
difference?
Ma'am, there are different formulations, ma'am. It is mainly it's based on the centrifugation, ma'am. So for the preparation of IPRF itself, many authors have given different centrifugation concepts, ma'am. This is, I took the reference from Miron et al. And he has used the 700 RPM. Ma'am, and this APRF is again a low, ma'am, PRF is a usual centrifugation, but when we come into low centrifugation, what they say is that since the centrifugation force is less, the platelets doesn't go hit onto the test tubes much. The hitting of the of the platelets onto the test tube is less. Therefore, they don't rupture and it's not damaged completely. That is why this low centrifugation concept has gained acceptance. There is more better release.
Yes, fine. Thank you.
Thank you.
Shall I start, ma'am?
Yes, please.
Very good morning to all. Today I'm going to present poster on non-surgical management of the aggressive periodontitis. So aggressive periodontitis, as the name implies, it is a disease in which there is extensive and rapid destruction of the alveolar bone, which occur in the systemically healthy patients and in the younger age group, but the patient may be older. So it was earlier called as in 1923 diffuse atrophy of alveolar bone, and later on several terminologies were there, and it was called as aggressive periodontitis in 1999. So a patient, 24-year-old male patient, presented with the chief complaint of swollen gums and mobility of the teeth, and there was intermittent episodes of pus discharge in the mandibular first molar region on the left side. There was no relevant medical history, and there was no history of previous dental treatment. The family history with the same complaint of mobility of the teeth was there. On extraoral examination, there was no abnormality detected, and on intraoral examination, plaque calculus was present. There was on gingival examination, a reddish soft and edematous gingiva was present. Signs of inflammation were present, and the on the periodontal, on the charting of the periodontium, the probing depths were present, generalized 5 to 6 mm, whereas the probing depths were more in the molar and incisor region. Dental caries were present, and swelling was there in relation to 3-6, and OPG revealed severe bone loss. And the treatment on the first appointment, scaling. So supragingival scaling was performed. Patient was motivated to maintain the proper hygiene of the oral hygiene, and chlorhexidine mouthwash was prescribed. After 2 weeks, subgingival scaling plus root planing was performed. On the first appointment, antibiotics were also prescribed, and on the second appointment after 2 weeks, subgingival scaling plus root planing was performed, and the signs of inflammation were reduced. Bleeding on probing was reduced. After 3 weeks, on the recall appointment, bleeding on probing was negligible, and probing depth was reduced. And on that third visit, extraction of in relation to 3-6 was done because it was grade 3 mobile, and root canal treatments were also done. The teeth which were requiring the treatment. The patient.
Vanna, do you have the term aggressive periodontitis in recent classification?
No, ma'am. In recent classification, there is term aggressive periodontitis is not there.
Term which is not there? Aggressive periodontitis is not there. Why is it not there?
Sorry, ma'am, can you repeat?
I'm asking why the term aggressive periodontitis has been removed from the recent classification, the 2017 classification.
Ma'am, because it was like for the generalized, because it depends on the age of onset and the aggressive. It means the because it like
Okay, you were talking about the non-surgical management. So how did you manage the bone loss?
Ma'am, the patient is still in the recall phase and the probing depth were reduced just 1 to 2 mm. So now if the probing depths are, it will be remaining same, then further on we can plan for surgical treatment because it's still in the recall phase.
Vandana, how did you reach to the diagnosis of aggressive periodontitis in this case?
Ma'am, there was, first of all, patient's age was 24 years and the more probing depths were there in the molar and incisor region as compared to premolar region, and there was family history. The patient presented with the same blood relation, like patient's...
Who was in the family affected?
Ma'am, patient's brother, he said that his elder brother presented the same chief complaint of the mobility.
But as far as I can see, there is abundant amount of local factors are also present over here. Though this is not a strict, contraindication for the diagnosis, but there are a lot of local factors also present. And what prompted you to restrict your treatment just to the non-surgical part?
Ma'am, initially I just tried to just look for that non-surgical part, and later on, if the probing depth will remain same, that is 6 to 7 mm, and if they won't be reduced, then we can further change the treatment plan.
Did you go in for a full mouth disinfection protocol in this patient?
Yes, ma'am.
How did you perform it?
Within the 24-hour period, I mean, during the first appointment when supragingival scaling was performed, within on the same appointment, patient was rinsed, advised rinse to.
But it is not mentioned anywhere over here in your treatment part. Anyways, thank you.
Yes, ma'am.
Thank you.
Thank you.
Am I audible, ma'am?
Yes, please.
Okay. Good morning, respected ma'am. I'm presenting a case report on a tongue tie. Starting with the introduction, that what is tongue tie? The tongue tie is also known as ankylosing, is a congenital disorder characterized by the short, thin frenulum, which affects the protrusion and the elevation of the tongue. The case report is highlights on the examination and to enable the comparison between the future observational as well as an interventional studies. 14-year-old male patient reported to Department of Periodontics and Implantology at Ahmedabad Dental College and Hospital with the chief complaint of short crown length with excessive appearance of the gingiva with the ongoing orthodontic treatment, and after the clinical examination, the ankylosing with the restricted tongue movements were also observed. Starting with we can see in the figure 1 the preoperative view. The patient was undertaken under local anesthesia with a procedure of the pre-suturing surgical technique in which the scalpel method, the hemostat was, first of all, the suture was inserted at the tip of the tongue, and then after the hemostat was inserted at the bottom of the lingual frenum at the depth of the vestibule and giving the 2 incisions at the superior and inferior aspect, removing the intervening frenum. So with the help of the hemostat, release the muscle fibers to achieve the good tension pin closure of the wound edges, and after which the wound edges were approximated with the 4-0 black threaded silk sutures. After the immediate procedure, the amoxicillin twice a day for the 3 days, and the non-steroidal anti-inflammatory drug, a tablet Kitro Ketorolac TT twice a day for 3 days were prescribed to prevent the post-operative infection and the pain. The sutures were removed after the 1 week, which showed the no scar tissue formation. And after the follow-up, the 3 months, the tongue showed a good healing, occlusion of the several as well as the beyond the lower lip and normal speech. So I conclude this case report by saying that the surgical intervention is an effective way to treat the ankylosing and also improving the limitation of the tongue protrusion, elevation, and other speech problems. Thank you.
What was the chief complaint of this patient?
The chief complaint of the patient was the patient has came from the Department of Orthodontics with the excessive gingival appearance. So he was going under the crown landing procedures, but while diagnosis, we diagnosed the case of ankylosing in it.
Otherwise, the patient didn't have any problems in speech, in swallowing or something?
The patient has a minimal problem of speech, but he haven't not been noticed since then. He noticed, like we asked the patient that what are the problems you are acquiring since before the orthodontic treatment or after during it. So then he said that he has some speech problems with certain words.
What is the normal time of intervention, surgical intervention in patients with tongue tie who are born with tongue tie?
What is the treatment? What is the time for the treatment procedure?
Yes. When do you do surgical intervention?
Like after 12 years, we can go for it.
Why after 12 years? If a person is born with tongue tie, he will have problem with swallowing.
Yes.
Right?
Then, sorry, I couldn't get your question.
When a person is born with tongue tie, when do you attempt the surgical intervention?
Then after, sorry ma'am, I didn't know the answer for this.
Okay.
Dr. Zalek, how did you classify the tongue tie in this case?
By Kotlow's classification, it is assessment of Kotlow's law in 1999. In this case, it was moderate between 9 to 10 mm. And he classified it into the 4 types. The class 1 is a mild, which is 12 to 16 mm.
What is this class type?
This is moderate one, 9 to 10 mm.
9 to 10 mm means?
It is moderate tongue tie.
Into 10 mm indicates what?
It indicates the moderate one.
Okay, fine. Thank you.
Okay, thank you, ma'am.
Good morning, ma'am. Ma'am, am I audible to you, ma'am?
Yes, madam, you can start.
Yes, ma'am. Thank you. Good morning. Today, my topic for poster presentation is hereditary gingival fibromatosis, a case report. So this is a common clinically evident form of gingival disease of genetic origin, and it is known as also known as elephantiasis gingivae or diffuse fibroma. So in my case, it was a 16-year-old female patient who had reported to the department with a chief complaint of increase in the size of gums since birth, and the size had increased gradually since the past 10 years, and it was not associated with any pain. However, she had complained of unaesthetic appearance and also difficulty during mastication. The medical history was non-contributory, and the family history revealed a genetic predisposition. Her father and her sister also had the same condition. And on intraoral examination, there was generalized enlargement of the gingiva in both the arches, and it was pale pink and it was fibrous. There were generalized pseudo pockets present, and routine blood investigation did not show any significant findings. But on the basis of the clinical and the family history, provisional diagnosis of our hereditary gingival fibromatosis was made. Then for the surgical technique, after the administration of LA, gingivectomy procedure was carried out to excise enlarged
enlarged gingival tissue, and the sample was sent for histopath analysis. And after the analysis, it showed elongated test tube shaped rete-ridges in the epithelium and also large areas of fibrosis with dense collagen fibers in the connective tissue. And all these findings were suggestive of the condition. Now, coming to the discussion, the inheritance condition in which the gingival tissue spontaneously and progressively enlarges is called hereditary gingival fibromatosis. It is more intense during the eruption of both primary and permanent teeth, and it also develops as an activation of resident fibroblasts phenotypically characterized by increased proliferation, low level of MMP synthesis, and abnormally high collagen production. Also, an influence of sex hormones have been suggested as the testosterone induces interleukin-6 production and contributes to the development of the condition. And since the patient is 16 years old and she was prescribed with vitamin C supplements along with periodic monitoring, and the recurrence is minimal if oral hygiene is maintained, and majority of the condition regresses during adulthood. Thank you.
Did you formulate any differential diagnosis?
Actually, what in the literature, what they're saying is that during histopath analysis, the differential diagnosis of peripheral ossifying fibroma is made because of the presence of the calculi in the connective tissue.
What is the incidence of this condition?
Ma'am, phenotypically it is 1:1,75,000 and incidence is 1:1,35,000, ma'am.
Otherwise, this condition, hereditary gingival fibromatosis, is it associated with any syndrome?
Yes, ma'am. The autosomal dominant variant is not associated with any syndrome, as in this case, but an autosomal recessive condition is associated with syndromes, and it is also associated with trichosis and other syndromes. And also, in
is
some
not
cases,
the syndrome; it is a part of the syndrome. Anyways, how do you know it is an autosomal dominant over here?
Ma'am, if there are no syndromes present, and then if the parents or family is an obvious has an obvious disease, then it is an autosomal dominant variant.
Fine. Next, please.
Thank you.
Am I audible, ma'am?
Yes.
Yes. Okay. Shall I begin? Okay.
Yes,
good morning, ma'am.
Yes.
Smile is a non-verbal method of communication that requires the harmonious interaction between the lip gingiva and the lips. So attaining a perfect smile has become a major goal for many people of this era. So a hyperpigmented gummy smile can often be debilitating for some patients and it compromises their self-confidence. So I'm here to present a case of hyperpigmented gummy smile that was done during this pandemic a few months ago. A 29-year-old female patient came to our clinic with a complaint of hyperpigmented gummy smile. On evaluation, we assessed the hyperpigmentation with Dummett's oral pigmentation index and her smile line was assessed. We could conclude that a short hyperactive upper lip and a less amount of vertical maxillary excess were the main etiologies. As since she was a soon bride to be and she refused to undergo most invasive orthodontic procedures, her choice of therapy was concluded to a laser-assisted depigmentation and lip repositioning with myotomy. This technique was introduced by Dr. Rubinstein and Dr. Kostyuanisky in 1973. As we begin, we explained all the possible outcomes and complications associated with the surgery and obtained an informed consent from her. A two-stage procedure was performed. Started with lip repositioning. A local anesthetic solution was administered into the vestibule from 1/6 to 2/6. And as seen in picture 3, upper and lower incision lines were marked using a 980 nanometer diode laser, and this serves as a path of incision and prevented massive bleeding. As seen in picture 4, incision was made using a number 15 BP blade, and an elliptical band of tissue was removed from the upper labial mucosa as seen in picture 5. As picture 6 depicts the simple interrupted sutures that was placed to approximate the tissue. Post-operative instructions and a course of antibiotics were prescribed to her. When she was reviewed on the 8th day, as seen in picture 8, a satisfactory healing was observed. Following suture removal, she underwent laser-assisted depigmentation procedure using 980 nanometer diode laser at 2 watts, and vitamin E was applied over the area. When she was reviewed after 1 month, as seen in picture 9, a pale pink gingiva with minimal scarring at the suture line and a reduction in gingival visibility was the fortunate outcome of our treatment. And the following photographs at baseline and at review at 1 week and 1 month can appreciate the visible changes in her smile. As I conclude, I would like to comment that this technique is an easy, least invasive, cost-effective, and that requires no hospitalization and longer treatment period, and can offer an excellent alternative to other procedures with higher morbidity rate. So in this case, we could provide the functional and aesthetic parameters that is required by the patient. And a patient's bright and confident smile is our prime and pride. So it brings great contentment for the clinician too. Thank you.
Dr. Shruti, what was the cause of gummy smile?
Ma'am, in this case, it was a short upper lip, and which was hyperactive, and an amount of vertical maxillary excess was also present, ma'am.
How do you decide which treatment you will go in for which cause of gummy smile?
If it was in case of a passive eruption, we could have gone for a crown lengthening procedure. But then she had already underwent crown lengthening 1 year ago from another clinic, and she was quite dissatisfied with the treatment. And since the crown length was adequate, which was not very short, so that we had the only option that was lip repositioning. And for orthognathic surgery, she was quite apprehensive, and she was soon bride to be also. So she needed an immediate treatment, the immediate outcome.
What I can see in pictures is short squat crowns. Probably along with depigmentation, a little of gingivoplasty would have given better results.
Okay, ma'am.
Any associated complication in your case?
No, ma'am. She was absolutely normal, and she reported when she came for 1 week, she reported a mild swelling of upper lip and over the cheek region. That's all, ma'am. She was quite comfortable after the treatment.
Do you have a long-time follow-up? Do you have a long-time follow-up for this patient?
Ma'am, this was done during this pandemic period, and then in February, we could call her only once, and after that, our college got closed because of this COVID
what
issue.
is your take? What is your take on that? That is the condition. Can this also get relapsed?
It can get relapsed,
Is
but
the relapse possible in this case?
In this case, it is usually seen in case of excess vertical vertical maxillary excess, ma'am. So in this case, since that was the main issue, I am not expecting such a relapse in this case.
But there are high chances of relapse in such cases.
Yes, ma'am.
As far as I have read, you need a long-term follow-up to.
Yeah, ma'am. Because of this COVID issues, we couldn't call her to the clinic.
Thank you, Dr. Shruti. Next, please.
Thank you, ma'am.
Yes, Dr. Sai, please begin.
Yes, ma'am. Good morning, respected judges and my dear colleagues. The topic of my poster presentation is the evaluation of injectable platelet-rich fibrin as a non-surgical alternative in the treatment of aesthetic root coverage with a thin gingival phenotype. So a 28-year-old healthy female patient has reported to the Department of Periodontology with a chief complaint of an aesthetic concern of receded gums in the upper front region. So on detailed examination, it was noted that she presented with Miller's class 1 gingival recession involving the upper central incisors with the thin gingival. Though there are various surgical approaches that can be done in such a case, the patients nowadays are more cooperative towards a less painful and a minimally invasive non-surgical approach. So I have looked towards the platelet concentrates. So the platelet concentrates have been used in dentistry for over 3 decades because of their potent regenerative capacity. So in this case, I have decided to use injectable PRF. So first, the patient was given a topical local anesthesia, and after which the baseline clinical parameters were recorded. And after that, 10 ml of the venous blood was collected from the patient, and it was divided into 2 separate injectable PRF tubes, and then it was centrifuged at 700 rpm for 3 minutes, and the upper liquid layer which was collected is called the injectable PRF. So this injectable PRF was injected 3 times with the help of a 30 gauge disposable insulin needle with an interval of 1 month between each injection, and this injection was given at 5 points, one in the mesopapilla papilla, in the distal papilla, and in the mid buccal, distobuccal, and the mesobuccal points. And the patient has been recalled after 6 months, and after 6 months we could see a stable result with an increase in the gingival thickness of more than 1 mm, and also about 1 mm decrease in the recession depth. So it can safely be concluded that injectable PRF can be used as a minimally invasive and a non-surgical alternative, and can be beneficial in the increase of the gingival thickness, and also could play a role in the aesthetic root coverage cases. Thank you.
Dr. Sai, the protocol of injecting 3 times for 3 months with an interval of 1 month each, it is taken from this reference which has been put up in the slide?
Yes, ma'am.
Okay. So, in any kind of oral hygiene instruction maintenance during this time?
Ma'am, first when the patient came, I have done the first round of scaling and root planing, ma'am. And after the injection, I told the patient not to brush there for 1 day. And after that, there has not been any instruction given.
Okay.
How was IPRF retained there after injecting?
Ma'am, because the local anesthesia which I have given is a topical anesthesia, ma'am, because I did not want to, if I could give an infiltration there, the blood vessels will get constricted. So I have given a topical anesthesia, and after injecting, I just applied with the hand pressure. I just press that region for the rapid absorption there, ma'am.
Absorption where? IPRF gets absorbed.
Ma'am, like it will get spread in the gingival tissue, ma'am.
Which gauge needle did you use for injecting IPRF?
Ma'am, I have used 30.5 gauge.
Yes, please.
Fine. Though this is a new thing, but the improvement seen is very minimal kind of.
Yes, ma'am. Yes, ma'am. Ma'am, what I have observed, it was more. There was an improvement in the thickness of the gingiva more than the root coverage.
Actually, it is an isolated case, no?
Yes, ma'am.
So we can't really comment.
Yes, ma'am.
Thank you so much.
Thank you, ma'am.
this was the last presentation for session 1.
Thank you.
So thanks to all the presenters and both the chairpersons for chairing this session. After this session, we would begin with the next session for poster presentation. We would like to welcome both the chairpersons, Dr. Mansi Bansal ma'am and Dr. Jyoti Gupta ma'am, for chairing this session. Thank you.
Thank you.
Am I audible, ma'am?
Yes.
Shall I start, ma'am?
Yes, please.
Good morning, everybody. Partial extraction therapy is gaining popularity among the clinicians around the world. So, these partial extraction therapy are a group of procedures where a part of the root or a part of the teeth is retained inside the socket so as to prevent the alveolar bone resorption and then to preserve the bundle bone. This is a socket shield technique where the part of root is left attached to the labial bone, which helps in maintenance of labial bone and soft tissue architecture. This case report shows a 23-year-old male patient with broken maxillary right incisor who came for replacement of the incisor and also the laterals. So after assessing clinically and radiographically, the teeth was firm with no mobility, and then IOPA also showed no periapical lesion. So we plan for socket shield technique along with immediate implant placement. So the first photo shows the preoperative image showing Ellis class 3 fracture in 1-1. After giving under LA, first the sectioning of the root was done with long shank carbide drill, followed by the palatal split was atraumatically extracted using the periotom. Next, the contouring of the labial shield was done, and the width of the labial shield was retained up to 1.5 to 2 mm, and the height of the buccal shield was also reduced to alveolar crest level. Next, the osteotomy site was prepared on the palatal aspect of the bone, and then the implant of size 3.3 into 16 mm was placed with the optimum gap of 1.5 mm from the shield. Then interrupted sutures were placed. After 4 months, after evaluating the IOPA, again surgical re-entry was done and the healing cap was placed and led to the formation of gingival collar. After the gingival collar has been formed, we have fabricated the customized metallic abutment, and then the final cement retain prosthesis was given in relation to 1-1-1-2 and then 2-1 and 2-2. This picture shows the extraoral post-operative extraoral picture of the patient. And so to conclude, this socket shield technique along with immediate implant placement would be a good alternative to preserve buccal cortical bone and also soft tissue healing, especially in the aesthetic areas.
Dr. Reshma, can you classify the socket shield techniques?
We also have root membrane technique here, where the implant is placed in contact with the tooth apex, the shield apex.
There are various other techniques, no, for socket shielding.
Proximal shield, we have C-shaped shields.
Yes. What else? Okay.
Okay. Fine, Dr. Reshma.
Okay, ma'am.
Thank you.
Thank you.
Ma'am, shall I start? Am I audible?
Yes, you are audible.
Ma'am, I'll start, ma'am. Diagnosis is not the end, but a beginning of the practice. Good morning, respected panel members. Today, I'll be presenting a case report on osteomyelitis, an unforeseen complication of COVID-19. A 40-year-old patient reported to the Department of Periodontics with a chief complaint of pus discharge from the lower front tooth region since 1 month. His past medical history revealed that he was tested COVID positive on 1st November 2020 and was treated with dexamethasone steroid therapy. On routine investigations, after recovering from COVID-19, he was confirmed diabetic with HbA1c percentage of 15.1. No significant clinical manifestations were present extraorally. However, intraoral findings revealed generalized class 1 Miller's recession with class 3 Miller's recession in relation to 3.2 and 3.3, exposed non-vital buccal cortical plate with pus discharge in relation to 3.2 and 3.3, grade 1 mobility in relation to 3.1, 4.1, 4.2, 4.3, and grade 2 mobility in relation to 3.2 and 3.3. Absence of bleeding point upon drilling a hole in the exposed buccal cortical plate confirmed the non-vitality of the alveolar bone. A provisional diagnosis of localized chronic suppurative osteomyelitis was made with a differential diagnosis of periodontal abscess, mucormycosis, and acute necrotizing ulcerative periodontitis. This diagnosis was further confirmed with the help of histopathological reports, which revealed absence of osteoblasts and osteocytes, and the CT scan showed foci of sclerotic bone suggestive of osteomyelitis. Furthermore, the pus culture reported 99% probability of E. coli. Based on this, the patient was initially treated with empirical antibiotic therapy, followed by extraction of 3.1, 3.2, 3.3, and sequestrectomy done under local anesthesia. The antibiotic therapy was modified to 500 milligram of IV injection of amikacin BID for 5 days. Finally, sequestrectomy with decortication was done under LA. With this, I would like to conclude by emphasizing on the fact that a combination of diabetes, one-size-fits-all approach of steroid use, and COVID-19 has caused an upsurge in deadly opportunistic infections among the patients, and which can be effectively treated by prompt diagnosis, quick surgical intervention, and regular follow-up. Thank you.
Aishwarya. Dr. Aishwarya, what was your role as a periodontal surgeon for this case?
Ma'am, the patient initially reported directly to our clinic, ma'am. And in our department, when we saw the patient and he revealed to us that he was tested COVID positive, we seeing the clinical findings, seeing the pus discharge, we checked the non-vitality of the bone as I said, by drilling a hole in this buccal cortical plate and realized that it was an involucrum, basically a dead bone, and we only diagnosed it with the help of an oral maxillofacial surgeon as a provisional diagnosis of osteomyelitis, and immediately sent him for the for this extraction and sequestrectomy, which was also a smear layer of pus was also taken at that point only, which helped us give a very quick diagnosis of this patient, and the treatment could be initiated very quickly. So our role here was to prevent the spread of the disease, because if we would have lacked to correlate between the COVID situation, the treatment he was given during COVID and the treatment the diabetes, that he was not a known diabetic, ma'am. But after that, when he reported to our clinic, we sent him for a diabetic test where he was found to be having 15.1% HbA1c levels, and FBS and PPBS were also uncontrolled. So there,
that's okay. So your case is limited to the diagnosis part, which could be for any dental clinic to whosoever this patient may be reporting.
Yes, ma'am.
Right?
Yes, ma'am.
Dr. Mansi, please.
According to you, what was the cause of development of this osteomyelitis? Whether it was the steroid administration, whether it was post-COVID, whether it was diabetes, or
it was both diabetes and the steroid therapy, ma'am, because these are one of the two major risk factors, as I mentioned, predisposing conditions, which can lead to this infectious nidus in our jaw. But what I was thinking was that this is a mandibular jaw, moreover, so the more probability of osteomyelitis is there in mandible compared to maxilla. But here, diabetes and steroid have played the major role.
Do you have the post-treatment pictures as well?
I have put one, ma'am, where 3,6 to 4,6 have been removed and granulation tissue have been debrided, and the mental nerve was involved, so that has been severed. The buccal cortical plate and interdental bone have been removed, but the lingual cortical plate was intact, so that has been kept.
Thank you.
Thank you. Next,
Thank you, ma'am.
please.
Good morning, ma'am. Am I audible?
Yes, you are audible.
Okay. Good morning to all. My poster is on the topic autogenous bone graft as gold standard for management of grade 2 Furcal defect, a case report. So according to Glickman, a grade 2 furcation involvement is essentially a cul-de-sac with a definite horizontal component, and a grade 2 furcation involvement can be managed either by a regenerative or resective approach. So, while attempting regeneration, autogenous bone grafts are preferred as they possess most of the properties of an ideal bone graft material. But the disadvantage is the limited availability in case of intraoral sites. So this is a case report of a patient, 59-year-old male patient who was referred from the Department of Prosthodontics for management of furcation involving 3/6, which is to be used as abutment for replacement of missing 3/5. On clinical and radiographic examination, 3/6 was root canal treated and there was radiolucency involving the furcation of 3/6. And the probing depth on the mid-buccal region was 6 mm and distobuccal region was 4 mm in relation to 3/6. Based on these findings, the treatment plan was to manage the furcation involvement by regenerative approach with the edentulous 3/5 region as the donor site for harvesting the autogenous bone graft. So 4 weeks after the initial phase 1 therapy, a full thickness mucoperiosteal flap extending from the distal line angle of the 3/4 to 3/7 was reflected under local anesthesia, and a thorough debridement of the defect site was done. A trephine burr was used to harvest the block graft from the 3/5 region vertically downwards from the crestal region, and the obtained the bone graft was then milled using a bone mill, and the resultant particulate graft material was packed into the furcation of 3/6, and the donor site was packed with the synthetic bone graft material. So then both the donor site and the recipient site was covered with collagen membrane, and the full thickness mucoperiosteal flap was repositioned and suturing was done. Co-pack was placed and review was done after 1 week, 2 weeks, 1 month, and 3 months post-operatively. And after 3 months post-operatively, there was successful clinical closure of the defect as well as sufficient bone fill radiographically. So coming to the discussion, autogenous bone grafts with its osteoconductive and osteoinductive properties and being source of osteoprogenitor cells have the regenerative potential. So it can be concluded that, as evidenced previously, autogenous bone grafts yet again prove as gold standard material as a bone graft material, and edentulous areas can be used as a donor site for harvesting autogenous bone grafts for obtaining predictable results. Thank you.
Dr. Delsa, do you think 3 months is an appropriate time to assess?
Ma'am, radiographically, 3 to 4 months we can see the bone formation, ma'am.
And did you probe at, you said you took readings at 1 week, 2 weeks also, though?
Yes, ma'am.
So did you probe at that time?
No, ma'am.
When did you probe?
Probing was done after at the third month review, ma'am. I have included the picture. The 11th image shows the probing at 3 months post-operative.
Collagen membrane did you use?
Healy guide, ma'am.
You don't? Okay. Okay.
Dr. Delsa, there are other, no doubt, autogenous bone is the gold standard, but there are other materials also which could be easily used here. So why was your preference for the autogenous bone and creating a second surgical site?
Ma'am, second surgical site, actually, since the tooth was to be, the furcal defect has to be managed. So anyway, the site has to be exposed. So the edentulous site was
Site
adjacent
has to
to
be
the,
exposed, but okay. So that's
and
why you have.
also, ma'am, the bone grafts that is commercially available will be more expensive. So this could be a more cost-effective way. At the time, in addition to that, we were able to achieve a good result also, ma'am.
But you have again put in the bone graft synthetic material only in the socket created over there.
Yes, ma'am. But compared to the synthetic bone graft material, autogenous bone graft being osteogenic and having osteoconductive and osteoinductive property
No, it is
will
a
be.
gold standard, but thank you. Thank you.
Okay, thank you, ma'am.
Next, please.
Good morning, ma'am. Am I audible?
Yes, you are audible.
Good morning, everyone. Today I am presenting a case report on hope for hopeless multidisciplinary management is the same. So, a 54-year-old male with a history of tobacco quid placement presented with a chief complaint of feeling of cracked tooth in the lower left back tooth region and difficulty in chewing food since last 3 months. On clinical examination and on further radiographic investigations, that is the IOPR and CBCT, it was revealed that there was a grossly decayed tooth, that is 3-6, with vertical crown root fracture. Along with that, there was gingival recession in 3-4, 3-5, 3-6, and periapical radiolucency, along with external root resorption in 3-5. CBCT also revealed complete loss of buccal cortical plate in relation to 3-5 and 3-6, and close proximity of the mental nerve to the apex of 3-5. Based on all these findings, diagnosis was made of endoperio lesion in relation to 3-6 with vertical fracture, perioendo lesion with external root resorption in relation to 3-5, and gingival recession in 3-4, 3-5, and 3-6. Prior to the surgical procedure, oral hygiene instructions were given to the patient, scaling root planing, as well as root canal treatment in 3-5 and distal root of 3-6 was performed. For surgical procedure, we went ahead with hemisection and episectomy. So first, the removal of the fracture segment of 3-6 was done. Then on flap reflection, the mesial root of the molar was removed. Then following which episectomy of the premolar was done. Then bone grafting and suture placement was done. 7 days post-op, it reveals complete good healing, and 1 month and 6 months post-op revealed reduced tooth mobility, bone formation, and gradual elimination of the periapical pathology. Planned prosthesis was then placed, and 1 year follow-up showed fully functional teeth without any complication and full satisfaction of the patient. Thank you.
Dr. Snehi,
yes,
you said with relation to 3-5, it was a perioendo lesion.
Yes, ma'am.
How did you come to that diagnosis?
There was, on clinical examination, there was no carious lesion in relation to 3-5. Only there was gingival recession, as well as on the distal aspect of 3-5, there was deep pocket of around 7 to 8 mm. So we came to the diagnosis of that it is a true perio and secondary endo lesion. And also the tooth was non-vital on pulp testing.
Fine. That's okay.
Thank you.
Thank you.
Good morning, respected panelists. So today I'll be presenting a poster on the repositioning of an aberrant buccinator muscle, which is a case report. So mainly a buccinator muscle is a thin quadrilateral cutaneous muscle, which is derived from the second arch, and it forms a lateral wall of the oral cavity. And muscle attachments near the crest of the alveolar bone or near the marginal gingiva, it may mimic that of a high frenal attachment and thereby have various various difficulties such as in food causing food lodgement or inhibiting maintenance of oral hygiene. So the buccinator muscle, it is it has fibers arising from the alveolar process of the maxilla, the mandible, as well as the pterygomandibular raphe. So here in this case report, a 23-year-old female was referred to our department for the management of a partially edentulous mandible with a high muscle attachment, and the patient had a chief complaint of difficulty in chewing food because of the missing tooth associated with the same, and also there was food lodgement associated with the 3-6 region. On clinical examination, the patient had no medical history and there was no history of trauma or any infections. The patient exhibited no habits, and there was good oral hygiene as well as periodontal hygiene. And on examination, there was a high frenal-like band of soft tissue, which was observed onto the edentulous ridge. So initially, an impression was taken and a passive fit acrylic stent was constructed. And on surgical intervention, a crestal incision was made on the edentulous ridge, and this incision was then dissected down with the muscle, causing the muscle attachment to be dissected from the crest up to approximately 1 to 2 centimeters inferiorly. And this was then checked by repositioning of the by cheek retraction. And this surgical area was then secured with the help of the surgical stent, which was stabilized for 15 days. And post that, after 2 months, the patient was recalled and checked for the healing. And it was found to have an uneventful healing with the association with an adequate vestibular depth. And thus an implant procedure could be planned for the same, and thereby coming to a conclusion that the treatment of buccinator repositioning is a combination of frenectomy as well as vestibular extensions, and it helps to achieve proper alignment and symmetry of the buccinator muscle with minimum chances of recurrence, post-operative complications, and also resulting in excellent healing and prognosis. Thank you.
What are the other techniques for this buccinator muscle repositioning?
We can use laser surgeries, and it can be done by electrosurgeries, as well as we can give pregingival grafts, or we can also use an epithelialization technique.
What about Z-plasty?
Yes, ma'am, Z-plasty does come in the vestibuloplasty techniques.
Here you have done the vestibular extension also. I mean, incision is.
No, ma'am. Vestibuloplasty has not been done. It is just that the muscle was dissected and
acrylic stent was placed.
Yes, to prevent the muscles from to prevent the fibers from reattachment.
So it was a wound healing by secondary intention.
Yes, ma'am.
So how did you maintain the area for 15 days? I mean, what were the instructions to the patient?
The patient was asked not to brush in that area and to maintain the stent, especially at times of eating, and oral rinses was given. Mouthwash was given to the patient. Betadine mouthwash was given to the patient to maintain oral hygiene.
Okay. Thank you.
Okay. Thank you.
Am I audible, ma'am?
Yes, you are audible.
Good morning. My topic is on management of gingival hyperpigmentation using a diode laser. Gingival hyperpigmentation clinically presented as black gums, it can pose a major aesthetic problem in individuals, especially with a high smile and or a gummy smile. So this can not only affect the aesthetics of the individual, but can also have a psychological impact on them. So this leads to the increase in demand of the procedure of depigmentation of gingiva. So there are various techniques for depigmentation, such as scalpel, electrosurgery technique, use of diamond burst, cryosurgeries, and lasers. So comparatively, lasers offer minimal bleeding and offers a less patient post-operative discomfort, and also helps in rapid healing. So the case report here, a 24-year-old male patient presented to a department with chief complaint of black gums, and also he gave a history of smoking since 4 years, and have quit the habit since 2 months. So laser depigmentation was planned for this patient. So the initial phase therapy of scaling was performed, and later, after the application of the local anesthesia, the repigmentation was performed using a diode laser of 445 nanometer wavelength and 2-watt power, which is angled at 45 degrees external bevel, performing light sweeping brush strokes in a light contact mode with the tissues. And also during the procedure, protective eyewear were used by the patient as well as the operator. And then the blistered gingiva was scraped off with a saline moisture and gauze to remove the epithelium containing the pigmentation. And later the surgical site was protected with a non-eugenol based periodontal dressing. So the results, after 1 week, the patient was recalled, and healing was uneventful without any complications. And in the 3 months review, the gingiva appeared to be normal, pink, and healthy. And again, the patient was recalled around 6 months after the procedure. So here, repigmentation was observed, and the patient had revealed that he smoked rarely, around 1 to 2 cigarettes once in 2 weeks. So to conclude, diode lasers provide the longest term stability and has been recognized as an adjunctive approach in gingival depigmentation, offering more patient compliance and comfort. However, smoking may negatively affect the longevity of the gingival depigmentation. Thank you.
The picture which you have put up here is for 6 months follow-up?
Yes, ma'am.
Do you have a 3-month follow-up pic also? I mean, it is not shown over here. What was the result after 3 months?
3-month pigmentation was, repigmentation was not much observed, ma'am. But I don't have a picture.
Because that is the, result. This you are showing that this is after the, patient resumed smoking after the procedure.
Yes, ma'am. Yes,
so this is 6 months.
Yes, ma'am.
Okay. Dr. Mansi, please.
Dr. Aparna, do you think this patient was an ideal candidate to undergo depigmentation procedure?
Actually not, ma'am, because since smokers usually depigmentation is not very useful, but then the patient had when we were taken in history, he had said that he had quit the habit. So so we tried to speak to the patient and we motivated him, and then that's how we actually went to the procedure, ma'am. But then again, after 3 months, he didn't smoke, but then 6 months later, when he came back, he again gave a history of smoking occasionally.
When does depigmentation occur after you have done your depigmentation procedure?
Ma'am, it actually varies. According to Dummett, the chances of repigmentation occurs around 33 days after the procedure, and according to Jinwala et al., it can occur around 22 to 24 to 55 days after the procedure. So it varies.
Theories of repigmentation. Why did repigmentation occur? What are the various theories of repigmentation?
Ma'am, again, Jinwala et al. Has said that the residual melanocytes, which were not completely removed during the procedure, that could have been result in the
in your lateral incisor 1, 2, you have residual pigmentation, right? So you can see in 6 months post-operative picture also the maximum enamel pigmentation is present at that.
Yes, ma'am.
Okay, thank you.
Okay, thank you.
Good morning, teachers. Am I audible?
Yes, you are audible.
Good morning, everyone. Today, the topic for my case report or the poster presentation is lip repositioning and crown lengthening, a combination and emerging dentistry for smile designing. As we know that the smile is the most important feature of our facial expressions. So the new life begins with a confident smile, and a beautiful smile is a powerful thing. So going to the case report. a 23-year-old female under the treatment of an orthodontist was referred for the management of excessive gingival display. The orthodontist had diagnosed for maxillary vertical excess and recommended orthographic surgery, but the patient was unwilling. So the pre-operative measurements were taken and the diagnosis of incompetent lip with due to maxillary vertical excess with normal lip length was seen, leading to the excessive gingival display. So excessive gingival display, referred to as a gummy smile, can be a source of embarrassment for the subjects. In this case, as the during the pre-surgical measurements, the crown length ratio was also crown length width ratio was also not appropriate. So firstly, the gingivectomy was done to remove the excessive gingival display, and later on lip repositioning was done to reduce the deep vestibular depth, and combination of these are promising alternative treatment modalities in selected case for aesthetic rehabilitation. The objective of lip repositioning is to limit the retraction of elevator smile muscles, and lip repositioning results in shallow vestibule, restricting the muscle pull, thereby limiting the gingival display during smiling. So in this case, after the gingivectomy, the lip repositioning was done, and in the lip repositioning procedure, the width of the lining mucosa removed from the vestibular area is double the width of the gingival margin, which is exposed during the smiling. So according to that, after the removal of the partial thickness, taking the partial thickness incisions in the vestibular region, the lining mucosa was removed and the suturing was done. And so this surgical intervention by lip repositioning stands as another less invasive permanent means of treating a gummy smile. Thank you.
You are Ashima. Ashima,
Yes.
do you have a post-op?
Ma'am, actually on the right side of the poster are the preoperative pictures. At the below edge is the surgical intervention procedures, and then at the left end is the post-operative pictures. So there is the frontal view and the lateral view of the picture out there.
How much long-term follow-up do you have?
Ma'am, actually in the poster, the pictures are of only 15 days, but the follow-up was done till 1 year. So at 1 year, from the 15 days till 1 year, 1 mm of reduction was there. And after that, the stability was maintained.
Why haven't you put a long-term follow-up picture over here?
Ma'am, that was not actually clear, so that is why I couldn't put that one.
Dr. Mansi, please.
Okay, ma'am.
Okay. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Am I audible, ma'am? Shall I start?
Yes, please.
Good morning, respected judges, presenters and attendees. The topic of my poster presentation is the replacement of an anterior missing tooth with implant therapy using grid split technique, a case report. Now, as we all know, management of deficient buccopalatal bicortical width is a common challenge we face with respect to implant therapy. And one of the commonest techniques being used these days in the management of this challenge is the rib split technique. In the current case report, a piezoelectric unit was used to split the alveolar ridge crest as atraumatically as possible. As the patient's age was only 22 years, strong cortical integrity was expected. History of blunt trauma to the anterior maxilla required radiographic elimination of doubt of vertical cortical fracture. Although the clinical appearance showed a crestal concavity, cone beam computed tomography revealed an intact buccopalatal crestal cortical width of 4 mm and height up to the nasal floor of 18 mm. For the procedure, after the crestal incision and reflection of the mucoperiosteal flap, initial crestal split was made using the piezoelectric insert tips, cutting tips. Following the development of initial split to the depth of 5 mm, osteotomes were used to widen the labiopalatal width to about 6.5 to 7 mm to allow the implant placement. Conventional sequential drilling was then performed, and a 3.5 mm into 11.5 mm implant was torque wrenched into the created osteotomy site, and the flap was sutured back in place. After that, intraoral periapical radiograph was taken to confirm the implant parallelism. Thank you, ma'am.
What about the post-op follow-up?
Ma'am, actually, this is the recent case which I had done just before the lockdown. So, ma'am, follow-up pictures I couldn't have, ma'am.
What was the advantage of using piezo surgery?
Ma'am, piezoelectric unit is advantageous as, ma'am, it will not allow or it does not cut any soft tissues coming in contact with the tip, ma'am.
I couldn't get you. What soft tissues are coming in contact?
Ma'am, our reflected flaps, which if we don't manage them properly, and if the tip comes in contact with that, or
No, the conventional red split. I mean, what is the advantage of using piezoelectric handpiece over here as compared to the conventional red split, which we do with sequential, drilling?
Oh, ma'am, neurovascular bundles and everything won't be damaged with the piezoelectric unit, ma'am.
But that could be confirmed by CBCT as well. CBCT and other measurements will determine. Otherwise, also you place an implant.
Yes, ma'am.
Anything else, Dr. Mansi?
No. Okay.
What was the buccopalatal width over here in this case?
Ma'am, buccopalatal width in CBCT, it was 4 mm, ma'am.
4 mm. Okay. And it was taken up to 6 mm?
Ma'am, depth was 5 mm and expansion we did to 6.5 to 7 mm, ma'am.
Okay. Thank you.
Thank you, ma'am.
Good morning, ma'am.
Good morning.
Am I audible, ma'am?
Yeah.
Yeah. Today, my topic for presentation is socket preservation technique. It's been reported that after tooth extraction, there is a hard and soft tissue remodeling, which takes part as a normal physiologic process that occurs as a remodeling process in the alveolar bone. Scoopus et al. Reported that 50% of the bone reduction occurs in the first year of the post-extraction phases. So as a result, to preserve it, the bone augmentation procedure or any other procedure which can help in preserving the bundle bone and the cortical bone for a socket is being advised. In this poster presentation, there is a case being reported in our department. A 45-year male visited our visited the department with a chief complaint for the replacement of the missing teeth. On oral examination, it's been found that the tooth has been badly decayed and fractured. On CBCT examination, there has been completely visible the loss of palatal bone till the two-thirds of the middle third of the palatal bone is being lost has been noted. Upon atraumatic extraction, the socket has been thoroughly debrided, curated, and been cleaned with a normal saline. This patient is being advised for a socket preservation with the bone grafting material. The bone graft material which is being used here was a Minros, which has been an allograft, which has a property of 50% cancellous and 50% cortical bone, which would help in preserving the bone for a longer period of time. Barrier membrane, which is being used here, is a periocal membrane, which is a fish membrane. In later images, it's been shown it as these. Upon suturing, the horizontal mattress suture is being used for the stabilization of a membrane, and a vertical mattress, interrupted suture was used for the suture. Upon the completion, the flowable composite bandage was placed in order to correct that. So that since there was a more than 2 millimeter of the membrane exposure was found, so the flowable composite was placed in order to cover the membrane and to have a better secondary healing. Thank you, ma'am.
Dr. Abhijit, is this your own case?
Yes, ma'am.
Why have you decided to take a CBCT of this area? It's a, decayed tooth. Were you planning anything else for that?
Actually, ma'am, immediate implantation was supposed to be planned, but since the fragment, the palatal fragment was mobile, and the ability of having a larger periapical radiolucency. So, in order to confirm that, the CBCT was planned, ma'am.
Okay.
Which bone graft did you choose?
A Minros.
What was the advantage of choosing Minros?
It's an allograft and it contains 50% cortical and 50% cancellous bone, which has a property which would help in retaining the bone volume for a long time. Since it's a COVID duration, we prefer to have a delayed implantation in this case. So we need a bone volume which is to be maintained for a longer period of time till the further implantation was done at this site.
Did you take a post-operative CBCT as well to confirm the
No,
heart?
No, ma'am. Post-operative CBCT you have not recorded. But surely before placing the implant, we'll be taking that.
Thank you.
Okay.
Thank you.
Good morning, respected person. Today I'm going to present my case report on pemphigus vulgaris presenting as gingival enlargement, a rare case. Pemphigus vulgaris is a mucocutaneous blister forming fatal autoimmune disease.
Sir, can you be a bit little louder, please?
Pemphigus vulgaris is a mucocutaneous blister forming fatal autoimmune
You are not
disease.
audible, Dr. Abdul. Please adjust your mics.
Ma'am, now am I audible, ma'am?
Yes.
Be a bit loud, please.
Okay. Pemphigus vulgaris is a mucocutaneous blister forming fatal autoimmune disease. Oral lesions of pemphigus commonly present as vesicle formation. Gingiva presents as necrotizing and ulcerative gingivitis, though gingival enlargement in case of pemphigus is a rare finding. 60 to 80% of cases of oral lesions appears first, followed by skin lesions, and usually occur at the age of 40 or more. In this case report, a 30-year-old female patient reported with a chief complaint of difficulty in chewing food and swelling of the gums in upper and lower jaws since 1 to 2 months. The enlargement was mild 1 year back and gradually reached to the present condition. During intraoral examination, there were vesicle formation and gingiva was enlarged. Nikolsky sign showed positive reaction. After taking biopsy, histopathological report showed fibrinous exudate, acantholysis, and intraepithelial suprabasilar split, indicated of pemphigus vulgaris. A rare finding, that is gingival enlargement, was observed in this case. As chronic inflammatory cells infiltration increased in the connective tissue layer, In pemphigus vulgaris, formation of granulation tissue and fibrinous exudate that could be the one of the possible cause of the gingival enlargement in this case report. As there were skin lesions and patient was not taking any medication, the patient was referred to the skin specialist and the patient was prescribed with corticosteroid, which is prednisolone 50 milligram per day for first 2 weeks, followed by 100 milligram per day rest of the 3 weeks. Side by side, complete oral prophylaxis has been done and the patient was called after 3 months for gingivectomy. Conclusion: pemphigus vulgaris presenting as gingival enlargement has not been reported in the literature till date. Institution of early diagnosis and treatment could prevent serious involvement of the other mucosa and the fatal complications, though more studies required to support the same. As a periodontist, my role is to do a proper early diagnosis and referral in this kind of cases. Thank you.
Dr. Abdul, do you have any X-ray showing the status of the bone in this case?
Yes, ma'am, I have it. Should I show it now, ma'am?
Was there any associated bone loss?
No, ma'am, there were no bone loss, ma'am.
Okay, there was no bone loss. And the age of the patient is 30 years.
30, yes, ma'am.
Okay. And what was the status of oral hygiene of this patient?
Ma'am, good, ma'am. The oral hygiene status was good, ma'am.
Okay.
Did you formulate any differential diagnosis, Dr. Abdul, for the present case?
Ma'am, differential diagnosis could be, ma'am, other forms of pemphigus, ma'am, which is paraneoplastic pemphigus, or ma'am, phallicis pemphigus, or drug-induced pemphigus.
Is there any other striking feature of pemphigus vulgaris? Histological.
Yes, ma'am. There is a positive Zhang test, ma'am.
Yes. What is it?
Ma'am, it will show, it is kind of, ma'am, multinucleated giant cells formed at like, ma'am, they will accumulate and show, ma'am, Zhang's test positive, ma'am. The multinucleated giant cells, the fusion of multinucleated giant cells, ma'am.
Okay. So did you see it in your histological investigation?
Yes, ma'am. Yes.
You didn't mention in your poster.
Sorry, ma'am, I forgot to mention that.
Since you have initiated the gingivectomy procedure after the institution of the steroid treatment, did you see any change in the condition after the treatment had begun?
Ma'am,
in the gingival condition?
Ma'am, actually, we have called that patient after 3 months, and the patient has taken the medication for 2 months, ma'am. But there were no reduce in the gingival enlargement, so we performed gingivectomy, ma'am. But the vesicles, they got resolved when we performed gingivectomy.
Okay. Thank you.
Thank you, ma'am. Thank you, ma'am.
So with this, we come to end of this second session. We extend our vote of thanks to both the chairpersons, Dr. Mansi Bansal ma'am and Dr. Jyoti Gupta ma'am, for chairing the session. Thanks a lot, ma'am.
Thanks a lot, Sohani.
We'll reconvene after the break at 11 a.m. for the next session. Thank you, everyone.
We'll have given you a break for 5 to 7 minutes. Thank you so much.
As a coordinator, a big thank you for finishing in time.
Thanks a lot, Dr. GP. Thank you to all organizers. Thank you, Dr. Mansi.
Yeah.
Okay. Bye. Bye.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population, to create an awareness among the general public, and to create an impact as well as on the treatment line, and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as a President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi all, periodontal disease or pyria, as we all know, it is inflammation of the supporting structures of the teeth, that is the gum and the bone. Studies have shown that there is a lot of association found between the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there is a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from an adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be an underweight of the baby, which itself is a risk. So, how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So, let us make a motherhood safe with a healthy child and a safe mother. Thank you.
India happens to be the diabetic capital of the world.
India also has the largest population of hypertensive. Alongside, India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world, with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge, and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population, to create an awareness among the general public, and to create an impact as well as on the treatment line, and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy.
Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
So can we start?
Yes, please.
So beginning with the third session for the day, we welcome all the participants and the chairpersons to this platform of 19th ISP PG Convention in this poster presentation session. We have with us Dr. Shalini Kapoor ma'am and Dr. Gurprakash Singh Chahal sir as the chairpersons. Dr. Shalini Kapoor ma'am, she is working as a professor in Department of Periodontology, Faculty of Dental Sciences, SGT University. She is gold medalist from Himachal University. She has been awarded with honors in pharmacology, endodontics, and oral surgery. She has also done advanced course in implantology, certified by University of Michigan. She is presently pursuing PhD. Ma'am has various national and international publications to her credit. She has been guest speaker in various national and international conferences. We welcome you, ma'am. Second chairperson for the session is Dr. Gurprakash Singh Chahal, sir. Sir did his graduation from Baba Jaswant Singh Dental College, Ludhiana, and post-graduation from BRS Dental College and Hospital Barwala. He is presently working as assistant professor in Department of Periodontology at Dr. Harvansh Singh Judge Institute of Dental Sciences and Hospital, Punjab University. We extend our warm welcome to you, sir.
Thank you, Dr. Suhani, for the introduction.
Thank you, Dr. Sohani. Good morning, Shalini ma'am.
Good morning, sir. Good morning.
Shall we begin with the session?
Yes, sir, we can.
Dr. Anshul, you can start.
Jai Hind and a very good morning to everyone. My name is Dr. Anchal Tyagi, and the topic of my poster is Covering the Black Triangle with the Gold Standard, a Case Report. Beginning with the introduction. The ultimate goal in modern restorative dentistry is to achieve white and pink aesthetics in aesthetically important zones. An open gingival embrasure or a black triangle, or we can also call it as a black hole, occurs as a result of a deficiency of papilla beneath the contact point, which causes a complex aesthetic and functional problem to the patient. So, a 28 years old female patient reported in our department with a chief complaint of black triangle present between the front teeth, which was a big aesthetic concern for her. Proper examination and case history was recorded. For this case, we have used the classification which was introduced in the year 1998 by Norlin and Tarno. So we have classified it as class 1 because the interdental papilla was present between the contact point and CEJ, and CEJ was not clinically visible. So moving towards the treatment plan. In such cases, we can go for surgical as well as non-surgical treatment modalities. When we talk about the non-surgical one, we can go for scaling, root planing, curettage, or even we can go for conservative, orthodontic, or prosthodontic approaches. Being a periodontal surgeon, we have chosen the surgical therapy. So first, oral prophylaxis was done, followed with papilla reconstruction, which was performed using a pouch technique, which was introduced by Hang and Tekai in the year 1996 with subepithelial connective tissue graft. Now moving towards the case, these are the picture of the case, and here the first one is the preoperative view. Then a recipient site was created. To create a recipient site, a semilunar incision was given, followed with a clavicular incision so that a pouch is created, making sure that there is no tissue laceration or tear. Then the donor site was created in the palatal area so that the subepithelial connective tissue can be procured. After the procurement, this subepithelial connective tissue was placed inside the pouch which was created, making sure that it is placed coronally. Once it was done, then both the side, the recipient as well as the donor site was sutured. And this is the 3-month follow-up picture. Here we can easily appreciate the difference. Thus, to conclude, this case showed that the advanced papillary flap with subepithelial connective tissue graft can offer predictable results for reconstruction of interdental papilla. Thank you.
Dr. Anchal?
Yes, ma'am.
As this was a class 1 embrasure space closure, can you, being a periodontist, do you have some other better options instead of a CTG which can give you a promising result in this?
Ma'am, we can use dermofiller like hyaluronic acid in such cases. Even we can go for curettage.
So, why you did not opted for those things and why you directly went to CTG in class 1 embrasure space?
Because, ma'am, somehow it was near to CEJ, so it was it won't give a promising result if I would have chosen curettage. So I thought that better results will
And
be
what
obtained
about
after.
HA gels? Have you ever used hyaluronic acid gel?
Ma'am, I haven't used hyaluronic acid gel as such, but yes, I have seen surgeries where my batchmates and other people have used hyaluronic gel.
Okay, that could be a very good alternative to a surgery, especially in cases of class 1. According to Norland classification, class 1 embrasure, it's a very, very good alternative and it gives a very promising result. You usually attain class 1, class 2, you get 100% coverage in the black triangle area. Would have opted for that also. Yeah, otherwise, it is a good case.
Dr. Anchal, what are the other treatment modalities for black triangles, treating black triangles?
So we can go for so dermal filler. We can use dermal fillers also in such cases, and other techniques can be used. Like in 2009, whale tail technique was introduced. We can go for pedicle grafts.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
Can I start, ma'am?
Yes, you can start.
Good morning, everyone. I'll be presenting a case report, free gingival graft around mini implants to prevent mucogingival problems. Anchorage control is one of the most important keys for achievement of success in clinical orthodontics. Orthodontic anchorage devices such as mini implants and mini plates are often called temporary anchorage devices. Mini implants placed through non-keratinized gingiva can lead to inflammation of the surrounding soft tissue, which in turn result in coverage of mini implant pain and discomfort. Therefore, mini implants must be placed in the implanted in the range of keratinized gingiva or attached gingiva. The standard treatment protocol is to excise the excess tissue around the mini implant to promote the formation of attached mucosa around the device. In this case report, after the surgical excision of the soft tissue regrowth, free gingival graft have been harvested from the palate and placed around the mini implant to prevent the subsequent complications. Coming to discussion, these are the post-operative images at 1 month follow-up. Coming to discussion, gingival soft tissue thickness must be considered while choosing the most appropriate type of mini implant. Mini implant placed in the alveolar mucosa might be covered by soft tissue. Tissue inflammation and minor infection and peri-implantitis can occur following mini implant placement. Inflammation of the peri-implant soft tissue has been associated with 30% increase in the failure rate. Therefore, mini implants better be implanted in the range of attached gingiva or keratinized gingiva. Thank you.
Dr. Usha?
Ma'am.
You are in which year of post-graduation?
Second year, ma'am.
Second year. So can you tell me the difference between attached and keratinized gingiva?
Ma'am, attached gingiva is a part of keratinized gingiva, ma'am. The keratinized gingiva is from the free margin to the mucogingival junction, ma'am. Free gingival margin to mucogingival junction.
Which is more?
Ma'am?
Which is more? Attached?
Keratinized gingiva is tissue width is more, ma'am.
Okay.
Dr. Usha, what are the techniques to increase the width of attached gingiva?
Apical reposition flap and coronally advanced flap, sir.
Okay. And after how much time does the free gingival graft get integrated, as for example you have done in your case?
Sir, 1 month.
Thank you.
Thank you, sir. Thank you, ma'am.
Shall I start, ma'am?
Yes, you can start your presentation.
Good morning, everyone. I'm Dr. Asha. Today, I'm here to present my poster on topic pocket reduction with high concentrated oxygen gel. It's a case report. As we all know, oxygen is essential for cellular metabolism, also has a vital role in wound healing, bacterial defense, and also in collagen synthesis and angiogenesis. Periodontal disease is a multifactorial inflammatory in nature. The primary goal of periodontal therapy includes the removal of etiological factor by scaling and root draining. Since the putative periodontal pathogens are anaerobic in nature, so application of this high concentrated oxygen gel into the periodontal pocket can create an high concentrated environment which can be lethal to the gram-negative anaerobes. In the present case report, a 28 years female patient with a complaint of bleeding gums reported to the periodontics department. On clinical examination, there was a pocket depth of more than 5 mm without intrabony defect in relation to 3-1 and 4-1. Clinical parameters recorded are plaque index, gingival index, bleeding on probing, PPD, and relative attachment level. And following the SRP, oral hygiene instructions, there was an application of a Blue M gel for consecutive of 7 days, and we reassessed the pocket after 1 month. After the 1 month follow-up, there was a complete reduction, reduction in all the clinical parameters. So, in the conclusion, the high concentrated oxygen could be a promising agent for the reduction of the pocket depth adjacent to an SRP. Thank you.
Dr. Asha?
Yes, ma'am.
Can you please explain me the mechanism how this oxygen gel is working in the periodontal pocket?
Ma'am, this is a commercially available high concentrated oxygen name called Blue M gel, ma'am. And the components, active ingredients are that is active oxygen, which is a hydrogen peroxide, and it also contains sodium perborate, honey, xylitol, and also methyl salicylate, ma'am. On the application of this oxygen, the mechanism is to deliver the high concentrated oxygen, that is hydrogen peroxide, in a controlled manner. And at the low concentration of this hydrogen peroxide act as a disinfectant action and occurs together with an antibacterial reactive oxygen species. And during the respiratory burst of the neutrophils in the normal wound healing.
1 second, Dr. Asha, 1 second. How it is controlled? That is my question. How it is in a controlled manner it is releasing? Yeah. What is the mechanism behind it?
Ma'am, in the Blue M gel, they have mentioned like it has a controlled release of an oxygen. Release of oxygen will be controlled, ma'am, and concentration is about 0.003 to 0.001%. They have mentioned, ma'am, in this.
You have not answered my question. Okay, it's okay. Sir, you can ask your question.
Dr. Asha, what was the post-operative residual pocket depth? Not residual, just the pocket depth.
Sir, it was reduced to 4 mm, sir. It was more than 5 mm. It was reduced to 4 mm, sir.
Why did not you go for surgical therapy in this case?
The primary goal of pocket reduction, the primary goal of periodontal therapy is first to go for the non-surgical periodontal therapy followed by surgical periodontal therapy, sir. So after SRP, we place the Blue M gel. So usually there will be a pocket reduction in non-surgical periodontal therapy, sir. So we followed the procedure like NSPT followed by SPT. Since there was a pocket reduction in this in a non-surgical periodontal therapy, I didn't go for the surgical procedure.
Right. Thank you.
Thank you, sir.
Good morning, sir. Good morning, ma'am. Should I begin?
Good morning, ma'am. Yes, you can
please
start.
Thank you, ma'am, for giving us the opportunity to present this poster titled Adjunctive Role of Diode Laser in the Management of Bullous Pemphigoid, a case report. The case what I am presenting today is a 31-year-old lady who reported to a Department of Periodontology with a chief complaint of recurrent gingival ulcerations with pain and discomfort while eating and bleeding gums for the past 2 years. On her intraoral a positive Nikolsky sign, edematous marginal and the interdental papillae, the bulbous interdental papillae, and generalized bleeding on probing. No systemic involvement and no history of any food or drug allergy were reported. Also, the patient did not give any history of any biopsy done in the past. So as to arrive to a definitive diagnosis, an incisional biopsy was planned. 2 biopsy specimens, one from the maxillary arch in the 2223 region and the other from the mandibular arch in the 3334 region, using the stab and roll technique were collected. This technique is designed to reduce the lateral forces on the epithelium. The microscopic examination revealed stripping of the stratified squamous epithelium from the underlying tissue with the epithelial mononuclear cell infiltrate on the histopathological examination, and direct immunofluorescence studies showed positive dermal epidermal IgG and C3 complement antibodies along the dermo-epidermal junction. Of bullous pemphigoid was arrived at. A treatment strategy was aimed at the elevation of the symptoms of pain due to ulcerations, achieve hemostasis at the biopsy site, and reduce inflammatory condition of the gingival tissue. The diode laser were used as an adjunctive therapy along with topical and the systemic drugs to achieve the desired outcome. For management, a 980 nanometer diode with 0.8 watts under continuous wave was used for the surface ablation of the marginal and the attached gingiva in both the arches, including the biopsy sites, to provide hemostasis, photobiomodulatory effect, anti-inflammatory effect, as well as to improve the healing properties. The second sitting of laser was planned after 1 week. Our results were consistent with our expectations. Post-lasing, an excellent effect was observed in the zones of high inflammation and friable tissue. Also, the patient experienced decreased post-operative pain associated with improved visual analog scale scores, ranging from an initial baseline value of 7 to a value of 3 after 3 weeks, with less of bleed, less of inflammation, better hemostasis, and better healing. Thus, based on our clinical experience and results, the use of laser as an adjunctive therapy in the symptomatic management of desquamative lesions is indeed a food for thought. Thank you.
Dr. Manik,
yes,
did the patient had any skin lesions or lesions anywhere near hand or elbow?
No, ma'am. Systemically, the patient showed no signs or any symptoms of any disease. We had done a thorough examination. She had only complaints of intraoral ulcerations for the past 2 years. So based on that, a provisional diagnosis of desquamative lesion was arrived at. And to confirm the diagnosis, we carried out the biopsy.
Okay. You have treated the disease, but have you treated the etiology of the disease? Yes, the disease has occurred. You have done laser. It has healed. But
Yes,
what about treating the etiology of the disease? Why this disease has occurred and should not reoccur also?
Yes, ma'am. For that, for ruling out any etiology, dermat opinion was also taken, ma'am. So she was referred to the Department of Dermatology, but the patient did not manifest any, as such, any reason could not be, etiology could not be found out now. So more of a stress-induced probably or an autoimmune disorder.
Thank you.
Dr. Manak, what is the differential diagnosis for bullous pemphigoid?
So primarily because a Nikolsky sign was evident, Solaris was thought of. But based on our biopsy reports, that was ruled out, sir. Plus, there could be other desquamative regions like the mucous membrane pemphigoid as well. Sir.
Right, and you followed up this case for how much duration? What was the follow-up?
We tried to follow for a few months, sir. Being in the army setup, sir, the patient and the COVID scenario which is prevalent, sir, the patient was posted out presently, and we plan to recall the patient, sir. Presently, the patient is in a northeast field side. Her husband is in the army, sir. So they get posted out, sir. So, but we plan to get the patient back for a review, sir.
Thank you, Dr. Manik.
Thank you, sir.
Good morning, sir. Good morning, ma'am.
Good morning.
Shall I begin with the presentation?
Yes.
Okay. Myself, Dr. Kirti Gupta, and I'm here to present a poster on non-surgical treatment approach for drug-induced gingival enlargement. Starting with the introduction, drug-induced enlargement manifests as abnormal growth of the gingiva due to a side effect in patients treated with various medications, including anticonvulsant, immunosuppressant, and calcium channel blockers. One of the main drug associated is phenytoin, which is an anticonvulsant which affects gingival tissues by altering the extracellular matrix metabolism. The primary aim of non-surgical approach is to reduce the inflammatory component and thereby avoiding the need for the surgery. Adding here, according to reports, the incidence of phenytoin-induced gingival enlargement ranges from 3% to 84.5%, but only 50% of the patients on the long-term therapy are prone to develop gingival enlargement. Presenting here the case report of a 42-year-old female patient who reported to the Department of Pedontology with a chief complaint of increased size of gums in upper and lower jaw since 3 to 4 months. And she revealed a history of seizure since 3 to 4 years, and for which she was taking medication tablet Eptoin, which is phenytoin. In the pre-op pictures, we can see the evident gingival enlargement. On clinical examination, we observed presence of calculus stains and bleeding and probing, and generalized gingival enlargement was seen. Based on history and clinical examination, a diagnosis of drug-induced gingival enlargement was made. Then the complete scaling and root planing was performed along with copious betadine irrigation. Patient physician was consulted for drug substitution, which was then done with tablet Levepsy, which is levetiracetam, and it was replaced with tablet Eptoin. Oral hygiene instructions were reinforced, and patient was asked and motivated to maintain meticulous oral hygiene practices, and the use of chlorhexidine mouthwash twice daily was instructed for the patient. Patient was recalled after 1 month, 3 months, 6 months, and still under maintenance therapy. As the reports have shown that even after the drug substitution, we need to get the patient under our observation for 6 to 12 months. That's it. Thank you, ma'am. Thank you, sir.
Dr. Kriti?
Yes, ma'am.
Please tell me the mechanism behind drug-induced gingival overgrowth.
Ma'am, if we talk about phenytoin, ma'am, it decreases the calcium cell influx, leading to a reduction in uptake of folic acid, which ultimately limits the production of active collagenase and therefore reduces the collagenylysis. And also, ma'am, analogs of phenytoin, it increases the synthesis of sulfilated glycosaminoglycans. And ma'am, it stimulates the proliferation of fibroblast or fibroblast-like cells, ultimately leading to the increased cellular components.
These are just 2 of them. There are 9 mechanisms how drugs causes enlargement. What about the other 7?
Ma'am, there is a role of matrix metalloprotein synthesis and their function. Also, ma'am, age, and there is role of genetics. Then there is role of growth factors in inducing drug-induced gingival enlargement. And ma'am, there's also role of inflammatory cytokines, as in case of phenytoin, interleukin 6 and interleukin 1, they are increased.
Fine. Okay, what type of growth is there in this? Is it fibrotic or inflammatory?
Ma'am, initially it is, ma'am, basically in drug induced, it is inflammatory more, because the patient is unable to maintain the oral hygiene, and ultimately it adds up to the secondary inflammatory component.
Okay, sir. Okay.
Dr. Kirti, you manage the patient only non-surgically?
Yes, sir.
So from the photographs, it's visible that there is some amount of attachment loss present with respect to maxillary anteriors, and which is not so in the post-operative pictures. Also, the diastema present in the pre-op pictures has gone. How is that?
Yes, sir. Sir, for diastema, it was the problem of the patient. It was the complaint of the patient, and it was not done in our institution. But she got something done for her diastema because she wanted it to be aesthetically pleasing. Otherwise, we didn't intervene it with the surgical therapy. It was just non-surgical approach from our side.
Right. Thank you.
Thank you, sir.
Good morning, everyone. My topic is rhino-orbital mucormycosis in the post-COVID patients. Mucormycosis is an epidemic in a pandemic. More than 10,000 cases are reported in the past 4 months in India. It is caused by mucormycetes, and most common generative which cause the infection in the human is rhizopus. This factor in those of the immunosuppressive therapy and uncontrolled hyperglycemia. Major host defense mechanism, that is the ability of phagocytes to kill the microorganism, is impaired in the uncontrolled diabetes. Further, the use of corticosteroid treatment in the COVID patients affects the ability of the macrophage to prevent the germination of the spores. It leads to dysregulated innate immune response, ciliary dysfunction, thromboinflammation, and microvascular coagulation. Objective of the study was conducted in a patient of a mucormycosis who presented with the signs of sudden teeth mobility with an objective that the early intervention in the form of surgical debridement and the rational use of steroid can be advocated to avoid unnecessary mortality. A 70-year-old diabetic patient having a history of COVID-19 infection and treated according to the persistent protocol present with the chief complaint of sudden teeth mobility and the unilateral facial swelling. A diagnosis of mucormycosis was established after the nasal endoscopy biopsy from the middle turbinate and the radiological investigation. Initially, the conservative management with the intravenous fluconazole and the amphotericin B was done, and later on the surgical debridement. The patient recovered with the minimal residual deformity as defect was closed primarily. Intraoral examination demonstrated a tender swelling on the upper left buccal mucosa with a black necrotic gingival tissue and the area of necrotic bone with the involvement of palatal mucosa. Nasal endoscopy revealed the black necrotic debris present near the middle turbinate. HRCT of paranasal sinus revealed the mucosal thickening with the soft tissue in the left maxillary sinus, left ethmoid sinus, which suggests of fungal sinusitis. MRI paranasal sinus revealed the heterogeneous signal intensity suggestive of fungal sinusitis. Histopathology angio-invasion, wherein the hyphae was seen invading the vessel wall, is the hallmark of the mucormycosis. Aseptate branching, broad-based fungal hyphae, and the chronic inflammatory cell infiltrate were seen. Early intervention and debridement in the form of maxillectomy and ethmoidectomy prevented the complications like loss of vision, orbital cellulitis, and meningitis. Conclusion, the question still prevails about the cause and the origin of the enhanced prevalence in the post-COVID-19 patient. Research is needed for the better prevention and the management of the opportunistic infection in COVID-19 patients. Extensive use of steroid and the broad-spectrum antibiotics may lead to the development and exacerbation of pre-existing fungal disease. Thank you, sir.
Dr. Pooja?
Yes, ma'am.
You have presented a nice case.
Yes, thank you, ma'am.
What was your role in this case? Whether you had a histopathological role or a radiological role or treatment role, what was your role in this case?
Yes, ma'am. Ma'am, first thing is the diagnosis role. The patient first come with the tooth mobility and the ulceration and the pus discharge, and it came to the department of periodontology. Then it's a teamwork actually, ma'am. Then along with the oral surgery department people, we have done the surgery. And in histopathology, we have found the angio-invasion, which is the hallmark of this mucormycosis. That is the fungal hyphae which invade the vessel wall. It will cause the thrombosis of the vessel wall and the cause tissue necrosis. That's why that blackish discoloration we can see in these cases. And ma'am, there is a correlation between the SARS-CoV and the periodontal pocket also, ma'am. Like if we see in the perio, this thing, that the periodontal pocket, there's a deepening of the periodontal pocket and the which is due to the host inflammatory mediators which are released, like interleukin-6, which will cause the deepening of the pocket and the downward displacement of the junctional epithelium.
Do you have a reference to say that COVID-19 caused deepening of the pockets in such a short duration of time of 14 days? It caused bone resorption and then deepening of the pockets? No doubt they have common mechanism of cytokine storm, but do they cause deepening of the pockets? What you said.
Yes, ma'am, it is there in the article, ma'am. And they have mentioned it very well, that there's a direct contact between the virus and the activation of the host immune response inflammatory mediators, which aggravates, actually there is a breach in the pocket epithelium, which results in the deepening of the pocket. Thank you, ma'am.
Dr. Pooja, can you tell me one thing, since it's a case report? So what were the predisposing factors for your patient developing mucormycosis?
So predisposing factors are steroids,
Okay.
And it's in diabetic patients mainly we are seeing, sir.
So what were the values for this patient?
So values were 450, sir.
Okay. You went for HbA1c or just fasting?
HbA1c, sir. HbA1c, sir.
Right. And since you told that the patient was taking steroids, what was the dosage of steroids he was using?
So he was using some methyl prednisolone, sir. So 1 gram, sir.
Okay, thank you. We can move to the next one.
Thank you, sir. Thank you, sir.
Good morning. Good morning to all. Today I am presenting a case report on Lipstat. Lipstat procedure was first described by Robinson and Kostianowski in 1973. This procedure I have performed in my patient. As we know, smile is a unique tool that God has given to everybody. Without saying any words, he and she can express his happiness to the others. Ideally, face is divided into 3 parts: upper face, mid face, and lower face. And all 3 parts of the face should be equal in size. But in our case, there was an excessive gingival display up to 6 to 8 mm. It was after thorough examination, it was decided that Lipstat procedure would be performed in the patient. Our treatment plan was totally depend upon the Bhola et al. Classification. That was etiological classification given in 2015. Now the procedure was explained to the patient and local anesthesia was injected into the vestibule. 2 parallel incision, that is banana shape or elliptical incision, was given into the vestibule to remove the 1 mm of epithelium lining by exposing the connective tissue. First of all, midline suture was given to avoid the midline shifting, and continuous suture was given to close the whole flap. Now the post-operative instructions was given to the patient not to stretch and apply extra oral ice packs to avoid the swelling and take medicine on proper time. Patient was recalled after 15 days and sutures was removed. Patient was satisfied as such. There was no complication was observed in the patient. Conclusion: Lipstat is a versatile technique to decrease the excessive gingival display, and it gives an aesthetic and stable result to the patient with minimum post-operative morbidity. Thank you. Thank you, sir.
Dr. Manish, can you classify excessive gingival display?
Yes, ma'am.
How do you classify that? And in which specific condition you can use Lipstat technique? It is not applicable in all the forms of excessive gingival display.
Yes, ma'am. If there is a gingival display up to 2 to 4 mm, then Lipstat with aesthetic crown lengthening would be done. But in the case of 6 to 8 mm, up to 8 mm, Lipstat with orthognathic surgery would be indicated, and more than 8 mm, purely orthognathic surgery would be indicated. In our case, there was a excessive gingival display up to 6 to 8 mm. So patient was very satisfied with the Lipstat procedure.
Yeah, I want to know the Dr. Bhola's article where he has clearly cited A, B, C, D, E as 5 main etiological factors for excessive gingival display. Can you enumerate them?
Yes, ma'am. In Bhola et al. Classification, he has given in A category. He said only gingivectomy would be indicated, or crown lengthening would be indicated. In B, crown lengthening with osseous reduction. In both the cases, there would be.
Fine, right. Sir, you can ask your question.
Dr. Manish, from your photographs which you have said that displayed, it is clearly visible that the patient has pre-maxillary bone volume excess.
Yes,
but
ma'am.
You have gone just for this Lipstat procedure only. Why not for orthognathic surgery?
Patient was not agree for the orthognathic surgery, because it's gives a more morbidity and it's a time consuming, and patient was very poor. So with this lip stat procedure, patient was satisfied with the results. I do advise go for the orthognathic surgery, but patient was satisfied with the lip stat.
Right. Thank you.
Thank you, sir. Thank you, sir.
Good morning, ma'am. Can I start? Yes, you can start your presentation. Yes, ma'am. Today I'm here to present a poster on the topic Evaluation and Assessment of Periodontal Minor Surgical Procedures by various methods performed under surgical operating microscope, a case series. Periodontal tissues play a vital role in function and aesthetics in patients. A healthy periodontium equalizes maintaining the physiological dimension, and any deviation from it could evidence altered functional aesthetics. Magnification is a procedure employed for many periodontal surgical procedures which have great impact on surgical outcome and precision. This magnification can be employed by either magnifying loops or with surgical microscope, and it facilitates a near neutral head posture by design. Even though various procedures have demonstrated potential for treating periodontal diseases, use of operating microscope and microsurgical instruments increases the ability of clinician in controlling the manipulation of tissues during surgery and has changed clinical outcome of both non-surgical and surgical surgical success in practice. The popularity of periodontal plastic surgery has enhanced the use of microsurgery in periodontics because of increased visibility of the surgical site, improved visual acuity, superior approximation of bone, rapid bone healing, decreased postoperative morbidity, and increased acceptance by the patient. Although few studies have evaluated the efficacy of various periodontal procedures under surgical operating microscope, there is a need to evaluate the efficacy of minor surgical procedures using various techniques under surgical operating microscope. Objectives of the present study are to evaluate patient comfort and evaluate postoperative healing. Patients with systemic diseases that contraindicate periodontal surgery and patients with active and periodontal diseases and smokers were excluded from the study. The referred patients were divided into three groups, into group 1 conventional method, group 2 laser, and group 3 electrocautery. Conventional method using 15 C plate and laser diode laser, and electrocautery using tip T4. Each group constitutes total of 8, with 2 in each comprising of depigmentation, crown lengthening, frenectomy, and operculectomy. And the examination included the assessment of visual analog scale and healing time. Results were analyzed using ANOVA and repeated measures of ANOVA, and all the methods have shown to be equally effective under surgical operating microscope when compared visual analog scale at baseline and 1 week, and early wound healing index at 1 week and 1 month. Here, I would like to conclude by saying that surgical operating microscope helps in better surgical ability and improve treatment quality. It also provides better ergonomics for longer duration and with increased precision.
Dr. Shravan, what was the magnification that you used?
10x, sir. Dr. Savanthi, how did you evaluate it which is better? Just by looking at the healing and visual analog score? Yes, ma'am. So how do you look at the healing? Watchels early wound healing. Ma'am, how did you look at the healing and evaluate it? Just by looking at the color of gingiva? Yes, ma'am. Is there any healing index which you should have used to evaluate? Yes, ma'am. Watchels early wound healing index. Okay, you did use this index? Yes, ma'am. And do you have a surgical microscope in your department? Labomed, my surgical operating microscope. You have it in your department? Yes, ma'am. Fine.
Thank you. You can start with the next one.
Thank you, sir.
Good morning to one and all present here. I'm Dr. Roshan, and today I would like to present a one-year case report titled Stitch the Pocket and Prevent the Socket. It is a 1-year case report wherein I had a patient who was around 56 years old and complained of sensitivity and pain in the upper front tooth region. And upon examining, I had noticed a 15 pocket in a non-vital toe one. And the patient did not want to get the tooth extracted, as we could see that there was periapical lesion, and onto the distal aspect there was a total bone loss. The total interdental bone was totally lost, and the patient did not want to undergo an extraction. The tooth was also pathologically migrated, and as I told you, there was a 15 pocket. So in order to help the patient out with his aims, wherein he wanted to go in for a non-extraction approach, we ended up completing a root canal in the endo department. Followed by that, I prepared my patient for the periodontal surgery, wherein we did a connective tissue graft with a bone graft with a connective tissue graft. So what we did was we elevated the flap. After that, visually we saw the defect after around 21 days of the root canal therapy. We harvested a CTG, we placed a bone graft, we covered that up with a CTG, and then we sutured it with a vicryl suture. And at the end of 1 year, we ended up seeing that the periapical lesion was totally healed, and there was a certain amount of bone fill which had occurred in the distal to the 2-1 as well. And upon seeing the post-op probing depth, that was at the end of 1 year, the probing depth had reduced from 15 to 9 So looking at this particular therapy, what had occurred, and there was no mobility also. So that was the reason why for such a long time I've already been following up this patient, and he still seems to be going good with it, and he has been able to prolong the duration of this natural tooth in his mouth for a longer period of time rather than extracting it and opting for another other treatment modality. So I would like to conclude by saying that connective tissue graft and a bone graft seem to be a promising non-extraction treatment option for such a deeply periodontally and an endodontically compromised tooth.
Dr. Roshan?
Yes, ma'am.
In your poster, if you can appreciate the change from the pre-operative radiograph to the one where you have already done the root canal treatment.
Yes, yes.
30% of the lesion is already healed in the root canal area.
Yes.
Isn't it? So what is your opinion to go for a periodontal surgery or not? Means if you would have given time, will the lesion would have healed properly or 100%, or the periodontal surgery was must?
It was a must because there was a 15 pocket which would not resolve on its own. So we had to intervene periodontally as well. And at the same time, if there is a pocket, there will always be debris accumulation there, which would not only compromise the periodontal wound healing, but also the periapical wound healing will keep getting compromised because of that. And moreover, it was a 15 pocket which was extending up to the apex also.
Okay, fine.
Dr. Roshan, was there
Yes.
any TFO present in this case?
There was no TFO as such, but there was pathological tooth migration was there. So I presume that there would have been a stage wherein TFO would have been present, and because of that only the tooth might have gone non-vital. Or and even the patient gave a history of trauma also. That was the reason why the tooth had become non-vital also.
Right. For your presentation, wouldn't it have been better if you had used clinical attachment loss rather than pocket depth as a criteria? Because
Sir,
the
that is
pre-operative and
yes,
post-operative,
exactly.
you can see that there is recession present.
True, sir. The recession coverage, the assessment to address the recession, that was not our criteria. Our criteria was to only satisfy the patient and to make sure that we go in for a non-extraction approach, and for the long term, the tooth still stays in the patient's mouth. That was the only criteria, and moreover, I do accept it is our mistake. It was my first case, so I did not prepare a stent. I did not do anything of that sort to exactly and accurately take measurements also.
Right. Thank you, Dr. Roshan.
Thank you, sir. Thank you so much.
Good morning, sir. Good morning, ma'am. Can I start, ma'am?
Yes, you can start your presentation.
Good morning to everyone. Today, my topic for poster presentation is Management of Teeth with Guarded Prognosis by Mother's Touch, a case series. Moving on to the introduction, this case series describes the role of amniotic membrane as a barrier membrane in the salvation of teeth with endoperioral lesion, which had a questionable prognosis. So, 3 patients having endoperioral lesion were participated in the study. This first case, moving on to the first case, the 17-year-old male patient came with a complaint of pain in the left upper back tooth region. On examination, the patient had a grade 3 mobility and tender on percussion, and on electric pulse testing, the tooth was non-vital with a pocket depth of 14 mm and grade 2 percussion involvement was seen. After phase 1 therapy was completed, flap surgery was planned. A full thickness mucoperiosteal flap was elevated, and osteograft and amniotic membrane was placed and sutured. After 1 year, the pocket depth reduced to 1 mm, and this is the pre-op and post-op IOPA after 1 year. And the case 2, a 42-year-old male patient came with a swelling in the upper left front tooth region. On examination, the patient had a grade 3 mobility and non-vital tooth and pocket depth of 9 mm with a class 1 recession. First, the emergency phase treatment was carried on by incision and abscess drainage, and then phase 1 therapy, and then root canal was done, and then flap surgery was planned. Osteograft and membrane was placed and sutured. After 1 year, the patient had a pocket depth of 1 mm, and this is the pre and post-op IOPAs. In the third case, a 39-year-old male patient came with a complaint of painful mobile tooth. On clinical examination, he had probing depth of 14 mm, grade 3 mobility, and the tooth was non-vital. And also the patient had a horizontal bone loss in other tooth, and so it was diagnosed as aggressive periodontitis with endoperioral lesion in the forceps. And in this case, a root resection was, distal root was resected, and then the graft and membrane was placed and sutured. 1 year follow-up radiograph showed significant bone formation and stability of the tooth. On conclusion, the amniotic membrane is one such barrier membrane with a number of unique properties such as anti-inflammatory, anti-scarring, and antibacterial. It also serves as a source of multipotent stem cells for the regeneration of lost periodontal tissues, and hence it can act as a better barrier membrane for GTR. Thank you.
Dr. Kofsalia,
yes,
where did you procure this membrane from?
Ma'am, Tata Hospital in Mumbai, amniotic membrane.
Okay, fine. What is the resorbability time of this membrane? How long does it stay?
I guess it's 4 months.
No. You can ask your question.
Dr. Kausalya, what are the advantages of using amniotic membrane over other GTR materials which are available?
So since it has many growth factors, it acts as better. It gives a better wound healing, and it reduces pain, anti-inflammatory, and anti-scarring. So growth factors are present.
And in most of your cases, it were perioendo lesions.
Yes, sir.
So you have instituted endodontic therapy in all of them. So how much time did you wait for these periodontal procedures?
So first phase 1 therapy, and we will leave for 2 weeks, and then recall the patient and root canal therapy, and then 1 week, and then periodontal surgery. So totally of 1 month to complete the complete procedure.
Thank you.
Thank you.
So with this, we come to end of third session. And now we I would like to thank both the chairpersons, Dr. Shalini Kapoor ma'am and Dr. Gurprakash sir, for chairing the session. And now we'll begin with the next session at 12 p.m.
Thank you. Thank you, Dr. Gurprakash.
Thank you, Dr. Shalini. Thank you, Sohani. We will reconvene in another 10 minutes.
Yes, yes.
In the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there's a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from a adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be a underweight of the baby, which itself is a risk. So how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So let's make a motherhood safe with a healthy child and a safe mother. Thank you.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world, with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge, and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population, to create an awareness among the general public, and to create an impact as well as on the treatment line, and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry, because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy.
Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
Hi all, periodontal disease or pyria, as we all know, it is inflammation of the supporting structures of the teeth, that is the gum and the bone. Studies have shown that there is a lot of association found between the periodontal disease as well as systemic diseases of conditions which primarily talk about diabetes, cardiovascular disease and pregnancy. Pregnancy, we are aware there is a lot of hormonal changes which is going to be undertaken in the body, and the most commonly seen condition in the oral cavity, which we can call it as a growth on the gum, which may or may not require intervention if it interferes in the normal process of chewing for the lady. Beyond that, the gum condition also has been seen to be worsening because of the hormonal changes, and it has been seen that the pregnant lady is bound to be suffering from a adverse pregnancy outcome, which means that there could be a premature delivery of the baby, which means that there will be a underweight of the baby, which itself is a risk. So how do we manage these conditions? It is important that a compulsory oral health screening or a checkup should be undertaken for the pregnant lady, and if any treatment is required in terms of cleaning or further gum and bone treatment, should be undertaken safely in the second trimester, because first and third trimester are not recommended for any sort of a intervention. So let's make a motherhood safe with a healthy child and a safe mother. Thank you.
So can we start?
Yeah, we can start, madam.
I welcome you all to this poster presentation session and wish all the participants a very good luck for the same. We have with us Dr. Shalini Kapoor ma'am and Dr. Gurprakash Singh Chahal sir as the respected chairpersons for this session. We welcome you both.
Good afternoon, ma'am. Am I audible?
Yes, you are,
ma'am. Yes, you are.
Should I start, sir?
Yes, please.
Thank you. So, good afternoon, everyone. Today, I am going to present my poster on the topic of management of peripheral osteoma or hard palate. Peripheral osteoma is a benign, slow-growing tumor which is mainly found in the craniomaxillofacial bone. Previously, it was thought as an hematoma, but according to the recent WHO classification, it has been considered as a true neoplasm of well-differentiated mature bone tissue. So, coming to the case status, a 33-year-old patient, Varun Sharma, came to our department with the chief complaint of irritation with tongue movement caused by presence of a hard painless mass on the right back tooth region on the inner aspect. On examination, a bony hard painless swelling was found in relation to 1.7 and 1.6 on the palatal aspect. After 7 days, when the patient was recalled for scaling root planing, a white hard tooth-like mass was found within the lesion. CBCT confirmed presence of a radio-opaque hard tissue mass, which was planned to be surgically removed. Now coming to the surgical procedure, after achieving proper anesthesia, clavicular incision has been given from the distal aspect of 1.7 to the mesial aspect of 1.6, followed by full thickness mucoperiosteal palatal flap reflection. On reflecting the flap, the mass was found to be adhered with the overlaying periosteum, which was tried to be removed along with its peripheral attachment, but it came out separately. After debridement, hemostasis and copious irrigation, suture has been placed followed by Copac placement. The removed mass was sent to the oral pathology department for histopathological analysis. On report, it was found that there is presence of bone demonstrating lamellization, osteocytes within the osteocytic lacuna, and some foci of marrow spaces, which gives us the final diagnosis of peripheral osteoma, which was previously thought to be an odonto. You can appreciate the postoperative pictures. On the 7th day, suture has been removed, but proper healing had not taken place. 3-month postoperative picture showed excellent healing. No recurrence has been reported after 6 months. So to conclude, this was peripheral osteoma was first described by Jeffrey et al. In 1935. This type of lesion needs surgical accuracy for proper management. So long-term follow-up is needed for better understanding its chance of recurrences. Thank you.
Can you tell me the difference between peripheral osteoma and exostosis? How do you histologically differentiate the two lesions?
In peripheral osteoma, there is presence of the marrow spaces and the osteocytic lacuna, osteocytes within the lacuna, especially the marrow spaces. In the of exostosis, I don't think there will be presence of these marrow spaces.
You don't think, or is it not there?
It will be not there.
Okay, fine.
Dr. Subhati, in the maxillofacial region, which are the sites which are mostly affected by osteomas?
In jaw, if we consider the jaw, then mandible is more affected than maxilla. And if the maxilla will be affected, then only the paranasal sinuses will be affected. In case of palatal or peripheral osteoma in palate is very rare. Mandible may be affected, and in maxilla, the mainly affected regions are the paranasal sinuses.
Thank you.
Thank you, sir.
Yeah, ma'am, you can start.
Good afternoon, everyone. Today I will be presenting a poster on gingival depigmentation by scalpel technique. So I start with the introduction. As we all know that an aesthetic smile enhances the personality and the self-confidence of the individual, and the gingiva, color of the gingiva plays a significant role in this. And the color of the gingiva is affected by the thickness of epithelium, degree of keratinization, size of blood vessels, and color pigments within the epithelium. The gingival hyperpigmentation can be physiological or pathological. And the gingival depigmentation is a periodontal plastic surgical procedure where the gingival hyperpigmentation is removed or reduced. And the first or the foremost indication for the depigmentation is patient's demand for his or her improved aesthetics. Now, the elimination of these melanotic areas can be done by scraping of the gingiva or slicing of gingiva by cryosurgery, electrosurgery, and various type of lasers.
Now, a 22-year-old patient had visited the Department of Periodontics with the chief complaint of black-colored gum. Her oral examination revealed, as you can see in figure 1, this is the pre-operative picture of the patient, which shows deeply pigmented gingiva from right first premolar to the left first premolar. And so the scalpel surgery was planned for the depigmentation. And in figure 2, number 15 blade is used to remove the pigment layer in the maxillary anterior gingiva. Figure 3 shows the removed tissue. In figure 4, this is the post-operative after removal of the pigmented tissue. And figure 5 shows 15 days post-operative picture where it shows a healthy gingiva with no increase in extent of the repigmented areas. So in discussion part, according to the Roshna T and Nanda Kumar K in 2015, the depigmentation procedure by scalpel technique is simple, easy to perform, and it is cost effective. The procedure involves surgical removal of the gingival epithelium along with a layer of underlying connective tissue, which allows the denuded connective tissue to heal by secondary intention. And the new epithelium that forms is devoid of the melanin pigmentation. So I conclude by saying that the depigmentation procedure was successful and the patient was satisfied with the result. And therefore, the depigmentation of hyperpigmented gingiva by scalpel surgery is simple, it is easy to perform, it is cost effective, and it causes less discomfort and also aesthetically acceptable to the patient. Thank you.
Dr. Sapna, you are in which year of MDS?
Ma'am, I'm in second year.
In?
Second year.
Second year. What made you present this case in national on a national platform? Means, we always put our best foot forward whenever we are presenting at such a national platform. Means, what was the innovation or a thing which you want to tell to others or you want to share with others in this case?
Ma'am, I just want to say because like we can use different methods also for gingival depigmentation, but like people who are practicing in the clinic not always have like laser machines or those kind of equipments because those are expensive. So scalpel technique is basically it's very cost effective, which you can perform in clinics as well. And as I discussed in the case, that it is easy to perform also, and it is not very expensive, and patient is also satisfied by the result.
Your message is clear, but when I look at the presentation of your poster, I think what all is required in the poster is lacking. No clarity of images, no presentation, no, I can't even read the text which you have written. So I think you should improve on these factors.
Yes.
Dr. Sapna, you concluded that depigmentation by scalpel is better. But since it's a case report, you have just done one case. How can you come to that conclusion?
Sir, this is just the one case that I've presented, but I have done other cases as well with scalpel. I've seen the results. It's quite acceptable.
Okay, and on what criteria could you base that conclusion? Okay, we understand you had other cases. You could have put it here. You could have done it together and made a better presentation. But nonetheless, how can you conclude? On what criteria could you conclude that scalpel is better than, say, laser or electrocautery or any other method?
Sir, because it is simple, it is cost effective and it is easy to perform. Otherwise, if we look at the laser has more advantages over the scalpel because it provides dry field while performing, and it also sterilizes the tissue. And
that will be all, Dr. Sapna. Thank you.
Thank you, sir.
Dr. Himani, you can start. If you're there.
Am I audible?
Yes, doctor, you are audible.
Can I start?
Yeah, please start.
Yeah. So topic for my poster presentation is gingival depigmentation. Hello. Am I audible, ma'am?
Yes, you are audible.
Yes, you are. You can continue.
Yes, sorry. Yes, ma'am. So topic for my poster presentation is gingival depigmentation. So starting with the introduction, it is the facial appearance depends on several oral and extraoral factors. The gingiva is an important oral tissue which was affected when particularly pigmentation was there, and it gives a very unpleasant appearance. Melanin pigmentation appears as an early sign of pigment. It's the only pigment that occurs after 3 years after birth. I have used laser therapy while doing this gingival depigmentation. So laser therapy is an effective and non-invasive treatment option of gingival depigmentation. There are various types of lasers available like carbon dioxide, Nd:YAG, that is neodymium doped YAG, and ER-YAG, that is erbium doped YAG. So coming to my case, it is a 23-year-old female patient that comes to the Department of Periodontology complaining of darkening of gingiva since last 1 year, which was resolved by using laser depigmentation technique. The frequency which I use for lasers is 50 Hertz, the power is 8 watt, and the pulse width is 26 microseconds. I use it in a contact method. While using it, I use a 400 nanometer flexible fiber optic handpiece. I have given circular motions with a very slight contact on the tissue, avoiding the teeth structure. Therefore, the angle at 45 degree, and the melanin pigment, I used to remove it until and unless there was a complete removal of the basal and the suprabasal layer of the gingival epithelium. And the resected part was removed by the saline soap gauge. There are various advantages and there are very disadvantage of laser treatment. The advantages are that it's very less pain and there's no infection and there's no swelling and they're very less bleeding. And but there are various disadvantages as well, like ulcerations, recession, and sometimes because it generally occurs when there is very less amount of periodontal tissue over the gingiva, and it's comparatively expensive. Thank you.
Imani, which laser you have used?
I've used a diode laser.
So can you tell me various other methods for doing gingival depigmentation?
Ma'am, there are various techniques. There are various surgical techniques that include scalpel techniques, lasers, electrocautery, and there are various chemical techniques as well.
Which chemicals do you use?
Ma'am,
have you ever used that technique?
No, ma'am. No, ma'am. I've never used any chemicals for pigment.
It's obsolete. We don't use it. That's it.
Dr. Himani, did you follow up this case?
Yes, sir. I've done in this case, sir.
So the results of this depigmentation procedure, they are retained for how much time?
For after 2 weeks, the results was there, and then after that, I called the patient after 1 month. There's no post-operative complications to the patient, and after that, that lockdown occurs. So I didn't make the follow-up again.
You can answer that from your knowledge as well. Normally, repigmentation starts after how much time after this procedure, repigmentation?
Repigmentation, sir, according to various studies by Hegde and Jinwala, and these guys, according to these studies, after 1 month or 1.5 months, if the person is continuously taking smokeless or smoking tobacco in any way, so there may be chances of reoccurrence.
So if according to it's a 1 month procedure, then why do we need to do it? Right, thank you. We can move to the next one.
Good afternoon, everyone. Sir, may I audible?
Yes, you're audible.
Yes, please.
I'm going to present here gingival depigmentation. Gingival depigmentation is a periodontal plastic surgical procedure in which depigmentation is carried out by various techniques. Here we use scalpel technique. Main objective for the procedure was to achieve aesthetics on patient demand. Methodology: a systemic healthy female patient aged 24 years reported to the Department of Periodontology with chief complaint of black colored gum. Depigmentation surgery was performed by scalpel. Here treatment plan is: in this technique, the pigmented gingival epithelium along with a layer of the underlying connective tissue is surgically removed, splitting the epithelium with blade. Care should be taken not to leave any pigmented remnants over the denuded area. The scalpel method is one of the most economic techniques and also does not require extensive armamentarium. However, scalpel surgery causes bleeding during and after the procedure, and it is necessary to cover the surgical site with periodontal dressing for 7 to 10 days. Coming to the result, depigmentation surgery by scalpel yielded aesthetically acceptable results with minimum discomfort to the patient. Healing was uneventful, the depigmentation was successful, and the patient was comfortable with the aesthetic achieved. Conclusion: the depigmentation surgery was successful, and the patient was satisfied with the result. Thus, they conclude that depigmentation of gingiva by scalpel is simple, easy to perform, cost-effective, and it causes less discomfort and is aesthetically acceptable to the patient.
Dr. Jitendra?
Yes, ma'am.
What are the cells that are responsible to cause pigmentation in the gingiva?
Sorry, ma'am.
What are the cells in the gingiva which are responsible for causing pigmentation?
Ma'am, melanin.
Melanin is a cell or
No,
a pigment.
ma'am.
So, Dr. Jitendra, you are a final year or a second year student?
Ma'am, final year.
Okay. So, what are the cells? Fast, we just have some time left, 1 minute only. Okay, just tell me the 3 factors on which the color of the gingiva depends. Come on, you are a final year student. What are the 3 factors on which the color of the gingiva depends? Okay, fine.
Dr. Jitendra, during this depigmentation with scalpel, what are you actually removing?
Epithelium, sir, outer epithelium layer.
Where is melanin present? Thank you.
Thank you, sir. Thank you, ma'am.
Hello. Good afternoon to one and all present here. Am I audible?
Yes, you are.
Okay. Today, myself, Tanushri Maid, would like to first take a
Hello.
moment and thank the platform for giving us this opportunity of presenting virtually in the midst of this COVID era. Me, with my two co-authors, Dr. Hirva Kothari and Dr. Devrat Patel, is going to present a poster on the topic of a non-surgical.
लेकिन ऑडियो किसी और का ही है नहीं हेलो 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 should I start ma'am
Yes,
hello
please.
Good afternoon everyone. I'm going to present a poster membrane as a bandage. The aim of study was to evaluate the clinically and histologically accelerated effect of concentrated growth factor membrane plus periodontal dressing and the periodontal dressing alone in the wound healing following the depigmentation procedure. The CGF was the first developed by Sacco in 2006. CGF is produced by centrifugation of the venous blood. Platelets are concentrated in a gel layer containing fibrin matrix. CGF is very similar to PRF except the number of growth factors are more. Coming to the methodology, after depigmentation, group A, that is the test group, received the CGF membrane plus periodontal dressing, and the group B controlled the periodontal dressing only. The individuals were evaluated for the visual analog scale healing index on the 3rd and the 5th day. This was the obtained CGF. It's converted into CGF membrane. Then this was a pre-operative view of the gingival pigmentation. Then partial thickness flap on the facial surface of the gingiva raised. Then the first quadrant was covered by the CGF and the suture with a 5-0 resorbable suture. Then the CGF membrane covered with a tin foil and the both the quadrant were covered with a non-usual periodontal dressing. Then this was a post-operative view at the 3rd day. Here we can see there is a good healing in the test side, and then this was a toluidine blue test on the 5th day. Then here we can see there is a more staining at the control side than the compared to the test side. Then coming to the histological analysis, the punch biopsy test should be punch biopsy test is done, and then the result was the control side shown the more inflammatory cell infiltration compared to the test side. That is the test side contains shown the less inflammatory cell infiltration. Then coming to the conclusion, the application of the CGF membrane as a the application of the CGF membrane the application of the CGF membrane in the present case series has given a good results in preventing the raw wound area of the depigmented site. There is a better patient comfort and the faster healing and the excellent handling. Thank you.
Dr. Chetrali?
Yes, ma'am.
You have done depigmentation in the entire anterior quadrant, means from 3 to 3. So were you able to get that
Yes,
longer membrane?
Yes, ma'am. We obtained 2 CGF membrane.
Okay. So what is the difference between CGF membrane and the PRF membrane?
Between PRF and CGF, na, ma'am. CGF for the CGF membrane we need a more configuration time, and the concentration of the growth factors is more in a CGF membrane than the PRF. The growth factors are more in a CGF.
What is the difference in like spinning and centrifugation time or something? Why there are more factors in CGF?
Yes, ma'am. For the centrifugation of the concentrated growth factor, we need a 14 minutes, and for the PRF, we need a 13 minutes. There is a more in a acceleration time, that is a 30-second, first 30-second acceleration, then 2 minute, 2 minute at 2400 RPM, then 4 minute at 2000 4,700 RPM, then 2 minute at 3000 RPM, and then last is a 30-second deceleration. By this process, we obtain a CGF membrane.
Fine.
Dr. Chetrali, according to you, the inflammatory cell infiltration was less in the test site. But
Yes,
this inflammation is occurring because as part of a healing mechanism, and you told that the healing was faster. How much difference did you note between both the groups?
Sir, we did a case series in our department. So we did a 4 patients. The results are obtained was the test site shows the more inflammatory cell infiltration. We did the punch biopsy test on the both side, and after the result, it's shown that there is a more inflammatory cell. Here we can see here is a more inflammatory cell infiltration than compared to the control side.
At what time period did you take it?
Sir, epithelialization test will done after on fifth day. After the depigmentation, we did the punch biopsy test on a 5th day for the histological evaluation.
Right. Thank you.
Okay. Thank you, sir.
Hello. Good afternoon to one and all present here. Today, me with my two co-authors, Dr. Hirva Kothari and Dr. Devrat Patel, are presenting a poster on the topic of a non-surgical periodontal therapy, a diamond in the rough. Firstly, I would like to take a moment and thank the platform for giving us this opportunity of presenting virtually in this midst of this COVID era. Coming to the case, since ages, several studies have shown that periodontal diseases comprises of more than 50% of the global population affected by oral problems, of which one such is the gingival enlargement. The most common form of the gingival enlargement is the inflammatory type of enlargement, which is due to the inflammation, plaque-induced inflammation of the gingival tissue. In the present scenario, a 37-year-old female patient reported to the Department of Periodontology, Ahmedabad Dental College and Hospital with the chief complaint of swelling in gums of teeth in upper front region. Local factors like plaque and calculus were present. As you can see in the picture, the marginal gingiva seemed to be markedly enlarged. Enlargement was localized and it was supported with the inflammatory component like more than 5 mm of bleeding periodontal depth, and bleeding on gingival bleeding on probing was also present. There was no drug or systemic history which rules out the presence of drug-induced gingival enlargement. No familial history was also present. So, according to Angulo, that is the most recent study in 2016, non-surgical periodontal therapy is the key factor in the treatment planning of the inflammatory gingival enlargement. So on the first visit, phase 1 periodontal therapy was initiated with oral hygiene instructions also given and the motivation to the patient to follow the same. After the full mouth scaling and root planing was done, it was followed by the use of 2 mg of tetracycline fibers, which were soaked in normal saline. This use of an antimicrobial agent as an adjunct to the scaling and root planing enhanced the results due to its root binding capacity and its property to release in active form over a prolonged period of time. The tetracycline fibers were selected in this very case to reduce the inflammatory enlargement. The fibers were incorporated at the localized inflamed sites after 1 week with the help of parental probe by applying gentle pressure. And periodontal pack was also given along the gingival margin in order to stabilize the fibers into the gingival sulcus. Later, after 1 month, as shown in the picture, the efficiency or efficacy of the tetracycline fibers in adjunct to scaling and root planing was evaluated and was proved to be effective as there was reduction in the enlargement. The enlargement was significantly reduced after the 2 months with achieving the scalloped and firm marginal gingiva. So with this, we can conclude by saying that tetracycline fibers proved to be effective as an adjunct and thus proving the title correct that it can actually work like a diamond in the rough. Thank you.
Dr. Tanushree?
Yes.
You said it's an inflammatory enlargement, is it? So, for inflammatory enlargement, if you would have done a proper scaling and root planning, the inflammation would have subsided. So, how could you justify the use of a tetracycline fiber in an isolated inflammatory enlargement?
Ma'am, actually, it enhances the result and it of course, I understand that the non-surgical only scaling and root planning can do the result and work, but sometimes giving the local drug delivery along with it can be helpful and it shortens the period of time to get the result.
There are certain guidelines to prescribe local drug delivery agents. Do you know that? Okay.
Dr. Tanushree, why did you choose tetracycline fibers?
So we chose tetracycline fibers because of its prolonged release over time, and it acts as a bacteriostatic in the lower concentration, but it can act as bactericidal when given in higher concentration, and as it was the localized site. So higher concentration will not even harm the remaining gingival tissue.
You are in which year?
Second year.
Thank you.
Thank you.
Am I audible?
Yes, please, you can start.
Okay, a very good afternoon to the respected panel of judges. I'm going to be presenting my poster on the topic Incidental Finding of Paradental Cyst in Maxillary Anterior Teeth During Immediate Implant Placement, a Case Report. To introduce, paradental cyst is classified under the inflammatory cyst in the WHO classification under a subheading known as odontogenic cysts. The incidence has been reported to be around 3 to 5%, which suggests that the rarity of the lesion. Rare incidence of paradental cysts in relation to the anterior teeth and maxillary teeth in particular is found. Coming to the material and method, patient reported with mobility spacing in upper anterior teeth. On clinical examination, the anterior teeth presented with greater than 50% bone loss, grade 3 mobility along with pathological migration. On palpation, there was a hardened increase in the volume of gingiva that could be observed with papillary swelling, exudation in relation to 2:1 with a pocket of 11 mm. The tooth was found to be vital and a diffuse radiolucency was found on the radiographic apical area of 2:1. Coming to the surgical procedure, the first image shows the preoperative image. On extraction, the paradental cyst was found on the apical area on the lateral aspect of the tooth. Proper degranulation and removal of tissue tags were performed. Then primary drills were placed, paralleling pins to see the accuracy of the position, and cover screw was then placed. On bone grafting was carried out with Serra bone all throughout the jumping distance and the space that was seen. O6 plus graft was split into two and placed over the grafted area. Sutures were placed. Patient was called after 3 months and the RPD was given to the patient. This is a clinical ongoing case right now. Grossing and coming to the grossing and histological section, the H&E tissues exhibited basal cell hypoplasia and continuous with the cystic wall. The lumen was discontinuous with non-keratinized stratified squamous epithelium, and it showed hypoplasia and arcading pattern. There was inflammatory cell infiltrate, hemorrhage, degeneration, and microbial colonies were also evident. This is a preoperative and postoperative image. Coming to the results, no recurrence of the cystic lesion was noticed, along with complete bone fill and soft tissue fill in the grafted area. Complete loading will be done after 2 months. To conclude, paradental cyst with maxillary teeth is a rarity due to its inflammatory origin in cases with long-standing periodontal infection or inflammation. Such cysts may be encountered and following treatment protocol may be advocated. Thank you.
It was a good presentation, Doc. I have a query that paradental cysts are usually associated with unerupted tooth, but here the teeth are erupted with periodontal disease. Can you justify the diagnosis of paradental cyst?
Ma'am, like how we found out it was a paradental cyst is because through the H&E, when we had and the tooth was vital. Usually paradental cysts are seen related to the third molars during an unerupted teeth or after the next is where we usually see it. But in our case, it was a rarity that during a long-standing inflammation due to the infiltrate that was present, there was probably a leak from the pocket lining that caused the cystic enucleation of the thing, and that's why paradental cyst was found in the maxillary area, ma'am.
Okay. And which bone graft you have used?
Serra bone, Bottis. Serra bone, ma'am.
What it is? Autogenous? Xenogenic? Which type of bone graft you have used?
It's a xenograft.
It's a xenograft.
Dr. Phoebe, what is jumping gap?
So the distance between the implant to the surrounding bone, where from the implant placement to the surrounding bone is the distance between that is known as jumping distance, sir.
And besides the pocket lining which you told for your case, the periodontal cyst, which other source of epithelium are there?
Source of epithelium. So the stratified squamous epithelium, so the non-stratified squamous epithelium usually. The dental follicle can be, the REE can be a source of cysts, reduced enamel epithelium.
Right, thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
Sir, am I audible, sir?
Yes, you're audible.
Ma'am, so good afternoon, sir and ma'am. Today my topic is laser-assisted lip repositioning surgery. So moving to introduction, smile is the best jewel person can have that makes the person beautiful and confident. Attractive smile that enhance the person's self-confidence, whereas the gummy smile it becomes the aesthetic concern. Excessive gingival display is exceeding 3 mm, unpleasant, and is referred to gummy smile. So as with dental professionals, it is referred to the gummy smile is as excessive gingival display. So moving to case report, a 26-year female patient came to the department with a chief complaint of how her gums are sore when she smiles. So on clinical examination, the upper lip length was 17 mm and the gingival display at 2 mm at the rest, and the gingival display 8 mm while smiling. So the lip repositioning surgery was planned. So what are the cause for the gummy smile? So there are three primary factors: lip, teeth, and the gingival scaffold. If a patient is having a more excessive upper short lip, so it's not going to cover the lower gingiva and the upper teeth. So compensatory delayed eruption and the delayed eruption and the upper lip hypermobility can cause the gummy smile. So it can be corrected by the surgical procedures. We have the three steps: preparative steps, surgical steps, and the follow-up. So using a dyed laser with 813 nanometer of the wavelength and 2.5 horsepower. So first incision was given in the mucogingival junction, and the second incision was given in the 16 mm far from the mucogingival junction. Myotomy was performed and the suture was placed. As you can see here, the gingival display trace is 2 mm and the smiling it's 8 mm. So after the surgery, so the gingival display is reduced. And so moving to the laser. So laser is a device that it is a device that stimulate the molecules and the atoms to the stimulus atoms to the emit the light at the particular wavelength and amplifies the light by producing the small narrow beam of the radiation. The laser sometimes is called as a soft tissue laser and is ideally used in the recontouring and the size of the oral soft tissue. So moving to the discussion, the lip repositioning technique was an excellent alternative as compared to the other costly procedures. So moving finally the conclusion. So laser assisted gummy smile is a multifactorial condition that needs the careful examination to deter the causative etiology. Thank you, ma'am.
Dr. Shekhar?
Yes, ma'am.
Is it like every patient which is coming to you with a complaint of excessive gingival display, you can start with lip repositioning surgery?
No, ma'am. If there is degree 1, 2 to 4 mm, we can go for the crown lengthening. And if it is more,
my question is not this. I don't know why you're misinterpreting my question. I have asked this to other people also. My question is that it is like every case of if a patient is coming with a gingival enlargement, that they will also show you excessive gingival display. Will you do lip repositioning in those patients? It is very important in this poster to show us the indications where we can do this surgery. Otherwise, this poster is incomplete without knowing the indications of the surgery. And second question I had is that what is the deciding factor that you have to cut 16 mm, as you said in your presentation, that you will cut 16 mm from the mucogingival junction? What is the criteria? Every patient will cut 16 mm, or is there any specific criteria for that?
Sorry, ma'am.
Basically, it is not every patient you will cut 16 mm. It is always twice the gingival display you are having. If your gingival display must be 8 mm, that's why you have cut 16 mm. That is the reason of selecting 16 mm. Okay?
Yes, ma'am. Thank you, ma'am.
Thank you. We can move to the next one.
Good morning, ma'am and sir. Am I audible?
Yes, please. You can start.
Good morning, analyst. Today I'm going to present a topic, a poster on the topic computer guided implant surgery. So basically, guided surgery in implant therapy facilitates an optimal 3D implant planning and placement with respect to both anatomic and prosthetic parameters. Implants can also be placed in an ideal position, taking into considerations the critical anatomic structures such as nerves, arteries, and sinuses. Moving on to the case report, this is a case of a 19-year-old male patient who came to the department with chief complaint of missing upper front teeth. Patient had a history of a road traffic accident 3 years back, as a result of which he lost his anterior teeth. On examination, patient had missing 1-1-2-1 and root stump in relation to one region. The patient was using removable partial denture for the past 3 years, and on further examination, there was insufficient ridge which was evident in relation to upper anterior region. So basically, CBCT and intraoral scan were done for the anterior region, and it was concluded that implant should have a length of 13 mm and a width of 3.8 mm. The intraoral scan and the CBCT were merged using an implant planning software. The preoperative picture shows a root stump in relation to 1-2 region. A atraumatic extraction was done of RS was done using periodome. Then tooth supported guides were used through which drilling sequences were done. So the sutures were placed at the immediate implant site. This is because basically during the implant drilling sequence, the procured bones were placed around the implants in order to maintain the soft tissue stability. And then processes were placed after 2 weeks. As temporary restorations were placed after 2 weeks, and this shows an OPG after 2 weeks. So the main advantages of computer-guided implant surgery is that it is minimally invasive and it is more accurate, and it requires less number of appointments and less post-operative discomfort, and reduced time option for patients with strong anxiety. There are other disadvantages as well, which includes the complexity of the guided system. The sleeves in the surgical guide obstruct the irrigation to the drilling sequence, and also it is highly costly. And moving on to the conclusion, guided surgery with 3D planning and evaluation have opened the gates for safer, accurate implant placement. Further research is warranted to improvise the shortcomings of this guided system. Thank you.
Doctor, which computer-guided software you have used in this?
It's 3M implant planning software, ma'am.
Okay, you have enumerated so many advantages and disadvantages of this system, computer-guided system. So, so is it advisable to go for computer-aided surgeries in all implant cases? What is your viewpoint?
Ma'am, I would say it mainly depends upon the patient's requirement, because some patients might feel having strong anxiety for this implant procedures. With guided implant, it is more minimally invasive and it requires less number of appointments. And also with treatment, guided implants are more accurate when we compare to conventional, and the main advantage being this does not require, it's more like a flapless procedure, ma'am.
So you will be doing guided implant surgery based on patient anxiety levels. Patient is anxious,
not exactly, but also depending upon the case requirements also.
Yes, it is the case requirement. It's an ideal case and you're confident about that case, then I don't think computer-aided surgery is required in all implant cases. It is according to case requirement. Fine.
Okay, thank you.
And more so to the anatomic landmarks. For example, this was the right decision since it was an aesthetic zone. So the angulation had to be important here.
Had to be more.
Dr. Kaushalya, which system did you use for implants here?
The 3M for implants, it is Dio Navy implants. So for implants planning software, it's 3M implant planning softwares.
So besides that, have you heard of real-time navigation?
Sir, I'm
Real-time implant navigation.
not sure, sir.
Thank you.
Thank you, sir.
Good afternoon. Can I start, sir?
Sure.
Good afternoon, everybody. My poster is on the topic comparison of coronally advanced flap with and without laser deepithelialization, a case report. So as we all know, gingival recession is one of the most commonly encountered challenge to the periodontist, and it poses as an aesthetic concern to the patient. And coronally advanced flap and its modifications have been proposed in the literature for treatment of gingival recession. So the objective of this case study was to compare the outcomes of coronally advanced flap with and without laser deepithelialization in case of Miller's class 1 gingival recession. A 48-year-old male patient reported to the department with a bilateral class 1 gingival recession, and he was advised a split mouth coronally advanced procedure with and without laser deepithelialization, and its results were observed. So on moving on to the photographs, on the left side of the screen is the right side in which we did the laser deepithelialization procedure. On the right side is without laser deepithelialization. We placed a GTR membrane in the site without laser deepithelialization, and suturing at the copac was done, was placed. And after 2 weeks, the measurements revealed that a similar recession coverage was seen in both sites with and without laser deepithelialization. So the indications to use laser for deepithelialization is for the deepithelialization for autogenous grafts, for anterior root coverage site as it is more aesthetically pleasing, and in case of thin donor palatal sites, and also for deepithelialization of periodontal flaps. And the advantages of using lasers is that it has an enhanced wound healing of periodontal defects by blocking the downgrowth of epithelium into the healing of the periodontal wound, and it prevents the formation of a long junctional epithelial attachment, and gives a more aesthetic results. So moving on to the discussion, Lin et al. In 2018 first used this laser deepithelialization for the autogenous gingival graft for root coverage along with coronally advanced flap, and they concluded that this technique is easier, more predictable, and gives a excellent quality and quantity of tissue without the inclusion of undesirable submucosa and adipose tissue. And a randomized controlled trial by Ozilic et al. In 2015 inferred that the deepithelialization of free gingival graft using laser decreased post-operative morbidity when compared to the deepithelialization with blade. So to conclude, a clinically sound knowledge and proper treatment plan along with combination treatment approaches are needed for good results, and the future perspective of this study is that we have to include more cases to perform, and with a longer follow-up period is required to assess the effectiveness of this procedure. Thank you.
Can you tell me, Doc, what is the concept behind deepithelialization?
Ma'am, a concept of?
Why we need to deepithelize the tissue? What is the concept behind deepithelialization?
So this deepithelialization of tissue will actually reduce the surgical and the healing time, and it reduced post-operative complications in patients, and it also reduces the bleeding. So, yeah, so that's why and it also produces the removal of the submucous and the adipose tissues is also done, so which hinders the healing.
Okay.
Dr. Manomani, in your discussion, you have told about the studies where laser deepithelialization has been done.
Yes,
but
sir.
Mostly it has been done in cases where you are using free gingival autograft.
Yes.
But in your case, you are using a GTR material. So why did you use lasers? In gingival autografts, it's understandable that you are doing the deepithelialization of the outer surface. But what's the rationale behind using it here?
So the GTA membrane was placed only in the site in which we didn't do the de-epithelialization, sir. The de-epithelialization was done on the right side, and since already they've done a lot of cases with free gingival grafts, we thought like we could assess the results in when only de-epithelialization of the surgical site was done to assess if there is any improved results in that case.
So epithelium is present on which part of the flap?
On the outer parts, the re-epithelialization was done on the remnant epithelial attachment which was found on the bone. That aspect was removed using the laser. So.
Right. Okay, that will be all from my side. Thank you very much.
Thank you, sir.
And ma'am, we are right on time.
Yeah, thank you, Dr. Guru Prakash.
Thank you, ma'am. Thank you, ma'am.
Thank you. Bye.
We would like to thank both the chairpersons. Thank you so much.
Thank you, Suhani.
Thank you, Sohani.
For next session, we'll start at 1 p.m. now.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge, and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as a President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details and nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy.
Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
We can start the session.
Uh, a very good afternoon to one and all present here. I hope you all are safe and healthy. It's my immense pleasure to walk you through the 19th ISP PG convention, introduce you to the speakers and delegates that have come from all over the country today to share their knowledge and enhance our mental horizon. Going ahead with the proceedings of the convention on the behalf of ISP, we are proud to announce our chairperson for the session, and I welcome them for chairing the session. Our first chairperson is Dr. Vidushi Shekhan ma'am. Ma'am did her post-graduation from Kurukshetra University and master's from Pandit Bhagwat Dayal Sharma University of Health Science, Rohtak. Ma'am is currently working as an associate professor in the Department of Periodontology at SGT University, and ma'am is actively involved in academics as well as many national and international publications to her credit. Ma'am is also a reviewer in many dental journals, and ma'am is also pursuing PhD in periodontology. We welcome you, ma'am. Thank you so much. Then our next chairperson is Dr. Nandini Bhaskar ma'am. Ma'am did her graduation and post-graduation from Punjab Government Dental College, Amritsar, and is presently working as assistant professor in Department of Periodontology at Dr. Harwan Singh Judge Institute of Dental Science, Chandigarh. Ma'am has many national and international publications to her credit and is a reviewer of various dental journals. Ma'am also has been a member of boards of studies at Punjab University. We welcome you, ma'am. Thank you so much, Priya. Thank you. Then coming to the session, we have total 10 presentation in this session, and each presenter should have 5 minutes, 3 minutes for presentation and 2 minutes for question answering. So over to you, ma'am. Thank you.
Good afternoon, ma'am. Can I start presenting? Start. Ma'am, am I audible? You are audible. Start. Yes, you're audible. Good afternoon to one and all present here. My presentation for today is a case report on the regeneration of an intrabony defect. So periodontal regeneration has been long studied with numerous bone grafts and membranes. And this case report has evaluated the periodontal regeneration using the sticky bone concept on one quadrant and with the advanced platelet-rich fibrin on the other quadrant. So moving on to the first case, first quadrant, it was treated, as you can see, with the NOVA bone and an IPRF. So moving in sequence of the pictures, it is a preoperative picture followed by the preoperative radiograph. So an open flap debridement was done, and the NOVA bone putty was mixed with the IPRF, and the bone graft was placed in the defect site of 2.5 and 2.6 in the second quadrant. And this was then covered using the Heligite GTR membrane, and the suturing was done, followed by the Copac placement. Moving on to the first quadrant in the region of 1.5 and 1.6, on the contralateral side, the open flap debridement was done, followed by procurement of APRF, the membrane, and it was mixed with with an osteograft, and it was placed at the defect site of 1516, and it was sutured, and the Copac was placed. So moving on to the advantages of sticky bone. The graft becomes embedded in the matrix of the PRF when combined. So along with the bone graft material, the sticky bone provides a surge in growth factors. It provides good healing and initiating soft and hard tissue regeneration. It can also be molded or cut into the desired shape and can be packed easily at the site that is required to be regenerated. And the advantages of APRF are that it brings it has a lot of growth factors that it could provide to the regenerative site, and it might substitute as a good space maintainer with a proper resorption rate. So to conclude with the limitations of the study with the follow-up period, it can be said that the interbony defects can be treated with either the sticky bone concept or an APRF membrane and the bone graft. Thank you.
Preeti, you have not, I think, used anything for standardization of the X-ray?
No, ma'am.
Okay, and your post-op X-rays after?
Actually, I was able to follow up only with a 2-week period, ma'am, because it was a recently done study and the follow-up was lost because of the lockdown. So it was only a 2-week post-operative picture that I could take along with the RVG, ma'am.
Do you expect that after 2 weeks you are going to see any change in the X-ray?
Ma'am, not to a great degree, ma'am, because a proper bone regeneration can only be noticed from 4 to 6 months after regeneration, ma'am.
Then what is the use of taking an X-ray after 2 weeks?
Ma'am, it is to check if there can be a mild bone formation, ma'am. There's not a greater degree that is very appreciable, ma'am.
Okay. Dr. Vidushi, you can ask.
Dr. Preeti. Ma'am, have you logged in from 2 devices?
Yes, I have logged.
Yeah, so can you just mute one?
Hello?
Still, the same issue is there. Can you just mute one device?
Yes, I have muted. Okay, I'll check.
Can you log out from one device?
Yes, I'll do that.
Yeah.
Preeti, what is the difference between IPRF and APRF?
IPRF, it's the injectable platelet-rich fibrin, ma'am. So the process of making it is a rotation of 700 RPM in 3 minutes, ma'am. And the APRF is 1,300 RPMs at an 8-minute speed, ma'am. And also IPRF doesn't have, we don't coat the tubes, ma'am, with the tubes of centrifugation are not coated, ma'am, so it doesn't have.
It's okay, pretty okay. Thank you. Thank you so much. Next one.
Good afternoon, ma'am. Am I audible?
You're audible and start.
Okay. Good afternoon, everyone. Today I'll be presenting a case series of ectopic tooth eruption. So ectopic tooth is nothing but the teeth that develop displaced from their normal anatomical position. The cause can be either genetic or environmental factors. So today I'll be discussing about ectopic canine. So the prevalence of maxillary canine impaction or ectopic eruption is in general population is about 1 to 2%. So palatally displaced canine can occur twice as frequently as buccally placed canine. So this case series aims at evaluating the different management techniques that is used for correcting ectopically erupting canine who were patients who are undergoing orthodontic treatment. So the exposures were done using 3 techniques. That is, first is the double pedicle flap, where the flap was elevated and the canine was exposed and the bracket was placed and followed by the orthodontic treatment. The second one was using the conventional corticotomy procedure, where the corticotomy was done for the canine exposure, followed by the orthodontic treatment. So the third technique is the apically repositioned flap for the palatally impacted canine. The canine was exposed, and you can see as a post-operative picture that the canine was exposed and it was restored in the normal anatomical position. So the post-treatment records demonstrated adequate exposure of the displaced tooth and restoration of normal anatomy of canine with all the three techniques. Moving on to discussion, there were many studies was conducted to evaluate the differences in the periodontal health, the root length, and the aesthetics in the participants who had bilateral palatally displaced canine with which was exposed using different surgical technique. They compared the open technique with the closed technique. And during orthodontic treatment, it is important to maintain a healthy band of keratinized gingiva around the labally positioned canine. So a study that done by Boyd et al. Demonstrated that labally positioned canine, 2 to 3 mm of attached gingiva was created by using apically repositioned flap. And also there was a reduction in the gingival recession, inflammation, and loss of attachment. So the periodontal health was maintained. So in this case series, it concludes that the careful planning and management is needed for the exposure of ectopic canine. Thank you.
Okay. Like on what factors you can decide what what type of the surgery you will plan?
Depending on the how it is impacted, up to the mucogingival line, if how much is exposed to the environment, I mean the oral cavity. It can be either for maintaining the for labally placed canine, you can use a apically repositioned flap. So you can maintain the attached gingiva. That is important for the orthodontic movement.
Okay. And what was the response of the patient in this? Like, did you come across that patient was more comfortable in like one of these, or with every, like with all of them, the patient was equally comfortable?
For one case, there was a post-operative swelling and like bleeding was there. And it was managed like after 2 weeks we were managed. Hello.
Okay, thank you, Dr. Vidishi.
Yeah, sorry for the interruption. I have logged in from the other device. Sorry. So after retracting the canine, have you used it as a biomaterial? Have you heard about the dentin matrix grinder as a autograft also? You can use that tooth.
I'm not sure.
You have just extracted it and the ortho movement has been done, right?
Yeah, yes, ma'am.
It has been used as a autograft material also nowadays.
Okay.
Good afternoon, everyone. Am I audible, ma'am?
Yes, you are audible.
Yes, you're audible.
Good afternoon, ma'am. I'm going to present a case report on hereditary gingival fibromatosis. Hereditary gingival fibromatosis, which goes by other names such as elephantiasis gingivitis, familial elephantiasis, or the hereditary gingival fibromatosis, is a rare gingival lesion that presents as localized or generalized enlargement of attached gingiva, and it can present as an isolated feature or as a part of a syndrome. It is transmitted through autosomal dominant and recessive modes. And in this, we have used pedigree analysis to analyze the pattern of inheritance of hereditary gingival fibromatosis. Coming to the case proper, a 16-year-old female presented with a chief complaint of gingival swelling all over her mouth, causing difficulties in speaking and eating and obvious implications for her aesthetic appearance. No complaint of pain, bleeding, or halitosis. And the swelling was seen from past 4 to 5 years ago, and it was slowly progressive. Medical history, it was non-contributory, no history of any medications, and the patient presented with normal height, weight, and normal intelligence. And we have consulted a physician consult was also taken to see if it is an isolated form or if it is associated with any syndrome or genetic components. And then in family history, the same features were seen in the patient's mother and the brother. And in intraoral examination, we can see that there is generalized gingival enlargement covering present on almost all of the teeth, and it is diffuse bluish red in color, and we can see the pebble surfaces, and the gingiva is firm and leathery in consistency. Then later we have constructed a pedigree analysis, and we included the latest 3 generations of the family. And in this, only 3 members of the only 3 members presented with this hereditary gingival fibromatosis. The mother might be a singular isolated mutation, and she had passed these traits to her descendants, that is to her daughter and her son. And there was no history of consanguinity seen in the family. And then we have done a histological analysis by obtaining a incisional biopsy. And we can see that well-structured hyperkeratotic epithelium and a thin papilla. And in the connective tissue, we can see increased amount of collagen fibers and minute amount of inflammatory infiltrate. And with the help of medical history, family history, histological analysis, and rate of recurrence, we gave a diagnosis of hereditary gingival fibromatosis. And in the treatment plan, after LA administration, bleeding points were marked, and the excess tissue was removed by modified flap operation and gingivoplasty. And continuous link sutures were given, and the patient was followed for up to 15 months with a tri-monthly follow-up. And no recurrence of the lesion was seen, and the healing was uneventful. So the clinical significance of this case is the use of genetic analysis and how pedigree aided in the diagnosis. Thank you, ma'am.
Can you elaborate? You have written here that the tissue was removed by modified flap operation.
Yes, ma'am.
Can you elaborate that? What is modified flap operation?
Ma'am, it is basically a Kirkland flap operation, ma'am, or the access flap operation.
What was the pocket depth in this case?
Ma'am, pocket depth of 5 to 6 mm was seen, ma'am, in few of the areas.
And do you think that was true pocket or a false pocket?
True pocket, ma'am.
And in this case, the ortho brackets, these ortho treatment was started when, like?
Ma'am, actually the patient presented to our department with the braces, ma'am.
Okay. And in this photograph, there is no braces in the B photograph. And again, braces are there.
Ma'am, in B photograph is of mandible, ma'am, and A is of maxilla. The braces were present only on the maxillary anteriors, ma'am.
Not on the mandibular, huh?
No, ma'am. Only in the maxillary anteriors.
Do you think there can be a role of this?
Ma'am, usually the inflammatory gingival enlargement can be given as a differential diagnosis, ma'am, but given the patient's medical history and the histological analysis, so mostly we are leaning towards the hereditary gingival fibromatosis as a diagnosis, ma'am.
Okay, Dr. Vidushi, please.
Did you find any plaque or calculus deposition around the teeth?
Ma'am, it is not more, ma'am. We have found it, but it is in very minimal amount.
And for how long the patient is complaining of the gingival enlargement?
Ma'am, they first observed it 4 to 5 years back, ma'am, and it was slowly progressive. Now
and when was the ortho treatment started?
Ma'am, 2 years before she reported to our department, ma'am.
Okay. So it might be because of the ortho treatment also, no? If it started 3 years ago.
2 years, ma'am, seeing that, but the braces are present only in the 6.
Okay.
Hafsa, start. Dr. Hafsa, start.
Good afternoon, respected judges. Today I'll be presenting management of multiple gingival recession in lower mandibular teeth with free gingival graft in a shallow vestibule and inadequate width of attached gingiva. To introduce, gingival recession is defined as the apical migration of the marginal gingiva resulting in a root exposure. And gingival recession, it may be caused due to a number of factors, which includes bone anatomy, tooth position, orthodontic movement, improper tooth brushing, high frenal attachment, smoking, calculus, and when there is a presence of active periodontal lesion. Treatment of or management of the gingival recession is of importance as it may cause root caries, root hypersensitivity, as well as aesthetic problems. So various treatment modalities have been considered for the treatment of gingival recession, which may include free gingival graft, subepithelial connective tissue graft, coronally advanced flap, GTR, acellular dermal matrix. But in this case, it was also a presence of the inadequate width of attached gingiva. So in order to manage recession as well as the inadequate width of attached gingiva, we had done free gingival graft to cover the gingival recession as well as to manage the gingival recession. So coming to the proper case, a 36-year-old male patient had reported to the Department of Periodontology with the chief complaint of receding gums in relation to 3.1, 3.2, 4.1 and 4.2. And 3.1 and 3.2 had shown class 2 Miller's classification, gingival recession, whereas 3.3 and 3.2 and 4.2 had shown class 3 gingival recession. So the on the mandibular lower incisors, a tunneling technique was performed. 2 vertical incisions were given on 3.1, extending from 3.3 to 2.3, and a tunnel was prepared, and an FGG was harvested in the area, and circumferential and sutures were placed. Whereas so since I was having only 1 month follow-up, so 80% coverage or root coverage has seen in the 3.1, 3.2 as well as 4.1, 4.2.
Dr. Hafsa, follow-up is just for 1 month?
Yes, ma'am, because actually because of the lockdown reasons, I couldn't get back to the patient, and that is why the follow-up was only for a period of 1 month. Otherwise, we had planned for a period of 6 months, ma'am.
Okay. And did you use any stent to measure the recession?
Sorry, ma'am?
Did you use any stent to measure the recession?
Yes, ma'am. Yes, ma'am. We can in order to measure the depth of the recession, we have used a stent, ma'am. So the measurement was done from using a stent on the lower mandibular incisors, ma'am. 3.1 and 3.2 had shown a measurement of 5 mm, ma'am.
It's okay. And what was the scenario about trauma from occlusion?
Ma'am, trauma for occlusion, ma'am.
Yeah.
Ma'am, actually, we didn't there was no even though Fremitus test was done, there was negative results, ma'am. The patient didn't had any trauma from occlusion, ma'am. It may be because of the other factors that has led to the recession as well as inadequate width of gingiva, ma'am.
It's okay. एक ही question को इतना मत खींचो. Dr. Vidushi, please.
आपने यहाँ पर लिखा you have written 3 months respectively follow up, but you did for 1 month only.
Yes, ma'am.
In the slides you have written 3 months. Secondly, did you done any root modification procedure before doing? Okay, and you have not shown the photograph of the donor site also.
Ma'am, photograph of donor is there, ma'am. On the left side, ma'am. On the first quadrant, healing is done, ma'am. In the post of first month, ma'am. During the procedure, I might have missed that.
And you should take one photograph with the help of the probe showing the recession pre-operatively and the post-operatively.
Okay, ma'am.
Okay.
Yes, ma'am. Yes, ma'am.
Thank you.
Thank you, ma'am.
Next, please.
Ma'am, good afternoon, ma'am. Am I audible, ma'am?
You're audible, and please start.
Yeah, okay, ma'am. Yes, good afternoon to everyone. Today's my poster is on the topic pinhole technique, which is a minimally invasive technique for root coverage. As you know, minimally invasive technique helps in restoring health, function, and aesthetics of lost soft tissue. Is to accomplish the surgery in the most efficient manner with the fewest post-operative complication. And the pinhole surgical technique is another example of a recent advancement in minimally invasive soft tissue grafting surgery that combines specialized surgical instrumentation and the modification of a tunnel technique. Moving on to the case presentation here, 23-year-old male systematically healthy patient came with the department with the chief complaint of sensitivity in the upper left front tooth region. On intraoral examination, it reveals that the Miller's class 1 gingival recession in relation to 2-3 with a recession of 3 mm. After phase 1 therapy of scaling and root planing followed by the infiltration with the local anesthetic at the surgical site. A small pinhole of 2 to 3 mm diameter was placed in the mucobuccal fold using a Arbenz knife and followed by tunneling instruments, which is used to gain access through the pinhole in order to elevate the mucosal tissues in the apicocarinal directions. And then resorbable collagen strips are placed through the pinhole and pushed into the interdental papilla to assist and hold the new gingival in the position. After the complete mobilization of the entire mucogingival tissues was made until the tissues advanced coronally, and then the surgical site was covered with the periodontal dressing. This is 1 month post-operative view, with a clinical attachment gain of 2 mm is achieved. Moving on to the advantages of this pinhole technique is regeneration of mucogingival apparatus without scalpel incision, suture, and donor site, which in turn decreases the risk of the second surgical site and the graft exposure. Gives perfect aesthetic long-term results, which reduce the surgical duration, enhances the faster healing without scar formation, and then minimal post-operative complications. Moving on to the limitations, according to the lingual and palatal recession defects, and then areas with the severe bone loss where the outcome is less predictable, and contraindicated in the patients with the traumatic activities such as aggressive brushing and bruxism, and then heavy smoking, uncontrolled diabetic, uncontrolled or poorly controlled diabetes, and medication that can compromise the healing process, which could also interfere with the risk of post-operative complications. Moving on to the conclusion, pinhole surgical technique is one such novel technique which holds a promise as an minimally invasive, more predictable and more efficient, less time-consuming and cost-effective procedure for the root coverage in Miller's class 1 and class 2 recession defects. Thank you.
Can you name some other minimally invasive techniques for gingival coverage?
Ma'am, pouch and tunnel technique, ma'am, and then Vista, ma'am. These are the techniques we can use for the minimally invasive for the gingival root coverage, ma'am.
Okay, you used which material, which collagen material did you use?
Ma'am, resorbable collagen, it is BioGuide, ma'am.
And it contains which collagen?
Ma'am, second generation, ma'am, resorbable collagen membrane, ma'am.
Hey, that I know it's a resorbable collagen. I am asking what type of collagen. There are different types of collagen. It contains which type of collagen?
Ma'am, type 1 collagen, ma'am.
Only type 1?
Yeah.
What is the other name for pinhole technique?
Ma'am, other name, ma'am, pinhole surgical technique. That's how I have come across, ma'am. I don't know the other name.
Okay. And according to you, what is the major advantage of pinhole surgical technique as compared to your traditional autologous grafting?
Ma'am, mainly without any scalpel, elevating of flap, and then involving the donor site, which also risk the secondary exposure, ma'am, and then and also which reduces the working durability, ma'am, and then enhances the faster healing, ma'am, when compared to conventional method for root coverage, ma'am. And also minimum post-operative complications.
And that too, you don't have any second site of surgery also.
Yes, ma'am.
Dr. Vidushi? It's okay, beta. Thank you.
Thank you, ma'am. Thank you.
The next one, please. Start.
Good afternoon, ma'am. Diode lasers in routine periodontal practice. Diode lasers are one of the most commonly used lasers in dentistry owing to its compact design and cost effectiveness. They produce wavelengths ranging from approximately 810 nanometers to 980 nanometers, which makes them suitable for the soft tissue procedures and find their use in the periodontal practice. The aim of this case series is highlighting the efficacy of diode lasers for the various soft tissue procedures. The first case shows a vestibular deepening with the laser. On examination, it was found that the patient had a shallow vestibule and the width of attached gingiva was inadequate, which led to the recession. And Hence, the vestibuloplasty was planned in order to correct the shallow vestibule using the biolaser diode laser with a power setting of 1 watt in continuous mode. And the patient was recalled after 2 weeks for evaluation. Coming to the second case, the patient reported to the department with the chief complaint and difficulty in eating due to the soft tissue mass or overgrowth, which was seen in the area of the lower anteriors. On clinical assessment, solitary pedunculated gingival overgrowth in the mandibular anterior region with respect to 3.2 and 3.3 was observed, and the lesion was excised using the laser in a continuous mode with the power setting of 2 watt, and the excisional biopsy was done, giving the final diagnosis as a pyogenic granuloma. The third case in the series is that of the gingival depigmentation, and the gingival depigmentation displayed while smiling according to the Damit-Gupta oral pigmentation index was score 3, and the laser depigmentation was carried out for both maxillary and mandibular arches in contact mode with a power setting of 1.5 watt, and post-operative healing was adequate, and on examination after 2 weeks the healing was adequate. Summing up the case series, I would like to highlight the various advantages of the lasers, including hemostasis, which gives us a dry field to operate and better visualization and less post-operative swelling, leading to minimal post-operative pain and less need for LA, and making the procedures minimal to non-invasive. However, there is a risk of excessive tissue destruction, which can be seen by direct ablation if not used carefully. I would like to conclude the presentation by saying that diode lasers are simple, safe, efficient, and easy to use and provides improved patient comfort. Hence, lasers may be considered as a boon for dentistry. Thank you.
Did you use Copac in your first place? Copac dressing?
Yes, ma'am.
And are you sure that this post-op photograph is after 2 weeks only? The first case?
Ma'am, like 2 to 3 weeks in middle almost. Yes, ma'am.
Because I doubt, because healing after like laser, after 2 weeks, this type of picture, like is a tough thing.
Ma'am, we had given low level laser therapy also for healing. So the healing was.
What is that?
Ma'am, low level laser therapy is given at a low power, so that there is advanced healing of the tissues and inflammation is reduced.
Dr. Vidushi?
Yes. Hello.
Yes, ma'am.
You have done this with the laser. Do you think there is any difference between the healing after scalpel and laser?
Yes, ma'am.
What is the difference?
Ma'am, in the laser, when we did, there was a scab formation seen, and in the scalpel, it takes more time to heal, and as well as post-operative pain is also more, and discomfort is there.
And for how long the patient is experiencing this fibroma? What is the reason you have diagnosed?
Ma'am, a few months, like 2 to 3 months, she had mentioned it.
And before 2 to 3 months, it was absolutely fine. So what was your diagnosis? How it occurred?
Ma'am, it was basically due to irritation in that area because of very brushing extensively. So we had given a provisional diagnosis of pyogenic granuloma only, because we had done the radiograph also. So
okay.
Yes.
Okay. Thank you.
Okay.
Good afternoon, ma'am. Am I audible?
You're audible. Please start.
Good afternoon, everyone. So we are here to present a poster on the topic xenograft plus GTR, a boon in the treatment of intrabony defects. As we all know, periodontitis is an inflammatory disease. It causes a great deal of periodontal attachment loss and bone destruction. So the ultimate goal of any periodontal treatment is the regeneration of the lost periodontal structures, which can be obtained from your surgical and non-surgical periodontal therapies. So coming to intra-bony defects, there are many other treatment procedures like your open flap debridement with graft and with or without GTR. Then there are 4 majorly acceptable periodontal bone graft materials that are your autografts, allografts, alloblasts, and your xenografts. Coming to your xenografts, these are the graft materials that are obtained from the other species, for example, bovine, porcine, equine, coral, etc. So coming to the material that has been used in this case report is matrix sauce. It is a porcine-derived cancellous bone developed by Nova Bone India. It is an unorganic carbon apatite structure bone graft material. It is highly porous and has osteoconductive properties. And the particle size is 5 to 2 mm. So the aim of the present case report is to assess outcomes of matrix sauce in GTR in the treatment of an intra-bony defect. Coming to the case, a female patient aged 33 years visited to the Department of Periodontics with the chief complaint of loose teeth in her lower front tooth region since 7 to 8 months. On examination, there was RT2 gingival recession, the presence of exudation and a probing pocket depth of 13 mm with respect to 4-3 in the mesial aspect, and there was also a grade 2 mobility. The IOPA revealed that there was a radiolucency extending till the apical 1/3 in the mesial aspect of 4-3. So initially the phase 1 therapy was performed, but the pocket was still persistent and the vitality of the tooth was checked, which came out to be non-vital. So the patient was advised to undergo root canal treatment before starting the periodontal surgical therapy. So Kirkland flap procedure was performed. After the flap elevation, the defect was debrided and it was analyzed to be a one-wall defect. And then matrix sauce bone graft material was placed into the defect. The graft was pre-sutured, and then the GTR membrane was cut into appropriate size, and then the ProGuide GTR membrane was placed into the defect, and then horizontal matrix sutures were given and Popac was given. So after a 9-month follow-up with good patient compliance, clinically there was reduction in probing pocket depth and gain in cal, and the mobility was reduced to grade 1, and radiologically there was significant bone gain. So by this case report, we conclude that matrix sauce can be used with GTR, that can be a beneficial treatment approach in the management of periodontal intra-bony defects. Thank you.
You told that tooth was non-vital. According to what can be the reason in this case for the tooth being non-vital?
Ma'am, because the radiolucency extended till the apical 1/3 of the tooth, so maybe it can be a perio-endo lesion, primary perio and secondary endo lesion. So that might be the cause of non-vitality.
And you did not standardize your X-ray, no? That is very important to check the bone.
Yes, ma'am.
Otherwise, how can you say that like bone fill was there? Okay. Dr.
Okay.
What other methods can you use apart from the IOPA? Because IOPA is not a standardization technique. This is a 2D view, right?
Yes, ma'am. CBCT, we can take CBCT, ma'am, to analyze the bone fill.
And by using RVG grid method also you can take.
Okay.
How much bone gain do you have achieved? How much bone defect fill?
Ma'am,
have you checked for the bone gain?
There was no, ma'am.
Did you check any bone fill is there?
Ma'am, actually, we just checked in the IOPA, ma'am, and after that, because of this pandemic, the patient could not come frequently for the follow-up case.
By IOPA, what have you checked?
Ma'am,
you must have checked now how much of the bone formation is there. Earlier it was how much, and after your procedure it was how much, and what was the probing pocket depth after the procedure?
Ma'am, after
and
the
after
procedure,
how many months you should take the probing depth?
Ma'am, after the procedure, after the 9-month follow-up, the probing pocket depth was around 6 mm.
Is 6 mm? Okay.
And after the procedure, yes, ma'am. After the procedure, after 3 months, we have to check for the probing pocket depth.
Okay. Thank you.
Thank you.
start.
Good afternoon, respected judges. The topic of my today's poster presentation is clinical and radiographic assessment of immediate implant placed with simultaneous platelet-rich fibrin matrix and demineralized freeze-dried bone allograft, a case report. The placement of implants in fresh extraction socket is advocated in order to reduce the time required for the rehabilitation. Following tooth extraction, however, a socket often presents with the dimensions that may be considerably greater than the diameter of the conventional implants. And hence, following implant installation, a gap may occur in the marginal part of the recipient site. This horizontal bone defect is also known as jumping distance or gap, which is defined by Botticelli et al. In 2003 as the distance between the implant and the surrounding wall of the defect. It has been suggested by Harris et al. In 1983 that a close fit between the recipient site and the implant was of a critical importance for proper osseointegration, and a gap between bone and the implant of 0.5 mm or greater compromised the establishment of the acceptance of acceptable bone to implant contact. In order to overcome this limitation, number of grafts have been used in cases of immediate implants, and the present case addressed the same issue of the gap junction with the objective to evaluate the crestal bone changes and success of immediate implant with simultaneous grafting using PRFM and DFDBA. A 20-year-old male patient reported to the outpatient department of periodontics and implantology with the chief complaint of fractured tooth in the upper front region of jaw. The clinical and radiological examination revealed non-resolvable or non-restorable fracture with 1-1 and was indicated for extraction. In the view of patient's young age and anterior placement of the jaw, the immediate implant was considered as an option. The radiographic evaluation showed adequate bone apically to obtain the primary stability, acceptable safety zone, and no signs of periapical pathology. For the surgical management, automatic extraction was carried out using the periotomes and the elevators in order to preserve the socket walls, and following which a type 1 socket, according to the Elian et al. 2007, was obtained. The socket was thoroughly debrided, and drilling with using the sequential drill protocol was carried out. The implant selection was done based on the width and height of the root which was obtained. The implant was placed close to the lingual socket wall as indicated by Evans and Chen in 2008. For the immediate implant placement, and after which a 3 mm gap distance was obtained. This was filled with PRFM plot prepared using Meris's PRFM kit. For the results, at 6 months follow-up, a bone loss, a minimal bone loss of 0.25 mm, both nasally and distally, was obtained, and all threads were in contact with surrounding bone, showing adequate bone to implant contact. And hence, in the present case, at 6 month interval, it was concluded that the bone grafting with DFT-BA and PRFM can result in predictable outcome and can be considered as an option instead of other materials used.
What is the idea behind mixing PRF and DFT-DBA?
The idea behind using this is to like the PRFM to stabilize the PRFM plot there, and the DFDBA acts as a scaffold for the growth factors.
You don't have your pre-operative IOPA?
Pre-operative IOPA I could not get.
Okay. Dr. Vidushi?
Which implant system did you use?
And we had used Austin implant system.
Austin implant system. Have you done the CBCT?
Yes, ma'am. Pre-operative CBCT was done, and on the basis of the 3D images only, the planning was carried out.
Okay.
What are the other types of PRF?
Other types of PRF are TPRF, APRF, LPRF, then PRF, that is other leukocyte-rich PRF, and IPRF.
Okay. Why did not you choose about like TPRF?
Actually, the procurement of the TPRF tubes was a little difficult as it was to be procured from Turkey. So, due to which this was readily available from Bangalore. It is Deponed Biointelligence have provided us this material. So it was readily available, and it was a new material. So that's why we have chosen this material for the study.
Okay. Thank you.
Okay. Thank you.
Very good afternoon to everyone. Poster presentation on topic isolated recession is the management in aesthetic zone interdisciplinary approach. Coming to the introduction, alignment of the teeth usually happen by both skeletal and dental problems. As well as soft tissue will always follow the hard tissue. Some of the consequences are gingival recession, shallow vestibules, cover and frenal attachment, inadequate width of gingiva. The width of inadequate attached gingiva and keratinoid gingiva is a prerequisite to maintain the gingival health, which is still a debate in periodontal world. Where this paper poster explains the vestibular plastic, which accommodates all the prerequisites. Coming to the pre-op, 35-year-old female patient reported with the chief complaint of receding gums and lower front tooth region. On past dental history, patient underwent orthodontic treatment 5 years ago. On a clinical examination, probing pocket depth was 6 mm with class 2 gingival recession in relation to 3-1 and 4-1. On IOPA, where we can evidence the horizontal bone loss, which is extending middle third of the tooth. Under diagnosis, it is according to Cotlini and Bizarra in 2018, it is diagnosed as decreasing vestibular depth and aberrant frenal attachment, which is comes under mucogingival deformities and conditions around the teeth. Since it is an interdisciplinary approach, where initially endodontic treatment, patient referred to dependent endodontic for root treatment in relation to 3-1 and 4-1, followed by periodontal management under surgical phase. Initially, under non-surgical phase, where oral hygiene habit counseling instruction, which has been instructed, and under surgical phase, submucosal vestibuloplasty, which has been performed, extending from middle part of the midline of 3-2 till midline of 4-2, with scalpel 15 bed, a sharp incision which has been given parallel to the long axis of the teeth and perpendicular to the vestibule, and make sure the incision should not contact till the bone. After giving a perfect sharp dissection, muscle has been resecting all the muscle fibers and followed by placement of aluminum foil and periodontal tag to accelerate the injury. This is the only follow-up which has been shown evident that there is desired vestibular which is gained. Coming to the discussions, John Tull in 1960 who described first vestibular plastic because of its stability and readability. Success of this vestibular plastic depends mainly on adequate bone support and also free mobile tissue, so that deepening which can be achieved. Coming to the conclusion, the expected outcome result in closure of midline diastema with the resin bonded crown and adequate vestibular depth, which leads to maintenance in relation to 3-1-4-1 to aid in form, function, and aesthetics. Thank you.
What is your number that is you have not displayed on the poster? You must be allotted some number.
CRP 129.
129.
CR
129.
129.
Here the title is given isolated recession.
Yes, ma'am.
Right?
Isolated recession management, which is
and here you have written the vestibuloplasty or vestibule surgical approach.
As a periodontal, we have done vestibuloplasty since I have given vestibuloplasty as a period.
Okay. What are the disadvantages of shallow vestibule?
Shallow vestibule, which can be leads to poor oral hygiene and also phenum pull and inadequate width of attached gingiva, and also leading to recession also will be present.
Your voice is not clear.
Hello.
Yeah.
Shallow vestibule, which leads to inadequate width of attached gingiva, phenum pull, and also poor oral hygiene.
And why do you place this tin foil? If you not place it, what is the purpose of placing the tin foil over the vestibule?
Placement of tin foil mainly for enhancement of wound healing. It will accelerate the wound healing, and also it will prevent bacterial communication between outer and inner environment.
Nandini ma'am,
how tin foil will enhance the healing?
It will protect the outer and inner environment since there is no.
What are you planning to do with this patient after this?
Actually, since class 2 recession is there, we have planned to do closure of midline diastema with the resin bonded bridges in relation to 3-1 and 4-1, followed by maintenance.
Which recession is this?
Hello?
Class 1? What did you say?
Class 2 gingival recession.
Class 2 gingival recession. Okay. Thank you.
Good afternoon, ma'am.
Silk versus N-butyl cyanoacrylate versus nylon suture, a case report. So before taking you through my e-poster, I would like to quote that to heal a wound, you need to stop touching it. Now, we all know that post-periodontal flap surgery, the adaptation of flap to the root surface and healing by primary intention are our major goals. Now, healing by primary intention is preferred because it causes less scarring and less patient discomfort and more rapid healing occurs. Suturing and healing by primary intention goes hand in hand. Suturing has been used since its very inception. However, these days, N-butyl cyanoacrylate adhesive material is also being widely used. This brings us to the aim of our study, that is to evaluate and compare healing after closure in conventional periodontal flap surgery by clinical method using silk, nylon, and N-butyl cyanoacrylate adhesive material. So in a single patient, 3 quadrants were randomly assigned to the group A, B, and C. This randomization was carried out using a chit method. The group A, as seen in the first figure, had 30 multifilament silk suture being performed in maxillary right posteriors. Group B, second figure, it had 30 monofilament nylon suture being performed in mandibular right posteriors. And group C had N-butyl cyanoacrylate adhesive material being applied by using the De Bono et al. 1997 technique in mandibular left posteriors. So the clinical parameters measured were Turisky plaque index, modified Quigley index at baseline and 1 week. Then we had sulcus bleeding index and pocket probing depth being assessed at baseline and 1 month. And the early healing index by Watchett et al. 2003 was assessed at 1 week follow-up, 14th day, and 1 month. So through this clinical assessment, we could come to a result that there was a significant healing found in patients treated with N-butyl cyanoacrylate in mandibular left posteriors. Concluding, healing of periodontal flaps with N-butyl cyanoacrylate adhesive material results in uneventful and early healing by primary intention in comparison to silk and nylon sutures. Thank you.
Pooja, have you taken any healing index? How you have compared the healing between all these 3 groups?
Ma'am, early healing index by Watchett et al.
But you have not mentioned the reading score, anything here?
Yes, ma'am, I haven't mentioned the score, but we had assessed it.
You should mention how you have assessed the healing. Secondly, how many patients you have taken in each group? Only one patient?
Yes, ma'am, only in
one patient in each group?
Yes, ma'am.
How was your ease?
Sorry, ma'am?
This is from the patient point of view, the healing you have taken. What about the clinician ease of doing the suture?
Ma'am,
which one you find convenient?
Ma'am, actually, if we see by using silk suturing, because we've been using since a very long time, so it is easy for us to perform, easy to tie and everything. But on the other hand, the only disadvantage I found for N-butyl cyanoacrylate was that it is very technique sensitive.
And what is the difference between mono and multifilament? Any difference in the bacterial accumulation in these 2 sutures?
Yes, ma'am. In multifilament silk sutures, we can see the Viking effect. That is, it pulls bacteria and fluid accumulation is much more than in comparison to monofilament.
Okay. Nandini, ma'am.
Pooja, how long does cyanoacrylate stay?
Ma'am, within 10 seconds, its polymerization and everything occurs.
No, for how long it stays? Like it works for how long?
Ma'am, we
follow you place the suture, then you have it's your choice. You are going to remove the suture. And what is the scenario with the cyanoacrylate?
Ma'am, till 1 month, how much we followed the patient, it did stay there. And in 1 week also it was there. So if there was any excess material, so we just removed it in 1 week. But it was there till 1 month follow-up. And even now, the patient has no complaint. I mean, they have not contacted us with any complaint.
Okay, thanks so much. Thank you.
Thank you, ma'am.
Please start. Dr. Gaurav, please
Gaurav,
start.
you can start.
Dr. Gaurav, you can start.
Hello, ma'am.
Yeah, please start the presentation.
Hello. Good afternoon, ma'am. Today I will be presenting my poster that is titled as Effect of Antimicrobial Photo. Yes, ma'am, I'm starting, ma'am. Am I audible?
Yes.
Hello, ma'am.
Yes, you are audible.
Hello. Hello, ma'am. Hello. Hello.
You are audible. Please start. You are audible.
Hello.
You are audible. You can start, sir.
Hello, ma'am. I'm audible, ma'am.
Yes, you are audible. Please start. I think there is some network issue. In the meanwhile, we'll start the next presentation, or shall we wait?
No, I think start the next. We can wait.
Hello.
Hello. Am I audible, ma'am?
Yes, audible.
Good afternoon, ma'am. I am here to present my poster titled Laser, the Ray of Hope and It Beyond, a case series of clinical application. So, laser is a device that emits the electromagnetic radiation. Laser is an acronym word for light amplification by stimulated emission of radiation. Some applications of laser: gingiectomy, gingivoplasty, de-epithelialization of reflected flap, removal of granulation tissue, exposure of dental implants, peri-implantitis, incisional biopsy, crown lengthening procedure, depigmentation, and tissue biomodulation and wound healing. So, advantage of laser is increased coagulation of tissue that yield bloodless surgical field, reduce bacteremia, tissue surface sterilization, decrease swelling, decrease post-operative pain, faster healing, increase patient compliance. So my case report one is a female patient, age 24 years, is reported to Department of Periodontology with complaint of spacing in upper front teeth. On examination revealed diastema present with papilla penetrating type frenal attachment. Treatment: frenectomy done under local anesthesia with diode laser 19 nm 980 nm diode laser. Here is case report 2. A girl patient, age 40 year, reported to Department of Periodontology with complaint of fluctuant swelling on left side of lower lip. On examination revealed mucocele. Treatment: excision of mucocele under local anesthesia by use of 980 nm diode laser. In case report 3, a female patient 24 year reported to Department of Periodontology with complaint of difficulty in brushing. On examination, we revealed inadequate width of attached gingiva, inadequate vestibular depth. So treatment plan is vestibuloplasty under local anesthesia with 980 nm diode laser.
How did you check the width of attached gingiva?
Ma'am, by pull test, we restrict the lip and we mobile the lip. And some other method is the rolling on method. We use probe and roll incisal to labial cervical to incisal edge.
Recording in progress.
And what was the change in attached gingiva after vestibuloplasty? How much did you gain?
Attached gingiva, ma'am, width is increased.
How much?
Ma'am, before procedure, width is less than 2 mm. After procedure, we achieve the 2 to 3 mm.
Okay, what is low-level laser therapy?
Ma'am, in low-level laser therapy, we use very minimal voltage for biostimulation and for pain therapy.
Okay, thank you. Dr. Vidushi.
You should add the pre and post operative photographs of each case. No? You have not
Yes, ma'am.
added those. And pictures are very small. It should be enlarged, clearly visible. No? If you have done these cases.
Yes, ma'am.
Have you done any of these cases?
Yes, ma'am.
Okay. Then you should show it properly.
Yeah, ma'am.
Or you can limit the number, or you can present 1 or 2 cases, but that too beautifully placed, so that it's good to see. मैम आपने पूछना?
I think we can go back to the 11th presentation. The 11th one, Gaurav one.
Okay, ma'am. Okay. What is low level therapy?
In low level laser therapy, we use very minimal voltage for biostimulation and for pain therapy.
Good afternoon, ma'am. Today I will be presenting my poster that is titled as Effect of Antimicrobial Photodynamic Therapy as an Adjunct to Open Flap Debridement, open flap in a patient with severe chronic periodontitis. So we all know that microbial plaque is in microbial plaque and pathogens present within them is the main etiological reason for occurrence of periodontitis. In literature, we have come across various studies and various modalities that have already been advocated to get rid of these periodontal pathogens. So relatively new form of that is being recently published in recent publications is antimicrobial photodynamic therapy. And there are various studies of non-surgical periodontal therapy along with antimicrobial photodynamic therapy that has already proven to be beneficial. So in this current case report, we try to evaluate the additive effect of antimicrobial photodynamic therapy along with surgical periodontal therapy. So coming to the case report, here we have a female patient, 55 years old female patient with no systemic complaints, complaining of bleeding gums, came to our OPD with clinical evaluation. On clinical evaluation, there was pocket depth of more than 6 mm and clinical attachment loss of more than 5 mm. So we recorded all the clinical parameters and collected the plaque samples for microbial evaluation on the same day and on the 98th day of follow-up. Then the patients were performed with non-surgical periodontal therapy, and it was seen that pockets were still persistent. So we went for surgical periodontal therapy. In surgical periodontal therapy, after a complete debridement of the pockets and the sides of the site, then antimicrobial photodynamic therapy was performed for the patient while using methylene blue as a photosensitizer and 660 nanometer low power laser of diode laser. So after this, the flaps were sutured back and patients were recalled after 90 days for further evaluation. On 99, so coming to results part of it, what we found was on 90th day there was reduction in the count of microorganisms as well as there was reduction in the clinical parameters. So considering all these findings, we can conclude that antimicrobial photodynamic therapy can be used as for surgical therapy, but an extensive clinical research and extensive publication results studies are needed in this field so that we can establish APDT as an adjunctive treatment to open flap debridement. In this method, RT-PCR was done for the microbial evaluation for counting the red complex bacteria. Thank you.
Which microorganisms come under red complex bacteria?
There are majorly three microorganisms that come under that. That is Prophyromonas gingivalis, Tenderella forsythia, and Treponema denticola.
Okay, what is your take on using this? You used methylene blue. Which
yes,
dye did you use?
Yes, ma'am.
And what is your take on the cytotoxicity?
Ma'am, the family of these dye family of photosensitizers are being extensively used, have been extensively used in various treatment modalities like methylene blue, toluidine blue, and they have shown good tissue acceptance and very less amount of cytotoxic effect in regards to that.
Can you name some other dyes?
Ma'am, like toluidine blue we can use, ma'am, oro green we can use.
Dr. Vidushi?
Yes. How much is the reduction in the bacterial count?
Ma'am, as being only a single case here we presented here, so in that case, ma'am, when we count post-operative after 90 days, the count of P. gingivalis was reduced very drastically. I mean, for example, ma'am, if I still remember, it's like it was 3.3 10 to the power 11. It was there at the baseline. It reduced to around 10 to the power 2 only, ma'am. The count was reduced, but that was not in case of T. denticola and T. forsythia. The reduction was there, but not as much as P. gingivalis.
You did a single case?
Ma'am, actually, I have continued this case for my or more number of patients have been included in the later studies. I still am going on with this study, ma'am. So still not completed. This was a case
not complete.
Pilots kind of study for further study, ma'am.
Okay. Okay, got it.
Yes, ma'am. Thank you, ma'am.
Thank you.
Thank you all. As this was the last presentation for this session, I would like to thank chairperson for chairing the session. Thank you, ma'am. Now moving forward to sixth session. Here we have 10 presentation in this session, and so I would like to pronounce a chairperson for the session, Dr. Vidushi Shirkhan ma'am and Dr. Nandi Bhaskar ma'am. Welcome to ma'am. Welcome you all.
Thank you.
Thank you.
Over to you, ma'am.
Am I audible?
Yes, you are.
Yes, you're audible.
Good afternoon, one and all. The topic of my poster presentation is periodontal disease and adverse pregnancy outcomes. Periodontal diseases are a group of conditions that causes inflammation and destruction to the supporting structures of the teeth. Whereas the adverse pregnancy outcomes, which is experienced by roughly 30% of the women, includes preeclampsia, gestational hypertension, gestational diabetes, preterm delivery, delivery of low birth weight infant, and the recurrent miscarriage. The possible pathogenous mechanism behind this is explained by two mechanisms. The first is the direct mechanism, and the second is the indirect mechanism. In the direct mechanism, the microorganisms, that is the bacterial pathogens, along with their byproducts, they directly affect the fetoplacental unit through a hematogenous dissemination. Further, when they affect the fetoplacental unit, further they cause the placental inflammation, which causes the reduction in the growth inhibitors, and that leads to the low birth weight. There is other route, that is the ascending route, that is through the genitourinary tract. The second mechanism, that is the indirect mechanism. In indirect mechanism, it is mediated through the inflammatory mediators, which are present locally at the periodontal tissues and which directly affect the fetoplacental unit. And one is it circulates through the liver, increasing the systemic circulation by creating an acute phase response that further later impacts the fetoplacental unit, which leads to the inflammation via TLR4 activation, which produces the prostaglandin. Prostaglandin is responsible for inducing labor, and that is why the preterm birth. Now, favorable outcomes have come due to during recent studies, which has talked about the possible outcome of the periodontal disease and adverse pregnancy outcomes. Like Jovicato et al. Said that based on the limited volume and fair and good quality of evidence, a positive association between the maternal apical periodontitis and adverse periodontal outcomes has been observed. Tesholm et al., he said, the periodontal diseases may be one of the possible risk factors for the preterm low birth weight. Corbetella et al. Stated that they reported a low but existing association between the periodontitis and adverse pregnancy outcomes. Now, the treatment approach. The important factor in the treatment approach, the important consideration is the timing of the periodontal treatment. Currently, the treatment is administered in the second trimester, which means that in the first trimester, which means that there is likelihood of subgingival pathogens that the periodontal bacteria already seeds in the placenta. Therefore, there is no positive outcome on the adverse pregnancy outcome. Whereas what we need to follow is the future approach, that we need to do the periodontal treatment prior to the conception, which has stated that there is a good result, which leads to the normal term birth. The conclusion is evidences of the positive correlation was seen between the periodontal diseases and adverse pregnancy outcome. However, more precise studies with randomized clinical trials with sufficient follow-up period must be done to confirm the association. Thank you.
Who was the first one to document the association between periodontal disease and adverse pregnancy outcomes?
Ma'am, it was done in 1916, but I don't recall the name. I cannot recall the name.
It's your review article, no?
Yes, ma'am.
You have not done anything about it, like Anna. So you should know what is the review of literature then, Anna. Okay, and what do you mean by preterm low birth weight?
Preterm low birth weight is, according to WHO, it is considered that the babies less than 2,500 grams, they are called the low birth weight. And the preterm delivery means that is referred to the early delivery, that is before the 37-week delivery, before the 37 complete weeks. That is the referred to the early delivery.
But what causes the preterm low birth weight?
Ma'am, the mechanism that I explained, preterm low birth weight, like an indirect method, it was said that due to the inflammatory process, the end product, that is the prostaglandin, the inflammatory mediator, it leads to it is responsible for the inducing labor. That is what causes the preterm low birth weight.
How you are going to use this knowledge of your periodontal disease and adverse pregnancy outcome to be helpful in the society?
Ma'am, as this periodontal disease and adverse pregnancy outcome, the adverse pregnancy outcome is a global concern right now. There has not been any established, there is no established association, but it is possible association. But what we need to do is, being a oral health provider, what we need is, obviously periodontal disease is considered one of the risk factors. So our duty as an oral health provider is to prevent it. Like in the treatment approach, we talked about, we need to prevent it, like we need to do the treatment before the conception period, so that it can, the results could be better. Okay, we need to provide the knowledge.
Thank you.
Which trimester is safe for doing the treatment?
Ma'am, for non-surgical periodontal treatment, as in it is stated that all the trimester are okay, but in surgical statement, we do in second trimester.
Okay.
Next, please.
Please. Next presentation, please.
So, Varsha.
Hello, good afternoon, ma'am.
Good afternoon, we can start.
Good afternoon, ma'am.
Good afternoon, please start.
Ma'am, the topic of my poster is, it is a survey study, assessment of knowledge and awareness level about periodontal health among pregnant women. Ma'am, as pregnancy gingivitis is the most prevalent oral manifestation that is associated with pregnancy. So, ma'am, this study was, it was a cross-sectional study that was carried out by among 150 pregnant women who were reporting to the maternity ward. And this study was carried out with the help of an informed consent and a well-structured questionnaire, which was provided to the participants. so that we can assess their knowledge and attitude towards oral health care. And ma'am, the model of that questionnaire was the name of that patient, the age, their qualification, and their gestational age. And the assessment was based on two point Likert scale, like yes or no. And ma'am, the questions they were divided into three parts. Like the questions, first is related to their oral hygiene status, second is related to oral hygiene practices, and third was related to oral hygiene knowledge. And ma'am, we also used clinical parameters to assess their oral health. And the parameters used were gingival index by low and illness, and the plaque index by illness and low. And ma'am, according to the questions answered by study population and according to their oral health knowledge, we concluded that 91% of them, they had a poor oral health. 9% had good oral health, and 75% of the population didn't know that regular dental visits are important. And 72% of the population didn't know that poor oral health can affect the fetus. So, ma'am, after the survey, the discussion was like there are hormonal changes, and there are various vascular changes because of those hormonal changes, and these changes exaggerate the inflammatory response. If already the oral hygiene is poor, so these changes, they exaggerate the inflammatory response. And ma'am, there are several decades of major improvements in diagnostic and therapeutic systems also, but ma'am, uh, the survey, I concluded from this survey that overall the oral health of the female, that is very poor, and it needs to be further studied for their or proper oral hygiene, and for their best pregnancy outcomes. Thank you, ma'am.
What were your questions? How many questions were there in your questionnaire?
Ma'am, there were 17 questions, and they were divided into three parts.
Okay, that is not mentioned here, I think.
Ma'am, yes, questions are not mentioned.
Not mentioned the question, you have not mentioned that you have divided in three parts, you have not mentioned the result, just 4 points in the results.
Yes.
And what is the duration of your study?
Ma'am, that was 6 months.
That is also not mentioned, 6 months. Right. Okay. Nandini ma'am.
Did you get your questionnaire validated?
Yes, ma'am.
Did you get your questionnaire validated?
Yes, ma'am.
From where? And what about the sample size? How did you calculate your sample size?
Ma'am, my sample size was 150 pregnant women. 150.
How did you calculate?
Ma'am, it included all the females in, all the females, they were randomly selected. There was not like a trimester-wise study. All the females in all the.
But we have to decide the sample size based on some reasons, ना? ऐसे तो नहीं randomly आप उठा लोगे कि 150 या 200. There has to have some basis for the sample size for your any research study. कुछ किसी के लिए भी you need to have some reason for your sample size. किस basis पे incidence, prevalence, otherwise किसी study को आपने उठाया कि कहाँ से calculate किया? From where did you calculate? And the clinical parameters recorded were only gingival index and plaque index, huh?
Yes, ma'am.
How did you check plaque index?
Ma'am, plaque index, that was the illness and low, and I checked it with the help of an explorer. The explorer that has to be run across the tooth surfaces, and we have to check the tip of explorer, that how much plaque had accumulated on it.
Okay, thank you.
Thank you.
Hello, good afternoon, ma'am.
Start करो बेटा. Afternoon. Good afternoon. Start करिए.
Please start.
Yes, ma'am. The topic for my poster presentation is antimicrobial efficacy of various platelet concentrates. Autologous blood products are being used since the last decade for various regenerative procedures, as they are the storehouse of various growth factors. Recently, their antimicrobial actions have also come into light because of the presence of some amount of WBCs in them, and to a large extent due to the antimicrobial activity of platelets themselves. In the presentation, in this study, the 10 ml of blood was drawn, and
please switch on your video.
Ma'am, I'm not getting.
Okay, continue.
Yes, ma'am. Ma'am, in this study, 10 ml of blood was drawn from the patient. 3 ml was used for PRP preparation, 3 for PRF, and 3 for IPRF preparation. For PRP preparation, the blood was collected in a glass tube containing 3.2% sodium citrate and was what is that 100 RPM for 13 minutes. Upper half was discarded, and for the second round 200 RPM. It was Vortex for 200 RPM. For PRF, it was done for 3000 RPM for 10 minutes, and the blood that was taken was not taken in, like it contained no additive. Similarly, for 3 ml of IPRF, no additive. There was no additive in the glass tube, and it was centrifuged at 300 RPM for 3 minutes. To check the antimicrobial efficacy, agar plate was inoculated with bacterial strains. For that, the supragingival plaque sample was taken and was immediately transferred into 5 ml of saline and vortex at 5 minutes to obtain a uniform suspension. Later, 0.1 ml was used for to plate the agar. The agar plate was labeled as PRP, PRF, and IPRF, and then it was kept in an anaerobic condition for 24 hours, and the zone of inhibition was checked, and it showed that IPRF had the highest zone of inhibition.
What is the reason behind the antimicrobial activity of PRF?
Ma'am, it contained more like the larger number of platelets were there.
Is platelets related to the antimicrobial activity?
Ma'am, it says that this study actually we're doing this study because recently they've come to say that because of the presence of amount of WBCs, and like they have WBCs present in them, and that helps in the antimicrobial efficacy.
Okay. Ma'am, आप पूछ लीजिए.
Please trying to switch on your video.
Yes, ma'am. Ma'am, I'm not getting the.
What are the different type of PRF?
Ma'am, IPRF, TPRF.
That's it.
There are others. APRF.
Have you done any case using the PRF?
Ma'am, I will be conducting this as my thesis work. I have not done it as it.
You have not done?
No, ma'am.
Which machine you are having the centrifugation machine in your college? No idea. No?
No, ma'am.
You're planning to take this as your thesis topic?
Yes, ma'am. I'm planning to take this as my thesis topic.
Okay. Thank you.
Thank you.
Hello. Am I audible, ma'am?
Yeah, you can start, sir.
Good afternoon, ma'am. Today's my poster presentation topic is SARS-CoV coronavirus detection in gingival clavicular fluid. As you know, the coronavirus disease, the current outbreak of novel coronavirus that was first reported in Wuhan, China, on 31st December 2019. So, what basically the coronavirus disease is like is defined as the illness caused by a novel coronavirus, now called as severe acute respiratory syndrome, coronavirus 2. So this coronavirus is like which can be transmitted to human, which was confirmed on the 28th Jan 2020, and it is transmitted through the respiratory droplets through sneezing and the coughing. And the main entry of this main entry of route of like transmission transmission of this virus through the nasal and the oral opening. So as lots of research and studies is going for the like diagnosis and detection of the coronavirus by taking the oral and nasal samples. So what is as we are focusing on gingival clavicular fluid, that gingival clavicular fluid is inflammatory exudate derived from the periodontal tissue. So the composition of the GCF, it contains the blood, leukocytes, proteins, enzyme inflammatory mediators, cytokines are there. And there are certain methods of collections of this GCF are like by using the absorbing paper strips, which can put into the gingival crevices, and the micropipette, which can be put into the gingival sulcus to like collect the gingival clavicular fluid, and the private vested threads, which can be placed around the tooth. And there are some advantages as a diagnostic, as a diagnostic for GCF is like it is not very non-invasive procedure. It is very convenient to do. It is economical and it is safer to collect and very easy to for the sample collection method. So we have done this. I have seen some like research done on this that in from the COVID positive patient, we took the GCF's collection sample with the help of micropipette, and this collected samples, like 2 microliter of these samples is collected in the micropipette, and this sample gets like transferred to the microcentrifuge tubes, and gets like going for the RT-PCR for the results for the detection of the coronavirus. The result was that the gingival clavicular fluid volume collection is an appropriate approach, which was be proved to be reliable diagnostic indicator in COVID-19 disease diagnosis for the coming years. There are certain studies and researches given by Des Gupta and Mohindra ma'am that envelope gene and the of the SARS-CoV-19 can be detected in the GCF samples.
Did you yourself collected the GCF from the COVID positive patients?
No, ma'am. Actually, this is the my basic research. So I've seen the some research like review articles, ma'am.
So this is your as such a review article. Then why
Yes.
did not you talk about saliva?
Ma'am,
Like why you have written only detection in GCF?
I'm I have this topic like GCF, so I'm focusing on this only. And there are, ma'am, I mentioned these studies in which the as Dr. Gupta ma'am like compare the saliva and GCF, ma'am.
Did you go through these studies?
Yes,
That
ma'am.
is why I'm
Yes, ma'am.
asking.
Yes, ma'am.
What was they studied both saliva and GCF if you have gone through. What was the difference in the saliva and GCF findings?
Ma'am, there are like they have conducted the study on these certain patients. They have seen ki only 1% or 2% of difference between the saliva and the GCF sampling, ma'am. The detection of the virus.
What was the difference in the saliva and GCF samples? में क्या difference था? That was statistically significant or non-significant? If you have gone through the study, you might understand what I am asking.
Ma'am, it is, ma'am, significant, ma'am.
Which was better according to them?
Ma'am, saliva.
And what is the logic behind GCF? What can be a drawback for GCF? Okay, thank you. Dr. Vidushi, आप पूछिए.
You have presented a review based on the 2 articles, right?
Yes, ma'am.
There should be more articles. Okay, and plus the ma'am has said that you should mention also about the saliva. You have just picked up GCF from these studies. You have so, matlab in 2 articles, in review articles also you have not compiled them properly. And if you're presenting some review, there should be enough literature for that. Okay.
Am I audible, ma'am?
Yeah.
Yes, please start.
Okay, good afternoon, everyone. Today I'm going to present 3D printing application in periodontics. So, three-dimensional printing, it is used in periodontics with the focus being on regeneration in research and printed guided for aesthetic gingival correction. And there are various printing techniques which find application in tissue regeneration based on the requirement of the defect area. Hence, it would be a good approach to print a 3D model which simulate the gum, periodontal tissue, and defect to develop the correct proprioception and the skill operating the patient. As the term 3D printing described as a manufacturing approach that build the object one layer by layer and also described as a rapid prototyping. So 3D printing processing, which include first acquisition of the 3D printing patient model, which may be a physical model or digital model, creating design STL file, which include model, application, prosthesis, design in CAD software, then preparing the model for printing. In this, the structure is sliced to create a stack of layer. Then 3D printing, slice data is sent to the printer and where the material laid down layer by layer. Then post-processing techniques. Uh, so in dentistry, it can be used to create patient model, which can be helpful in treatment of planning for orthodontic and prosthodontic appliances. For periodontists, clinical application of periodontics include first guided bone or tissue regeneration by bioresorbable or scaffold technique. Then purpose of scaffold is to promote the formation of bone, periodontal ligament, and the cementum. Then in case of socket preservation, then sinus bone augmentation, then guided implant placement, and patient education model. So advantages of 3D printing, which include cost reduction, minimum or less waste, then reduce production time and enhancement or competitive advantage, and reduce errors, compatibility, and production on the demand. So I conclude that it would be a good approach to print 3D model to overcome the shortcoming of 2D images and to develop the correct proprioception and the skill before operating the patient, as well as to educate the patient, and also has huge impact on the regenerative periodontics with the little material waste, and it is more accurate.
What are the different techniques of 3D printing?
Ma'am, there are different types of printer which include in 3D printing, like stereolithography, direct light processing, fuse deposition modeling, then inkjet powder printing, select laser sintering, and direct metal laser sintering.
Okay. And is it cost effective or not?
Yes, ma'am. Sometimes it is cost effective.
Sometimes.
And the main disadvantage of 3D printing is at certain level it is costly.
Have you seen
but
a
it is
Have you seen a 3D printer?
What, ma'am?
Have you seen a 3D printer?
No, ma'am.
Okay. Thank you.
What is your say on the 3D printing? Is it beneficial or the upcoming in future trend? And how many labs are doing this 3D printing nowadays? Do you know any lab?
Yes, ma'am. It is beneficial, and 3D printing mostly used in metro cities like Mumbai, Delhi. But in smaller cities, there is no.
What is the future perspective of the 3D printing in Peru?
Ma'am, it is used in future. It is mostly used in guided implant placement and in socket preservation techniques.
Okay. Thank you.
Thank you, ma'am.
Yes. Ma'am, am I audible?
You're audible. Start, please.
Yes, you're
Yes.
audible.
Yeah. Good afternoon, everyone. Topic for my today's presentation is evaluation of efficacy of extraoral aerosol suction in reducing aerosol contamination during oral prophylaxis. As we all know that the clinical dentistry poses an exposure risk to dental professionals and the patients largely due to the generation of aerosols, which can produce airborne particulates contaminated with virus, bacteria, fungi, and blood. To ensure both the patient safety and the patient and the dentist safety, it is necessary to use methods that limit aerosol inhalation and droplet splatter, which can be done using an extraoral aerosol suction device. Therefore, this study was conducted to investigate the efficacy of extraoral aerosol suction in reducing the splatter contamination. Coming on to the materials and methods, the study was conducted in the Department of Periodontology using a mannequin head. Full mode supragingival scaling was carried out using an ultrasonic scaler at high frequency on a jaw set containing acrylic teeth. Diluted citric acid solution was connected to the water lines of the dental chair. Extraoral aerosol suction device was placed at a 5 o'clock position at maximum flow capacity at about 15 to 20 centimeters from the teeth. Then the universal indicator paper, which is also called as the litmus paper, was placed in different locations, mainly on the operatory, that is the floor of the clinic, and over the clinician and the assistant. In general, we know that the litmus paper turns a red color when it gets into contact with the acidic solution. Similarly, here, when the citric acid splatter falls on the litmus paper, we can appreciate the chromatic color change from yellow color to red color. Uh, um, yellow to red color. Then the entire procedure is carried out twice. Initially, it is done with aerosol suction device, and then it is performed without aerosol suction device. Coming on to the results, we can see that the patient apron was the most contaminated surface when compared to everything, and the second most affected was the surfaces of the dental chair. And the results were analyzed in terms of frequency and intensity of contamination. There was 25% reduction in the frequency of contamination seen. There was 25% reduction in the frequency of contamination in the operatory, but not much of difference was seen in the over the clinician and the assistant. And similar, but then there was significant reduction in the intensity of contamination. We can see that 66% of reduction was seen in the operatory, 33% of reduction was seen in the clinician, and 50% reduction was seen in the assistant. Thus, I conclude by saying that the usage of extraoral suction device has major role in reducing the splatter contamination, and it helps in reducing the risk of dental professionals.
What is the difference between aerosol and splatter?
Aerosol are minute particles which spread in the air, which has a diameter of like less than 10 micrometer. Splatter is like it can be like water droplets kind of like, uh, yeah, which can splatter can settle down easily on the floor, but aerosol it can spread in the air also.
And that is why we are more worried about aerosols rather than splatter. Splatters
Yes.
are heavier compared to aerosols. So splatters usually settle down.
Yes.
Okay.
Yeah.
Thank you. मैम आप पूछ लीजिए.
How did you check for the contamination between the different areas, and how have you assessed this? Any microbiological data have you
Uh,
taken?
no, ma'am. I didn't do anything related to culture studies or which microbial contamination was there. It was just the spread of contamination was evaluated using a litmus paper, and I did it with visual inspection only, ma'am.
Okay. So you have not put any picture of that.
Uh, like this in the middle picture, that litmus it was not very clear, but that
Yeah.
red color, the color change from yellow to red can be appreciated in this case.
But I am not able to appreciate. As few drops of red is visible, but not very much clear. That picture should be clear.
Yes, ma'am.
Okay.
Yes, ma'am.
Why you have used limited number of litmus paper strips? Might have increased, right?
No, actually it was placed everywhere on the operatory floor, and in this picture, like assistant's face shield was contaminated more when compared to the clinicians, that I have mentioned. But other that picture I can't include that, since the poster was
There is a
there was
lot
no
of
space in the poster.
but if there is a lot of spacing between your litmus strips. अगर पास में रखते size would have been more, it would have been more easily appreciable. जैसे मैम कह रहे हैं कि it's true that we are not like it is so much appreciable that we can plainly say yes, it turned red. No? So even if the size would have been more, it would have been more clear. Okay, thank you.
Yes. Yes,
Yeah.
ma'am.
Thanks. Thank you.
Okay.
Am I audible?
Yes.
Good afternoon to all. I'm here to present a poster on evaluation and comparison of periodontal risk with 3 different risk assessment models among adults aged 30 to 60 years. Risk assessment goes beyond identification of a disease, extending its spectrum to factors that influence disease progression. Thus, it improves clinical decision making, reduce the need for complex periodontal therapy, improve treatment outcome, and ultimately reduce the cost of oral health care. But unmethodical assessment of risk without the use of a model can cause inter-examiner variability, and it can be complex and time consuming. Hence, several risk assessment models are proposed. So my aim was to evaluate and compare periodontal risk of subjects using periodontal risk assessment, modified periodontal risk assessment, and the simplified method for the periodontal risk assessment models. So coming on to the first model, which is called as periodontal risk assessment or the hexagonal risk diagram, which was given by Lang and Trinity in the year 2003. This risk assessment model is based on a multifactorial graphic, which is composed of 6 vectors representing a combination of 6 clinical and systemic environmental factors to predict risk and classifies the patient as low, moderate, and high risk profiles. So the diagram includes a percentage of bleeding on probing sites, number of residual pockets which is greater than or equal to 5 millimeter, number of teeth lost, percentage of alveolar bone loss in relation to the patient's age, systemic and genetic predisposition, which includes interleukin 1 gene polymorphism, diabetes, cardiovascular diseases, and then environmental factors like tobacco usage. And aggregate of these factors are added, and the individualized sum total risk for each profile is patient is calculated. Coming on to the second model, which is called as the modified periodontal risk assessment, which is given by Chandra in the year 2007. It is also based on the hexagonal risk diagram, with the difference that here diabetes and smoking, which is considered to be risk factors, are considered separately, and risk determinants like stress and socioeconomic status are also considered to be separately. Here, the difference is that alveolar attachment loss per age is calculated instead of bone loss per age. Now, coming on to the simplified method or the UNIFY method, which stands for University of Ferrara, which is given by Thromboli and co-workers in 2009. This method uses 5 different parameters like smoking status, diabetic status, number of sites with pocket depth greater than or equal to 5 millimeter, bleeding on probing, and bone loss per age. Here, each score is given. Each parameter is given a score called parameter score, and the total of all the parameter score is calculated, which is called as risk score. And based on risk score, patients are classified into low risk, low medium risk, medium high risk, and high risk. And in my study, 30 patients who reported to the outpatient clinic in periodontology department was recruited, and a thorough periodontal evaluation was carried out. 14 females and 16 by females, and the results are given in the pie chart. So to conclude that, what I saw is that all three models were equally effective and can be useful tools for predicting disease progression. Here, MPRA considers greater number of parameters than the PRA. Even though it was like that, there were no statistically significant differences existing between them. And the Unified method categorizes patients into 5 different categories, and criteria used for assessment were different. Thank you.
Why did you select 30 subjects?
Based on the the data is a categorical method, ma'am, and I used chi-square test in analyzing the samples. So,
okay, what is PRC?
Periodontal risk calculator, which was given by Page et al, ma'am.
And what are
It is
the,
another different based on a software.
and what are the key risk parameters for that? Do you know?
I'm not sure, ma'am. But the bleeding and probing pocket depth were all calculated in most of the periodontal risk assessment, ma'am.
Okay, thank you.
Thank you.
Out of these 3 methods, which one you find convenient?
Actually, I personally I believe modified PRA to be better, because they have considered risk factors and risk assessment separately. Because in the original model, which was given by Lang and Trinity, the cumulative status of the patient is considered. The present status of patient's systemic disease is not given importance. But here, based on the diabetic status as well as smoking status, the risk factors are given good importance in this case.
Okay, thank you.
Thank you so much.
Good afternoon to all. Am I audible?
Yeah,
Yes,
audible, please start.
Yeah, my topic for my poster presentation is Blue M Gel, a revolution
Please
against...
switch on your video.
It's on.
Continue.
Yeah. My topic of presentation is Blue M Gel, a revolution against periodontitis. What is periodontitis? Periodontitis is a multifactorial chronic inflammatory disease associated with altered dental biofilm that causes the progressive destruction of the supporting tissues of the teeth. Now, what Blue M Gel is, it is developed in 2017 by Peter Job. He's an oral maxillofacial, and what Blue M Gel does is specially designed by a team of implantologists, oral surgeon, and dentists. The gel contains an extra high concentration of active oxygen. This means that the retention of the said oxygen is increased in the mouth. The mechanism of action, what Blue M Gel is controlled delivery of active oxygen, that is hydrogen peroxide, to the site of the treatment, in which saline reacts with sodium perborates, which convert into sodium perborate, which converts sodium and borate, and hydroperoxide is released. Now this hydroperoxide again reacts with the saline, which in turn the saline is now in the oral cavities compared to saliva. Now when this react with hydrogen peroxide, it releases nice oxygen. Now, as per applications in dentistry, Blue M Gel helps in healing of wounds in mouth, thereby prevent and reduce bleeding gums, periodontitis, periimplantitis, wounds after extraction of implants, chemotherapy, wounds caused by dentures, pockets around the teeth and implant. From this, what I conclude is to conclude Blue M Gel can be caused as a reliable option for various dental procedures, as a oxygen releasing capacity of a Blue M Gel helps in pocket reduction, faster wound healing, and also it helps in a decrement of colonial forming units. Hence, it can be used as an adjunct to mechanical debridement and also can be used as an adjunctive to local delivery agent. Further studies will help to illuminate the effectiveness of Blue M Gel against the periodontal diseases. Thank you, ma'am.
You used this only in one patient?
Yes, ma'am. This is my thesis cases, and since the corona phase is on, so I did a pilot study, and in that I saw the. Sorry, ma'am.
Your photographs in which you are putting this gel into a syringe.
I'm sorry, I couldn't hear you.
Whose photograph is this? Is it your in which the gel is being
No,
put
no,
in?
ma'am. It's not mine. It's not mine. It's from the site of oral care.
What is what is the drawback in this?
The quantity, ma'am. If you put because the site of administration, the quantity requires
If
nearly
you have been
0.1 ml.
you have been using this on the patient, then you have to wear the gloves. You cannot simply put
Yes,
it in the syringe and then you can keep it in the pocket. Hello? Okay.
true, ma'am. True.
What is the cost of this gel?
Ma'am, experimental costs for experiments, the tube is cost for 1500 rupees, and for consumers, it is cost 2000 rupees.
Okay. Thank you. Ma'am, आप पूछ लीजिए.
Yeah, you're going to take up this as your thesis topic. You're
Yes,
planning
ma'am.
to take. So what all
Yes,
parameters you are including to check what are the healing index, how you're checking?
ma'am, bleeding on probing, pocket depth, clinical attachment level, those are the parameters. Gingival index also. Now it is a comparative study between two gels. One is placentrix gels and one is Bluem gel.
One is
So
blue
since
M gel and other is
placentrix, human placental
Placentrix.
extract, yes,
Okay. And you are going to compare these clinical parameters.
as per my thesis studies.
Okay. In the pocket depth of how much pocket depth?
My mild pockets is in 4 to 7 mm, 4 to 7 mm.
7 mm is mild. Okay. Thank you.
Hello, good afternoon, ma'am. Am I audible?
Yes, you're audible.
I'm not able to start my video, ma'am. The host has disabled. Yeah. Good afternoon, everyone. My poster topic is on periodontal station measure of stress among day and night shift workers on the salivary cortisol level, which is a clinical biochemical study. So, stress describes a destructive notion which has bearing on one's physical or mental health. It also increases the propensity to periodontal disease. So, how this stress is related to periodontal disease is based on two mechanisms. One is the psychosocial stress, in which based on the adequate coping or inadequate coping. The stress is based into most different types: psychosocial, physical, emotional, and etc. So when there is stimulation of the activation of central nervous system, the hypothalamus, and the autonomic nervous system, this will induce the pituitary hormone secretion, which is nothing but the adrenocorticotropic releasing hormone, which will with the help of adrenal cortex, there is a release of the cortisol. This cortisol, which is the stress hormone, will depress the cellular immune response. So due to this post-altered cellular immune response, there is a increased chance of infection, which will lead to periodontal disease. And the another mechanism is based on the behavioral change of the individual, which will lead to increase in the smoking habit, which also has an influence on periodontal disease. And due to the behavioral change, there is inadequate oral hygiene maintenance and poor compliance, which will lead to increase the colonization of bacterial load. So, and then due to the behavioral change, there is overeating, which lead to increased amount of cortisol fat diet. So this will lead to the impairment in the immunity, which will lead to the periodontal infection and periodontal disease. So the aim of the study is to evaluate the stress and salivary cortisol level on the periodontal status among day and night shift workers. So the materials and methods are: the age group is from 25 to 50 years. The group one, two groups have been separated, in which group one are 35 patients, day workers, and group two is 35 night shift workers. And the parameters evaluated are the stress level, that is DAS score 21 questionnaire survey, which is nothing but depression, anxiety, stress score level score, and the salivary cortisol level, which is measured with the use of ELISA. The clinical parameters are the CAL, PPD, and oral hygiene index. The exclusion criteria are the patients who are under the corticosteroid therapy, antibiotic therapy, and who are patients undergone periodontal treatment, and who are patients with pregnancy and lactation. So the results we concluded where the intergroup comparison was done with the T-square test, in which group 1 and group 2, they compared the cortisol level, in which we have achieved the increased amount of cortisol level in group 2, that is night shift workers.
And in case of intergroup comparison of stress level based on the DAS score 21 questionnaire survey, the group 2 patients, again, the night shift workers have increased amount of stress level based on the DAS score. And they have compared the salivary cortisol level with the clinical parameters based on group 1 and group 2 individuals, in which in case of group 2 individuals, there is increased amount of pocket depth, CAL, and some amount of very mild correlation between the overall aging index. So they concluded the study that the cortisol level was increased in the night shift workers with increased amount of stress and periodontal condition. So to conclude that stress is most the risk factor for the periodontal disease and its condition. Thank you.
Why did not you choose about GCF?
Ma'am, since I went to a factory, ma'am, for collecting the sample, not in the college, it's a baseline study. I went to a factory for a day. I went on a day and find the day shift workers 35%, and night I went again to above. I went to a night shift worker. So EC collection was saliva there rather than GCF, ma'am.
And did you collect stimulated or unstimulated saliva?
I collected unstimulated saliva only.
Why? And on what basis you decided the number of the patients, 35 in each group?
There is 35 is group 1 is day shift, ma'am, morning shift workers, and group 2 is night shift workers.
Okay, on what basis did you decide the number? 35. Okay, thank you.
Okay.
Ma'am, आप पूछ लीजिए please.
Yes. So what is your say why the stress is more in the night workers? What is the logical reason behind this?
They don't have adequate sleep.
Have you
and
inquired about their sleep time?
No, ma'am, I didn't inquire about.
Then how do you know that they don't have adequate sleep? What can be the other reasons? Okay. Okay.
Okay.
Thank you.
Thank you.
Thank you. As this was the last presentation for this session, I would like to express our sincere thanks to our chairperson, Dr. Vidushi ma'am and Dr. Nandini ma'am for giving excellent coverage and who spared time for her busiest, from her busy schedule to graceful session. We thank you for being with us, ma'am. Thank you so much, ma'am.
Thank you. Thank you so much, Priya. Thank you, everyone.
Thank you.
Thank you, Dr. Vidushi.
Thank you, ma'am. Thank you, Nandini ma'am.
Thank you so much.
Thank you, Nandini ma'am. Thank you, Vidushi ma'am.
Thank you. Thanks a lot. Thank you.
Now
Thank
we
you,
will
ISP.
convene after the short break. Thank you.
We can start the introduction.
Very good morning to one and all present here. It's my immense pleasure to walk you through the 19th ISP PG convention to introduce you to the speakers and delegates that have come from all over the country today to share their knowledge and enhance our mental horizon. Going ahead with the proceedings of the convention, on the behalf of ISP, we are proud to announce our chairperson for the session, and I welcome them for chairing the session. So our first chairperson for the session is Dr. Komal Puri. Ma'am completed her graduation in 2007 and her post-graduation in 2012. Since then, she is actively involved in academics and is a reader in the Department of Pedontology, Institute of Dental Sciences and Technology, Modinagar. Ma'am is also a consultant periodontist as various reputed dental clinics. She has many publications in both national and international journals, and she is the author of a few books. Ma'am is also a reviewer and an editorial board member to the reputed national and international journals related to the pedontology field. Welcome, ma'am. So our next chairperson is Dr. Shweta Shud. Ma'am did her post-graduation from graduation from BRS Institute of Dental Science in 2002 and post-graduation from DAV Dental College, Yamunanagar in 2006. Ma'am has been working as a senior assistant professor in the Department of Periodontology at Dr. Harwan Singh Judge Institute of Dental Science at Punjab University, Chandigarh. Ma'am has authored and co-authored for more than 20 articles in many national and international journals. She is also a reviewer in many dental journals. She has presented many papers, posters, and also chaired many scientific sessions at various national and international conferences. She also has been working in many projects funded by Department of Science and Technology, Chandigarh. We welcome you, ma'am.
Thank you, Priya, and good afternoon, everyone.
In this session, we have 10 presentations, and each presentation should have 5 minutes, 3 minutes for presentation and 2 minutes for. Over to you, ma'am.
Good afternoon, ma'am. Shall I start?
Yes, Dr. Kalyani, you can begin.
Yes. Good afternoon, ma'am. Today my poster, it is a review of the antibacterial effect of hydrogen water on plaque in chronic periodontitis patient. Periodontitis, it is an inflammatory disease which is initiated by microorganisms and results in destruction of the tissue surrounding the tooth, and eventually it leads to the tooth loss. Now, as we know, various mechanical and chemical products are there so as to reduce the microbial load in the plaque. But nowadays, various researches are being conducted to such natural agents with antibacterial effect as a supplement for the chemical method of plaque control. Hydrogen water is considered to be one of those natural agents which has antibacterial, anti-inflammatory, and potent antioxidative activity as it reduces the oxidative stress. Now, there are various studies have been conducted on the antibacterial effect of hydrogen. Up till date, almost 300 articles are being published and studies have been done on this. There are various modes are there for the preparation of hydrogen water. Some of this can be mentioned. Some studies, they have used hydrogen water preparation as it can be dissolved. Electrolyzed hydrogen water can be dissolved in the pure water, or by dissolving hydrogen in water under high pressure, or by the use of hydrogen gas releasing agents. Like if magnesium it is reacted with water, it will lead to the production of magnesium hydroxide ions, as well as hydrogen will be produced. So, and other mode of preparation of hydrogen water is by the use of commercially available bottles. So in the commercially available bottles, at the base of these bottles, electrodes are attached. When distilled water is infused in these bottles, and the power plug is on, electrolysis occurs in water in about 3 seconds. Due to electrolysis, hydrogen is formed at the cathode in about 5 minutes. Various studies have been done to study the exact mechanism of action of the molecular hydrogen. How does it act on the plaque and the bacteria? So Kim et al. In his study, he conducted his study to determine the effect of hydrogen water on streptococcal biofilm, that is mutant streptococci. As we know, mutant streptococci, Streptococcus mitis and Streptococcus sorbinus, they are mainly responsible for the initiation of plaque formation and caries activation. So mutant streptococci, they synthesizes extracellular polysaccharide from the sucrose with the help of the enzyme glucosyl transferase. With the help of glucosyl transferase and extracellular polysaccharide, it binds to the tooth surface with the help of glucan binding proteins. Now what happens is hydrogen, it downregulates the activity of glucosyl transferase and hence prevents the binding of the mutant streptococci to the tooth surface. Next study, Zhang et al. He conducted his study on mice to study the effect of hydrogen water on the depressive behavior on mice. In his study, he concluded that hydrogen water suppresses the production of pro-inflammatory mediators by inhibiting the activation of P38 and nuclear factor kappa beta. Similarly, Osawa et al. In his study, as we know, reactive oxygen species, they are produced excuse me, ma'am, I'm not able to see the timer here.
Timer is over. It's just for 3 minutes. You need to present it only for 3 minutes.
Ma'am, I was not able to see the timer here.
Okay, you continue.
Okay, ma'am. Thank you, ma'am. Ma'am, Osawa, in his study, he studied reactive oxygen species. It is produced when the neutrophils, they are produced by neutrophils as a normal immune response against the bacterial pathogens. Now, the level of reactive oxygen species, it is maintained by antioxidants. But if the homeostasis between antioxidant and reactive oxygen species is broken down, it leads to the production of oxidative stress, and excessive oxidative stress may create damage to DNA, proteins, and lipids. So, in his study, he mentioned that hydrogen ions successfully scavenges hydroxyl ions and converts it into hydrogen and other hydrogen atom. So hence he concluded that hydrogen reduces the cytotoxic oxygen radical and serves as a novel antioxidant. Lee et al. In his study, he concluded that hydrogen water also shows antibacterial effect on Actinobacillus actinomycetum comitans, F. nucleatum, P. gingivalis, which are considered to be the red complex organisms, P. gingivalis, T. denticola, for causation of plaque and calculus. Hydrogen atom molecule also modulates intracellular signal transduction system. There are various modes of consumption of hydrogen water. In various studies, they have mentioned different modes of consumption, like breathing or drinking water. Mainly, hydrogen water is consumed by drinking water or by oral rinses. Hydrogen water on gingiva. Kosciuszko Tomofeevil has mentioned that hydrogen water is beneficial in suppressing
Your
the
time is
progression
up.
of periodontitis by decreasing the.
Your time was 3 minutes and it's now more than 5 minutes. So I think you need to stop now.
Okay, ma'am.
Okay, Dr. Kalyani?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay, can you tell me any study wherein hydrogen water has been used to decontaminate the implant surfaces in cases of implantitis, periimplantitis? Very latest studies?
No, ma'am, I have not seen about this study. I have not seen, ma'am. Latest study I have seen on antibacterial effect on chronic periodontitis patient, ma'am.
Okay. Over to you, Dr. Komal.
How do you what are the different modes in which this hydrogen water is given to the patient?
Ma'am, it can be either given by drinking, patient can drink it, or oral rinses can be done, or aerosol inhalation can be done of that, or inhalation hydrogen gas can be inhaled also. Inhalation
Is it available
of hydrogen
commercially?
gas. Hydrogen sticks are also available, through which hydrogen water bottles are available, ma'am, through which hydrogen water is made, and aerosol inhalators are also available.
Is there any side effect of this hydrogen water?
Ma'am, according to US Drug and Food Administration, they have considered hydrogen to be safe for drinking purposes, and as considered for hydrogen gas inhalation, it is safe. But if hydrogen gas is inhaled in excessive amount, it may lead to oxygen deprived environment, which may lead to dizziness and unconsciousness. But as considered of hydrogen water, it is comparatively safer to be used.
What is hyponatremia?
Hyponatremia means, ma'am, decrease in oxygen content.
Natremia.
Nitrogen oxygen level decrease.
No.
Deprived oxygen atmosphere.
Read about it. It's one of the side effects of the hydrogen water. Okay.
Okay.
Thank you. Next,
Thank
please.
you,
Am I audible, ma'am? Am I
Yes,
audible,
please.
ma'am?
Start.
Good afternoon, esteemed faculty members. My topic of poster is recent advances in imaging technologies in implant industry. Diagnostic imaging is critical to pre-surgical treatment planning and success of implants. Various imaging modalities may aid in the placing or placement of implants in an appropriate location with relative ease and obtain a predictable outcome. These imaging modalities include analog imaging modalities, 3D imaging modalities, and the recent advancements. I'll be talking about the recent ones. CBCT, that is cone beam computed tomography, it is the gold standard for imaging oral and maxillofacial area. CBCT gives a three-dimensional view of anatomy and pathology. It uses a cone-shaped source of ionizing radiation in a 2D area detector fixed on a rotating gantry to acquire multiple sequential projection images in a complete one scan around the area of interest. The radiation dose for this is about 45 to 477 microsievert units, and the voltage is around 80 to 100 kilovolt peak. The advantages of CBCT is that we have a predetermined dimension of the implant, so selection of right sized implant for an optimal support, and it also provides a precision of placement of implant in the bone, proper orientation of implant, and prevents implant penetration into the sinus. And if there is associated structure like any nerve is present over there, we can simply we know the location of the that areas that structure, so we can, in a way, we can prevent injury to that area. So now coming to simplants, simplants are basically based upon computed tomography principle only, but this is a software basically. So in this, the clinician can plan on a computed corrected placement of dental implant with respect to position and aesthetics in 3D plane. And I have mentioned Noble Guide also. It is prosthetic driven treatment planning and guided implant surgery. It offers guided pilot drilling and fully guided implant insertion. Basically, it is mostly industrially produced surgical template that fits in, and it is made according to a plan. And there is a company called Noble Guide R which produces this Noble Guide. Now, CT scan. CT scan is a series of X-ray images taken from different angles and uses the computer processing to create cross-sectional images or slices of skeletal muscle, bone, visceral organs, and brain and other tissues. Now, the difference between CT scan is and CBCT is a modification of CT only. It works on the principle of CT only, but the radiation dose in case of CT scan is much more. That is around about 2000 microsievert units. So I'll conclude with that various modalities are available for implant site imaging. The technique should be adopted according to the case and clinician's ability to interpret the image required. Thank you so much. Have a nice day. Stay safe.
Dr. Sakshi?
Yes, ma'am.
What is the difference between CBCT and DentaScan?
Ma'am, CBCT, it works on the principle of CT computed tomography only. There is basically this is a 3D imaging technology in which we have a plane 3D plane which is operated along the patient's head, and the area detector is a 2D plane. 2D the area detector is a 2D plane, and it is fixed on a rotating gantry. It is in case of CBCT, there is a more pronounced or more visualization effect of the images, like they are more pronounced. Images are the quality of the image is better in case of CBCT. And moreover, we have a predetermined idea of the implant size also. So, and in a way, we can protect the adjacent structures present over there, because we have an idea that this structure is present over there.
And regarding radiation exposure?
Yes, ma'am. Radiation exposure in case of this CBCT, it is round about 45 to 477 microsievert unit, and there are two basically doses: absorption doses, absorption organ, absorbed organ dose, and effective organ dose. In case of this CBCT, and ma'am, I don't know much about dental scan.
Okay. Over to you, Dr. Komal.
Dr. Sakshi,
Ma'am.
what is image noise?
Image noise is not, it is not some kind of noise, no, it is kind of distortion of the image, overlapping of the image, that is image noise.
And how do you reduce it?
Sorry.
Thank you.
Am I audible, ma'am?
Yes, please start.
Can I go ahead?
Yes, start please.
Thank you. A warm welcome to everyone. My name is Nilav Krishnan and my topic is tissue engineering, a boon in periodontal regeneration. We know that plant grows from seed, but how many of us know that damaged tissue or even lost tissue can be regenerated? My answer is yes, by the procedure of tissue engineering. Tissue engineering is an interdisciplinary field that applies the principle of engineering and the life science towards the development of biological substitute that restore or improve tissue function. Tissue engineering is most complex process in our body. This approach involves three key elements as mentioned in tissue engineering triads: progenitor cell, signaling molecules or growth factor, and scaffold, progenitor cell or stem cell. These are undifferentiated totipotent, pluripotent, or multipotent cell derived from pulp, periodontal ligament, impacted third molar, or dental lamina, and even exfoliating deciduous tooth also. Signaling molecules or growth factor. These are regulatory substances that stimulate cell growth, proliferation, and differentiation. Example are platelet-derived growth factor, fibroblast growth factor. Scaffold. Scaffold is an artificial structure capable of supporting 3D tissue formation and serves as a delivery vehicles for growth factor. It serves as a framework which maintains the shape of defect. Biomaterials used as scaffold are ceramic, natural polymers, and synthetic polyester. Advantage of tissue engineering is that it is minimally invasive and reduce the risk of infection as the cell are autologous. Coming to the evaluation, well-defined preclinical models are needed to be further investigate the true potential of growth factor, cost effectiveness, and risk benefit needs to be studied more. We have potential challenges also, like understanding molecules and signaling pathway, culture condition, and immune rejection often after administration of stem cell. But we also have prospects for improved method for gene delivery cells. It would be right to say that tissue engineering has enlarged our vision and thus made the fascination of being able to achieve regeneration of a periodontal complex in its entirety a reality. Thank you, ma'am.
Okay. Can you tell us something about 3D scaffolds?
In the process of in the process of tissue engineering, it is important to formulate tissue 3D tissue formation to three-dimensional tissue formation to formulate the defective site.
Can you name any of these scaffolds?
Scaffolds are that is natural polymers and the synthetic polyester, just like chitosan, or ceramic that is hydroxyapatite, or the beta tricalcium phosphate.
Okay, what should be the prerequisite for these scaffolds?
It is an artificial structure capable of supporting 3D tissue formation. serves as a delivery vehicles mainly.
Okay, over to you, Dr. Komal.
What are the different types of stem cells?
Stems. It is stem cell are from impacted third molar, and second is from exfoliating deciduous tooth also, and dental
No, I'm
lamina.
asking what are the different types? Okay, David. Can you name any bone graft that contain growth factors?
Fibroblast growth factor.
No, commercially available bone graft. Thank you. Next, please.
Thank you.
Am I audible, ma'am?
Yes.
Good afternoon, everyone. Today, my topic for poster presentation is assessment of cytogenic damage in stage 3 grade B periodontitis with and without type 2 diabetes mellitus by a micronucleus test. DNA and cells of human body are constantly in threat of exposure to oxidative stress. The overproduction of reactive oxygen species can cause oxidative damage to large number of molecules, including DNA, chromosome, and has been associated with the pathogenesis of disorders like diabetes mellitus and periodontitis. So micronuclei is a small extranuclear DNA particle formed when chromosome fragments lag behind and fail to include in main nucleus of daughter cells during the cell division. So it indicates that some genotoxicity or a DNA damage happened. So micronuclei test is basically a test of buccal epithelial cells, and it is a minimally invasive method for monitoring the genetic damage, cell death, and genotoxicity. So the aim of the study was to determine the cytogenic damage in healthy patients with periodontitis and diabetes, and patients with periodontitis without diabetes. And the subjects who are pregnant, alcoholics, smokers, and with systemic disease were excluded from the study. And coming to the procedure, using a wooden spatula or plastic spatula from the side of the cheek, the exfoliated buccal epithelial cells were collected and fixed and spread on a slide and fixed using 80% ethanol. And after that, slide was placed in HCl for 60 degrees Celsius for 30 minutes, and it's rinsed with distilled water for 3 minutes, and again strained with the main reagent, Schiff's reagent, for the fusing reaction. And after that, after drying it, it was stained with 1% light green stain for 30 minutes and observed under light microscope. So the results observed was the presence of the micronuclei was for 55% in group 3, that is the group with diabetes and periodontitis, and it was 42% in group 3, where it was periodontitis without diabetes, compared to the healthy group. So this micronuclei basically indicates the damage, where other apoptosis indicators like binucleated cells, karyorrhexis, and pycnosis was also observed in the slides. So basically 30 cells per slide was observed. So the study, it was concluded that the presence of micronuclei was more in the group with diabetes and periodontitis, which indicates the association of oxidative damage, oxidative stress to DNA damage in those patients. So this can be used as this micronucleus test can be used as a marker for the assessment of the genotoxicity or DNA damage. Thank you, ma'am.
Okay. Dr. Shruti?
Yes, ma'am.
Can these tests be used to assess the success of periodontal therapy?
Ma'am, there are certain limitations for this test, ma'am. Like inter-examiner variability can happen, ma'am. during the methodology also, ma'am, during staining procedure also, many variations can happen, ma'am. And as such, no studies how they have assessed, ma'am, in cross-section studies, the presence of micronuclein periodontitis patients and diabetes patients. But after therapy, none of the studies have been assessed, ma'am.
That is after therapy, whether there is any reduction in the oxidative stress. That such studies are not there.
Not
But
there,
it-
ma'am.
Okay. Okay. Over to you, Dr. Komal.
Was cytogenic damage because of the periodontitis or diabetes? How did you confirm that? What about the confounding factors?
Yes, ma'am. Since both diabetes and periodontitis is a inflammatory disease which can lead to oxidative stress, yes, ma'am, it is difficult. Determine which one caused is difficult, ma'am. Because both.
And
Yes,
what was your healthy group?
Ma'am, without both without diabetes and periodontitis, ma'am. Healthy group, 15 individuals.
And what about non-periodontitis plus diabetes?
Ma'am, in total 45 subjects, ma'am. 15 in the healthy group, 15 in the periodontitis and diabetes group, and 15 in the periodontitis group without diabetes, ma'am.
Okay, thank you.
Thank you.
Hello. Ma'am, am I audible?
Yes, please start.
A very good afternoon to one and all. I'm presenting a poster on herbal medicines in periodontology. Reason being, we all know that periodontal diseases are amongst the most prevalent disease affecting 60 to 90% of the population worldwide. Conventionally, periodontal diseases are treated with non-surgical and surgical treatment modalities along with various drugs to improve on the outcomes. Conventional drugs have side effects, may lead to development of drug resistance and superbugs and are expensive. Herbal medicines are medicines derived from plants. Herbal medicines are claimed to have therapeutic effects, are easily available, have little side effects, and are also economical. So, herbal medicines are being used in periodontology for their various beneficial properties like anti-plaque, host modulating, immune boosting, and antioxidant properties. Beginning with aloe vera, it has anti-inflammatory, immune boosting, and antimicrobial properties. A.R. Pradeep et al. In 2015 conducted a study in which they concluded that adjunctive use of local drug delivery of aloe vera gel in comparison with placebo gel resulted in decrease in plaque index, probing depth, and gain in clinical attachment level in patients with type 2 diabetes mellitus and periodontitis. Curcumin is a polyphenol extracted from the root of turmeric and possesses multifunctional properties, mainly antibacterial. Suzuki et al. In 2016 stated that curcumin inhibits the growth of periodontopathic bacteria and may be a potent agent for preventing periodontal diseases. Neem, it has good efficacy in the treatment of periodontal disease. A systematic review in 2015 by K. Dhingra and K.L. Vandana stated that neem-based herbal mouth rinse improves gingival health and plaque control. Clove oil or its extract, along with various other herbs, were found to be effective in improving the gingival status and resulted in significant improvement in the clinical parameters. Chamomile possesses antimicrobial and anti-inflammatory properties. Chamomile mouth rinse can be used as an effective adjunct during non-surgical periodontal therapy for chronic periodontitis, as stated by Ashish Agarwal et al. In 2020. Mira is a sap-like substance, comes out of cuts in the bark of trees and are members of Comphiro species. It helps in decreases the inflammation. In 2015, EID-HA conducted a study and stated that Mira extract has promising antibacterial effects as well as biofilm inhibition of Streptococcus mutans. Hence, herbal medicines present an attractive potential as an adjunct to mechanical periodontal therapy. Concluding with, future of herbal medicines in periodontics is promising, but further research needs to be done for evidence-based use of herbal medicines. Thank you.
Okay, Dr. Kanchan, any limitations of these herbal medicines?
Yes, ma'am. The problem with herbal medicines is that more longitudinal studies needs to be carried out. And ma'am, the substantivity of herbal medicines have not been researched as yet.
Okay, any other limitation or drawback?
Ma'am, Ma'am, the more clinical trials need to be done on herbal medicines.
Okay, any herbal preparation used as a local drug delivery?
Yes, ma'am. Cure Next, it is derived from curcumin.
Okay, what is the concentration of curcumin in that?
Ma'am, it is 0.8. Ma'am, I'm not sure, but
Okay. Okay, over to you, Dr. Komal.
Thank you. What about the toxicity of the herbal products?
ma'am, it has a very low toxicity as compared to the conventional drugs.
How do you know? Are there any studies related to it?
Ma'am, there are not, ma'am, currently it is still under research that herbal
How's the antibacterial effect of product tested?
Antibacterial effect
of all these herbal products? How is it tested?
Ma'am, studies have been conducted by various authors like Anirban ma'am, a study was conducted by Anirban Chatterjee et al. In 2013, which stated that antibacterial effect of neem.
No, how is it checked? How do you check? If you have like a curcumin mouthwash or anything, so how is it checked?
Ma'am, microbiological study along with a clinical and a microbiological study.
Okay, thank you.
Thank you, ma'am.
Please switch on your camera. We can't see you.
Ma'am, am I audible?
Yes, please start.
Good afternoon, everyone. This is Dr. Kamakshi, and I'm presenting a poster on DentaScan third eye of implants. As we all know, for centuries, we all have struggled to find answers to the complex problems associated with tooth loss. Dental implants have made it possible to quite an extent. Since implant surgery is exacting, the procedure demands a lot of precision to be followed while executing it. The anatomy of the specified area plays an important role in the success or the failure of the implant. And that's why one needs to do a careful preoperative planning to avoid failure. Imaging of the dentofacial structure is one of the areas that has been influenced over the last 2 decades. DentaScan play an important role. DentaScan is actually a specially developed computerized reformatting program that has been developed to obtain true cross-sections of the mandible and the maxilla. The purpose behind taking DentaScan is that whenever we are going for endoosseous dental implants or subperiosteal implants, we can have a preoperative planning and idea. Its indications are preoperative evaluation of implants, evaluate late complications like peri-implantitis to find out any encroachment of mandibular canal, maxillary sinus, or nasal cavity during implant placement. It helps in measuring bone quantity and volume. It also helps in giving multiplanar reformation of images. It provides information about the proximity of vital structure and very low radiation doses and minimum extra cost is required. However, no doubt, it also helps in measuring the bone quantity and volume, but when it comes to bone quality, we require additional age. Moreover, it doesn't provide us the true size and we require compensation for magnification. There is a limited range of diagnostic grayscale and it's quite expensive when compared to conventional radiography. Here I conclude with this. DentaScan may play a wider role in evaluating lesions of the mandible and maxilla. It provides valuable information in the assessment of bone anatomy before and after implant surgery. Thank you.
Okay, which is better, DentaScan or CBCT?
Ma'am, as per study, CBCT is better than DentaScan.
Why? What is the reason?
Ma'am, CBCT requires a low radiation doses when compared to DentaScan.
Can you just tell me the doses?
Ma'am, as such, I don't remember the exact number, but.
Okay, any other limitation of DentaScan?
Ma'am, dentist can actually, when it provides the images, it generally of larger size. So we require additional aids to minimize it.
Which additional aids you are talking of?
Ma'am, like in the form of the voxels, we need to reduce the image magnification.
Okay. Anything else?
No, ma'am.
Okay. Over to you, Dr. Komal.
Yes. Do you know about the artifacts that may interfere with the diagnostic process performed on the data? What is the difference in between the dentist scan and CBCT in relation to the artifacts?
Ma'am, there's a difference in the voxel sizes.
Hmm.
It's 25 mm in the dentist scan and 15 to 20 in CBCT.
What is the gold standard to measure the alveolar bone in implants?
Ma'am, we generally prefer for radiograph.
No, the gold standard. In radio, when you compare radiographs, obviously CBCT is better, right?
Yes, ma'am.
But which is the gold standard? Thank you. Next, please.
Good afternoon, everyone. Ma'am, am I audible?
Yes, you are visible and audible. Please start.
Yes. Good afternoon, everyone. My topic is local drug delivery system in periodontics. Generally, commonly available drugs are there is first local drug delivery system introduced by Dr. Max Goodson in 1961. There are a lot of local drug delivery system is available in different forms, fiber, gels, and injectable systems, and strip and compacts. They are commonly available drugs are tetracycline, minocycline, doxycycline, metronidazole, and chlorhexidine. They are talking about tetracycline. Is available form is periodontal AB plus. It is a fiber containing drug, brown color fibers. Tetracycline hydrochloride 2% is content is 25 per milligram of collagen fibers. It is biodegradable. It is release of drugs in 7 days. In another drug is minocycline. Minocycline is available form is aristine. Aristine is composition of minocycline 1 mg plus HCl. It is a white color in gel system. It is a biodegradable microsphere. It is a release of drug in 7 days. In another drug, minocycline, dentomycin is 2% weight in water. It is a yellow, slightly yellow in color. This injectable system is drug. And another drug is doxycycline. Doxycycline is available to syringe system is Artidox. Is a one syringe is containing of aristine in 450 milligram. It is in composition of 36.7% of polydilated lactic acid and dissolved in 63.3% of methyl to pyridone. And another syringe is containing of 50 milligram of doxycycline hyclolate. It is available in 42.2% milligram of doxycycline. Another drug is metronidazole. It is Eligol. It is available brand is Eligol. It is metronidazole benzoate. It is content of 25 milligram in 25% milligram. It is injectable system, slight yellow in color. It a composition of mixture of the glyceride, monoleate, and triglyceride. It is brown in yellow in color. It is a real drug release in 7 days period. It is another drug is chlorhexidine. It is most commonly used in the oldest in periodontal. This is called as a periochip. This periochip is a orange brown rectangular chip. It is in placement in the periodontal pocket. It is a diameter of 4 into 5 into 0.35 millimeter. It is each chip weight is 6.9 milligram. Each chip containing 2.5 milligram of chlorhexidine gluconate. It is dislodgement in 7 days of period of periodontal pocket.
Okay, what are the advantages of using local drug delivery?
Ma'am, compared to systemic drug delivery, yes, lot of uses there, ma'am. Compared to systemic, and there is advantages to SRP curate than placement of local drugs, ma'am.
I didn't get you. How is it better than systemic antibiotics?
Ma'am, systemic they can't properly provide in the concentration of local area, ma'am, compared to local drug delivery.
So what is the concentration of perio chip?
Ma'am, 2.5 milligram in each chip, ma'am.
No, what is its how much drug would be available in the GCF in first 48 hours, and then after that, after 7 to 10 days? Have you studied all this?
1500 microliter in liter, ma'am. 24 hours first.
First 24 hours, how much?
1500, ma'am, microliters.
Okay, any disadvantages or limitations of these agents?
Ma'am, improper placement, improper technique for sensitive patients.
Any other limitation?
And systemic conditions, ma'am. Some systemic infective conditions.
We cannot use them.
Yes, ma'am. On that time, we are using systemic drugs, ma'am.
Okay, over to you, Dr. Komal.
Thank you. Can you name a new? Can you name a few latest LDD materials?
Ma'am, Aristine, Aristoduct.
No, the newer ones. The apart from the ones which we have already spoken about.
Ma'am, Aristox, ma'am. In periodontal epiphysis. Tetracycline drug is, ma'am. Ariston.
These are older ones now. Any newer ones?
I don't know.
Okay. Now, is LDD an adjunct to scaling or root planing, or can it be used alone?
Ma'am, with SRP curate, scaling and root planing, ma'am.
It cannot be used alone?
Ma'am, sometimes it's not effective for compared to scaling and root planing, ma'am. It's best for scaling and root planing is more.
How is a local drug delivery agent retained in the sulcus?
Ma'am?
How is any LDD agent retained in the sulcus?
Sometimes some LDD also retained on this area, ma'am. On that area, some gingival irritation or some.
Okay. Thank you. Next, please.
I'm audible, ma'am?
Yes, please start.
Good afternoon, everyone. My poster topic is today for clinical relevance on periodontal phenotype in surgical periodontal therapy. The periodontal phenotype includes gingival phenotype, that is gingival thickness and keratinized tissue width, and it's include the buccal bone plate. The treatment plan and treatment response and prognosis of periodontal procedure vary between teeth with different phenotypes. The knowledge and assessment of periodontal phenotype has become an important resume in clinical decision making. In several dental procedures, the gingival tissue is subjected to clinical and surgical insult, and both the phenotype respond differently to them. In the event of inflammation or any other type of insult, soft tissue in a thick biotype respond by more fibrotic changes and pocket formation. On the other hand, the thin biotype, we see more inflammatory changes and recession of gingiva. Patients with thin biotype are more vulnerable to connective tissue loss and epithelial damage. Thus, they need special atraumatic treatment and oral hygiene technique. We can measure the periodontal biotype or phenotype in different techniques. There are invasive or non-invasive technique. In non-invasive technique, we use the visible technique and the probe transparency. According to 2017 World Workshop, the periodontal transparency is 80% reproducibility and is an accurate method, a non-invasive method for check the gingival thickness. In non-invasive method, the direct method, we use the endodontic spreader and check the thickness of gingival thickness, and we can use the CBCT for more accurate dimensions of soft tissue and hard tissues. And some studies which said about the surgical outcome, the periodontal phenotype, periodontal effect of periodontal phenotype in surgical outcomes, that are crown lengthening resulted in more soft tissue rebound in teeth with thick periodontal phenotype. And the recent study on influence of periodontal phenotype on outcome of open flap debridement revealed that sites with more than 7 mm probing depth presenting greater clinical attachment loss gain in thick periodontal phenotype than thin periodontal phenotype. So the conclusion is that periodontal phenotype can be an important factor influencing cal gain in open flap debridement procedures, root coverage, soft tissue grafting procedure, and for the implant success. Thank you.
Okay, Dr. Krishnan.
Yes, ma'am.
Does the gingival biotype has any impact on prognosis of the treatment?
Yes, ma'am. In case of soft tissue grafting, or in case of implant treatment management, in thin periodontal phenotype, there is more chances of recession or dehiscence or fenestration. But in thick phenotype, there is more collagen and more blood supply of the gingival tissue. So there is a good chances of good outcome in thick periodontal phenotype.
Okay, so what should be the ideal range or thickness of gingiva?
Ma'am, there is no universal rule or classification for the periodontal phenotype or thickness. Every author has own criteria, but nowadays, after 2017 World Workshop, decided the less than 1 is in category of thin, and more than 1 mm is in category of thick phenotype.
Okay. Okay, over to you, Dr. Komal.
Okay. What about the non-invasive method of checking the periodontal phenotype?
I mean, non-invasive methods, we can visualize method, we can see the fibrotic or the gingiva or the shapes of the tooth. And then, ma'am, the visual method, it cannot be good or in compare of
no, any advanced non-invasive technique.
Ji, ma'am,
Advanced non-invasive technique.
Advanced non-invasive technique, ma'am. Ultrasonic. Hello. Ji, ma'am. Yeah. We can use ultrasonic, which is based on echo pulse. There is a probe from which we can measure the thickness of the gingiva.
Okay. Thank you. Next, please.
Thank you.
Am I audible?
Yes, please start.
Good afternoon, everyone. So my today's poster presentation topic is a review, that is biomarkers, a boon for predictability of periodontal diseases. So starting with the history, the term biological marker was introduced in 1950s and the term biomarker was given in 1980. Coming to the introduction, which is a definition, a biomarker is a substance used to indicate a biological state and is an objective measure to evaluate and present and future disease activity. It is defined as a substance that is measured objectively and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacological response to a therapeutic intervention. And there are certain media used for the detection of biomarkers, that is gingival clavicular fluid, saliva, serum, urine, etc. And then coming to the classification, it is classified as proteomic biomarkers, genetic biomarkers, microbial biomarkers, and other biomarkers. In proteomic biomarkers, it consists of alkaline phosphatase, aminopeptidase, lactoferrin, translactoferrin, IgM, MMP13, MMP8, MMP9. In genetic biomarkers, it consists of interleukin group, that is IL-1 polymorphism, IL-10 polymorphism, T1 necrosis factor polymorphism. And in microbial biomarkers, aggregative factor actinomycetin commitans, Campylobacter rectus, Mycoplasma, Porphyromonas gingivalis, and P. intermedia, whereas other biomarkers consist of calcium, cortisol, hydrogen sulfide, methyl mercaptan pyridine. Now, coming to the characteristics, so the question arises, what is an ideal biomarker? It should be reliable. It should be applicable during diagnosis, staging, and prognosis. It should be consistent among gender and ethnic groups. It should be modifiable with treatment. It should be cost efficient for follow-up, and it should be safe and easy to measure.
There are various chairside kits available in the market, like a BANA test, prognostic, evaluate, periocheck, periocard, BioLyse, and Topaz, and the perioscan. The advantages of the biomarkers are easy to use, and they are cost effective, and they are non-invasive. The limitations of biomarkers is clinical and radiographic measurements of the attachment loss are not precisely accurate, and the individual susceptibility to periodontitis varies both genetically and over the time.
So the conclusion is all this evolutionary process has promoted the discovery of new biomarkers and the development of new therapeutic approaches, mainly using host modulation.
Okay. Can you tell us something about the genetic test kits and their advantages?
Ma'am, genetic
Interleukin polymorphisms, then cathepsin C polymorphism, and TNF alpha gene polymorphism, and the CD14 gene polymorphism are detected in the genetic biomarkers. And
Okay. What does PerioSafe detect?
what, ma'am?
PerioSafe. PerioSafe or implant safe?
PerioSafe or implant safe?
PerioSafe.
It is used to detect?
Peri-implant peri-implant diseases.
No.
Ma'am, it detects the enzymatic activity.
Which enzyme in particular?
Ma'am, aspartate transaminases.
No. Okay, over to you, Dr. Komal.
Can you name a few bone-related biomarkers?
Ma'am, osteocalcin, osteonectin.
What are epigenetic biomarkers?
Epigenetic.
What is a nucleic acid probe? That's it. Thank you. Next, please.
Am I audible?
Yes,
Yeah,
please start.
As we all know, good morning, ma'am. As we all know, periodontitis is a progressive inflammatory disease of which clinical management is a challenge right now. Because there's currently plaque removal and inflammation control by scaling and root planing is the most common method which we kept on relying in the periodontology. But this cannot restore the attachment of the periodontal ligament. Therefore, the function is impaired. So, through this poster, I am focusing on the periodontal regeneration, its challenges and future perspective. For the above, methods for regeneration is guided tissue regeneration, enamel matrix derivatives, grafts, growth factors, and tissue engineering. The basic principle behind tissue engineering is it induces the formation of naked resident dental follicle cells, which normally vanishes when the tooth development completes. The tissue engineering includes two major steps, scaffold formation and the complete drug delivery system. The scaffold formation is done by the collagen, fibronectin, fibrin, hyaluronic acid, proteoglycan, foams, fibers, gels, and membranes. The cells which help in the scaffold formation and the regeneration are the adult stem cells, embryonic stem cells, marrow-stroma cells, stem cells, periodontal stem cells, and dental pulp stem cells. What is the controlled delivery system? In this system, this model is proposed by the Jiangzhou in the Biomatter Journal, published in the PubMed. In this, the multi-drugs are lined with the blank lines in between these. The blank lines are for increasing the lag phase to release the drug sequentially. This is called the temporo-spatial control by the controlled delivery system. The future perspectives of the periodontal regenerations are the cell culture and the multiphasic scaffold formation. The cell culture includes cell sheeting and the spheroid culture. In the cell sheeting, the cells are cultured. For example, the cells of periodontal stem cells. The cells are cultured. They form the cellular junction in the extracellular matrix. At greater than 37 degrees Celsius, they are hydrophobic, and less than 32 degrees Celsius, they are hydrophilic. When they are hydrophilic, they remain attached to the water content and will help in the regeneration of the periodontium. A polymer called as isopropyl acrylamide polymer is used in the cell sheeting technique. It is a scaffold-free technique. The drawback of this technique is that it leads to the single structure formation only, whereas the tooth is the multi-structured. Multi-phase scaffold includes electrospinning and the 3D printing. Electrospinning uses the voltage applied polymer solution in which the fiber in the form of the nanofibers is evacuated. The challenges which we face in the periodontal regeneration are these: the traditional biomaterials do not mimic the finer structures like the acellular cementum or the cellular cementum, and basically they do not regenerate the sharpest fiber, which is a major connection between the bone and the root of the tooth. Non-maintenance of the temporal and the spatial control of the controlled delivery system, and the lack of clarity of basic biology of repair and healing of the periodontal tissue. Another knowledge gap is the proper concentration. Like right now, we don't know the proper concentration of the drugs and growth factors. And the last is the restoration of horizontal alveolar bone loss. Because of the horizontal bone loss, we don't have the concise area to concise the graft or any regenerative material. Thank you, ma'am.
Okay, Dr. Anjali. Can you hear me? Am I audible?
Ma'am, Dr. Mrinalini here.
Okay, sorry. Can you hear me?
Yes, ma'am, I can hear you.
Okay, can you name any immunomodulatory biomaterial which has nanofibrous microspheres, which is used in periodontal regeneration?
Immunomodulated.
Immunomodulatory biomaterial, which basically has nanofibrous microspheres.
Ma'am,
And it mimics it mimics the extracellular bone matrix.
Sorry, ma'am.
Okay, can you name any drug which can promote periodontal regeneration? Commonly used drugs that promote periodontal regeneration.
Ma'am, doxycycline.
Okay, any other?
Ma'am, ketoprofen.
Not exactly.
Because they are also used in the controlled delivery system in which the periodontal regeneration is conducted.
No, any drug which has osteogenic potential. Which promotes the osteogenic differentiation. Any anti-diabetic drug which you can remember? Okay, never mind. Over to you, Dr. Komal.
Dr. Mrinalini,
yes,
how do you assess periodontal regeneration? Are you there?
Yes, ma'am.
Yeah. How do you assess? What are the methods to assess regeneration? Which is the best method?
Pardon, please, ma'am.
Which is the best method to assess regeneration?
Ma'am.
Okay.
So this was the last presentation for this session. I would like to thank our chairperson for chairing this session. Now moving forward to next session. Here we have 9 presentations in this session. So for this session, our chairperson are Dr. Komal Puri ma'am and Dr. Shweta Sood ma'am. We welcome you, ma'am.
Thank you, Priya.
Over to you, ma'am.
Good afternoon, everybody. Today I am presenting a poster on the topic Role of Dental Evidence in Forensic Investigations. The term forensic dentistry or forensic odontology, it comes from the Latin word forensic. It means a forum or a platform where legal matters are discussed. So, science of dentistry as related to the law is known as forensic dentistry or forensic odontology. Theory behind the forensic odontology is no two mouths are alike. The dental evidence can help us in age determination, race determination, habits and cultural activities of various ethnic groups, sex determination, and economic status of the deceased or dead person. How does they help in age determination? We can determine the age with the help of number and sequence of erupted tooth. Same for race determination. It has been shown that shoveling or scooping of upper incisors in Asiatic Mongoloids is present. Pipe smoking, cigarette smoking, and tobacco smoking. These all habits give specific features to the teeth and the oral cavity. Now, what can be the dental evidence? The dental evidence can be a tooth, it can be saliva, it can be bite mark, it can be skull or alveolar process with tooth, which can be obtained from mass disaster cases. It can be a prosthesis. Now, there are various methods to analyze dental evidence. These methods include bite mark analysis. In this method, we obtain the bite mark from the victim's body, from the eatable or any non-living matter also. We can obtain the occlusion or the arrangement of the teeth of the victim or the suspected person and compare it with the suspected case. Another important method is comparison of the post-mortem records and the ante-mortem records. Ante-mortem records are usually present with the dentist. They can be in the form of casts, they can be in the form of impressions or the bite marks on the vaccines. From the post-mortem records, we can obtain the size and shape, various osseous defects that can be compared with the ante-mortem records. Another method includes DNA profiling. DNA profiling can be done from saliva and or also DNA is obtained from pulp. Now, there is also another method where we compare the palatal rugae. Palatal rugae, they undergo very less alteration with the age. They are mostly helpful in the cases of edentulous patients. We can compare the palatal rugae in the dead person with the suspected one. Also, the radiographic analysis play a significant role. If we have the radiographs of before death or incident or after, we can compare the osseous defects, the developmental defects, any anomaly present. Thank you.
Okay. You told that we can detect the economic status of an individual using forensic dentistry. How is it possible?
We can determine the socioeconomic status like the poor people cannot afford the caps of ceramics or zirconia caps. If we have, if the presence of zirconia caps or good implants are present in the mouth of the dead person, it means obviously he can afford the that cost. So it is of he might be a rich person. So in this way, we can determine the socioeconomic status also about and how he maintain the oral hygiene also affects.
Okay, are there any softwares that are being used in forensic dentistry?
There are various softwares.
which are used for antemortem and comparing the antemortem and postmortem records. One such software is then Solver software is there, and also DCIA software is there, in which digital comparison is done with the records, antemortem and postmortem records. There are other software also. I know these two softwares.
Okay, thank you. Over to you,
Thank
Dr.
you, ma'am.
What do you mean by amyloglyphics? Amyloglyphics.
Amyloglyphics.
What about amylogenin gene? Are you aware of?
Yes, ma'am. Amylogenin gene. We use the amylogenin gene also in determination of sex. It is different on X chromosome and Y chromosome. From this gene, amyl gene, amylogenin gene, we can identify the sex of the person. It is having different sequence in male and females.
Thank you. Next.
Thank you, ma'am.
Good afternoon, ma'am.
Good afternoon. Please start.
Okay. I'm Dr. Sanjay here to present nutrogenics, its role in periodontal health and disease. Nutrogenomics is a science which study the effect of bioactive food components on gene expression. It has four basic tools, which are proteome, transcriptome, epigenome, and metabolome, through which it regulates our body systems. And the nutrogenetics, the gene affects how our body responds to food, and nutrogenomics, what we take, affects how our gene behaves. The mechanism by which nutrients influence the gene expression. Gene expression is nothing but it's a protein synthesis by transcription and translation, and it's regulated by transcription factor and transcription process. Here, the bioactive food act as a regulatory sequences in DNA and binding to the promoter sites and continue with the mRNA conversion and finally results in protein synthesis. The protein formed here is either it may be beneficial or as well as harmful to our body, and this protein synthesis can be inhibited at the level of transcription in the promoter site of the DNA. Another way of regulation is through chromatin structure and DNA susceptibility. It is inhibited at the transcription level when there is chromatin is inactive and acylated histone and demethylated cytosine is present. And our dietary factors also affect the DNA methylation process. DNA methylation is nothing but it's an epigenetic. It alters the DNA activity without altering its sequences. In our food enriched with folate, vitamin 6 and 12, increase the level of methyl tetrahydrofolate for the conversion of methionine into S-acetyl methionine, which is a methyl donor for the DNA methylation process. So the role of this DNA methylation is to control the gene expression to avoid unwanted protein synthesis. And the DNA damage is mainly because of the oxidative stress and excess calories and nutritional deficiency. So to avoid this, we should advise the individuals with the suspectable dietary intakes. And on periodontal inflammation, the oxidative stress is a major risk factor. Associate our periodontal disease with other systemic conditions, which are cardiovascular, obesity, rheumatoid arthritis, and type 2 diabetes mellitus. And other nutrition factors like selenium, it reduces the periodontal destruction by reducing the conversion of lipids and phospholipids into harmful product. And the polyunsaturated fatty acid enriched with omega-3 fatty acid, which help us to reduce the pro-inflammatory markers at the site of alveolar bone loss. By the way, it reduces the bone destruction in periodontia. And other nutrients like antioxidants and the vitamins are essential for maintaining the periodontium and its health. And mainly the vitamin A is essential for maintaining the epithelial tissue integrity. And other micronutrients like calcium, antioxidants, and vitamin D are essential for maintaining the periodontal alveolar bone. So coming to the conclusion, a clear understanding of the interaction has the potential to support the disease prevention through optimization of dietary recommendation. If our diet is correct, there is no need of medicine. If our diet is wrong, there is no use of medicine. Thank you.
Okay, nowadays we are talking a lot about zinc. So what impact has zinc on periodontal tissues?
Ma'am, zinc is very essential for maintaining the periodontal health, ma'am, by reducing the markers at the site of inflammation.
How does it do? What exactly is the mechanism?
Ma'am, it acts on the inflammatory release by the macrophages and monocytes at the site of inflammation.
does it reduce the oxidative stress in the tissues?
Yes, ma'am. It also acts as antioxidants for to protect our periodontium, ma'am.
Okay, what all nutrients act as antioxidants?
Ma'am, nitric oxide and citrus fruits are the major antioxidants, and vitamin A, D or E and or act as an antioxidant, and mainly vitamin C is more essential for the antioxidants, ma'am, in our food. Citrus fruits are plays major role in antioxidants, ma'am.
Okay. Okay, over to you, Dr. Komal.
According to the NANS survey conducted, what do you think who are at most risk of the periodontal disease?
Ma'am, ma'am. Yes, ma'am.
Who has the worst periodontal disease according to you? Like as far as your nutrigenomics is concerned, who has the worst periodontal condition? And there's
The
a NANS
patients who have
survey also conducted according to that.
Autoimmune disease patients have more risk for this.
Anything related to the nutrition?
Yes, ma'am. Mainly systemic conditions, patients are more risk for periodontal conditions, ma'am.
Read about the latest NANS survey.
Okay, ma'am.
And how is LDL and HDL
Ma'am,
associated with the periodontitis?
Yes, ma'am. The oxidative stresses plays major role, ma'am. It decreases the level of HDL and increases LDL content, ma'am. Free radicals plays major role here, ma'am. And that also involved in inflammation. It releases the inflammatory markers at the site, ma'am.
Which is more harmful?
Ma'am, LDL, decreased in
also.
LDL and decreased HDL and increased LDL will be more harmful, ma'am. Oxidative stress is major role here, ma'am.
Thank you. Next,
Thank you,
please.
ma'am.
Good afternoon. This is Dr. Vasudev. Today's my topic for post presentation is on assessment of prevalence of myths regarding oral health among the non-medical students in Nellore, Andhra Pradesh. Myths are defined as something that many people believe that does not exist or it's false. Introduction. Myths regarding oral health have strong influence among the individuals seeking treatment during illness. Awareness of myths and disbeliefs about the disease is necessary in providing dental care. Objectives. According to some recent review of literatures, the prevalence of myths revealed that many of the myths were yet to be studied. Hence, the purpose of this study was to assess the prevalence of myths regarding oral health among non-medical students and suggest possible measures in conveying the facts. Methodology. A cross-sectional study was conducted among 200 non-medical students at the institute in Nellore. In order to assess the prevalence of myths regarding oral health, the data collection was done using a questionnaire based on the myths and facts related to dentistry. Results. This graph depicts when the students were asked about the questions regarding extraction of teeth affect their eyesight, and the more time you brush, more brighter your teeth will be. More than 70% of students agreed with the myth, and they were asked about tooth structure when deposits as felt as a true structure. They completely disagreed with this myth. And when they were asked about flossing creates spacing between the teeth, they are more than 70% were unaware of the facts. And also with this myth, this graph depicts when tooth loss occurs due to aging and swelling creates spacing between the tooth and also increases the sensitivity. More than 60% of students agree with the myth. And when they were asked about internet hacks will help tooth whitening rather than visiting a dentist, and one should stop brushing when the tooth hurts, they completely disagree with the myth. And this pie diagram depicts more than 70% of students were asked about front tooth spacing is lucky. They completely disagree with it. More than 52%, 52.2% of students still believe in myths. Conclusion. Therefore, from the results of the study, concluded that various myths regarding dental treatments are still believed.
Okay, your questionnaire comprised of how many questions?
Almost I had gathered 20 questions. Among them, these questions related to periodontology were taken into consideration.
Which were the questions related to periodontium?
Like flossing creates spacing between the tooth, and tooth deposits on tooth surface are felt as a tooth structure. Like characters which is felt as a tooth structure when while eating they felt like what part of tooth was broken, and more time you brush, more whiter your tooth will be, and gums bleed, you should stop brushing, and having front tooth is lucky. Front tooth spacing, midline digestion.
Okay, what was the age group of your students?
200 people from an engineering college.
Okay, about
25 years.
Around, okay. Right. Over to you, Dr. Komal.
What about the other confounding factors like socioeconomic status and all? Does they affect the assessment of the
socioeconomic status? Just we are these are the common beliefs, misbeliefs the students still believe, and these were the facts that stop from visiting a dentist. These are the fears they have while visiting a dentist.
Is there any difference between the taboos and the myths?
Taboos are just local beliefs which were still believed from the ancient times, whereas myths these even some internet hacks also create some fear. And
does level of literacy plays a role in that?
Yes, definitely.
How?
They need more education. They need to be educated about these myths so that they can. These are the facts, and they need to be educated about the facts so that even they can educate the others regarding these myths and stop believing those myths.
Okay. Thank you. Next, please.
Thank you.
Am I audible, ma'am?
Yes, please start.
Good afternoon, everyone. I'm here to present a poster titled Ozone Therapy, a Revolution in Periodontics. Ozone, coming to the introduction part, ozone is one of the strongest oxidants known, and it consists of 3 oxygen atoms arranged in a triangular configuration with an angle of 116.8 degrees. Ozone is a molecule which has been used as an adjunctive therapy for longer periods in medicine as well as dental uses. Coming to dentistry, it was first used by Dr. E.A. Fish as ozonated water. Ozone can be used in various forms consisting of ozonated water, gaseous ozone, ozonated nanobubbles, and ozone nanobubbles, and and ozonated oils. The mechanism of action has various roles to play. It consists of various mechanisms like antimicrobial action, biosynthetic, it is an antioxidants, it decreases the hypoxia, and it is immunoregulatory. Coming to the various ozone delivery system, there are many ozone systems developed like Helozone. It delivers both the gaseous and the ozonated water. Coming to the ozonitron, it is for the inaccessible areas like the root canals and the pockets, especially used in pedontology. Next is the prozone, which gives the stream of ozonated water. And last is the ozotop, which gives the gaseous stream. Ozone has been used in dentistry widely, like for caries reduction, in root canal therapy, for the bleaching purposes, but specifically in root canal in periodontology. It has been used as an adjunct therapy along with scaling and root planing. It has been seen that it gives much better results compared to the other procedures when it is used as an adjunct with the routine scaling procedure. It is also seen that it helps in pocket reduction in patients of aggressive periodontitis because it helps in reduction of Aggregatibacter actinomycete vomitans. And it helps in maintaining the periodontal health because it acts against the Streptococcus, Staphylococcus, and Candida albicans also. It has been used in the regenerative procedures also. It has been seen that it increases the osteoblast count and increases the total bone area when used as an adjunct. In case of periimplantitis, it has been used successfully because it is antibacterial and antifungal. Moreover, it helps with the oxygenation process and decreases the hypoxia. It also helps by stimulating the anti-inflammatory cytokines, and it decreases the pro-inflammatory cytokines. Coming to the next uses, it is also used as an irrigant because it is antibacterial and antifungal. Moreover, it is also used for different surgical procedures like wound healing. Again, it is because it helps with the oxygenation, it releases the oxygen, decreases hypoxia, and decreases the pro-inflammatory cytokines. And it decreases the immune response by acting on transforming growth factor beta. It increases its production and decreases the other inflammatory cytokines. Coming to its contraindications, it is contraindicated in pregnancy, glucose G6PD deficiency, hypothyroidism, severe anemia, and other alcoholic intoxications. Coming to the conclusion, because of the effective antimicrobial therapy and the increased oxygenation process, it should be made a priority in the dentistry as well as in the periodontology. But thorough research is also advised for more of the knowledge. Thank you so much.
Okay, doctor, you talked about its use in pit and fissure caries and in root caries. How does it act against caries?
Ma'am, it acts against the Streptococcus. It is antibacterial.
That's it? Anything else about it?
Ma'am, it also releases the nascent oxygen because it is very unstable molecule. It helps in the oxygenation and decreases the count of anaerobic bacteria.
Okay, does it have any impact on the smear layer?
Yes, ma'am. It decreases, helps in the removal of the smear layer.
Okay, what is its role in dentin hypersensitivity?
I'm sorry that I don't know.
Okay. Okay. Over to you, Dr. Komal.
According to the recent systematic reviews or Cochrane reviews, what is their say on the use of ozone therapy in perio?
Ma'am, I don't know about that. So,
how is ozone delivered in the? How is it used in perio?
Ma'am, it is used in gaseous form, and some carrier oils are also used, like olive oil or pure oil, like sunflower oils, and water sprays are also used.
How is it delivered into the pocket?
Ma'am, pocket may as in gaseous form.
How?
Ma'am, with these delivery systems, with the
like.
Ma'am, like Ozotop, the Periotron.
So what will you do?
Sorry?
You'll take it into the mouth and deliver it? How will you deliver it?
Ma'am, I don't know. Sorry.
Thank you. Next, please.
Thank you so much, ma'am.
A very good evening to all. I am Dr. Ankit Desai, and my poster topic is Can Alendronate Help Regenerate? Now, as we all know, periodontitis results in the destruction of the connective tissue attachment, the cementum, and the bone. The ultimate goal of periodontal therapy is thus to regenerate the lost periodontium on the previously diseased root surface. Various methods have been used to achieve this, like the use of bone grafts, guided tissue regeneration, and growth factors. The purpose of this poster is to see whether alendronate sodium can help in the regeneration of periodontal tissues. Alendronate sodium is an amino bisphosphonate and has anti-resorptive properties and also has an effect on new bone formation. Animal studies by Juin et al. In 1991 suggested that it inhibits bone resorption by preventing the formation of ruffled borders on osteoclasts, thereby preventing its adhesion to the bone surface. Jernberg in 1997 suggested that it induces new bone formation by inducing the osteoprogenitor cells to form osteoblasts. Various in vitro studies by Thirumal Reddy in 2005 suggested that the gel form can be made free of microbes. It has optimum solubility, pH, and particle size to be used in periodontal defects. So here, as you can see on the figure on the left, alendronate sodium can be used in the gel form, which then can be packed into intrabony defects, or it can be mixed with bone grafts, maybe DFDBA, to be then placed into the intrabony defects. However, there are very limited clinical studies with the use of sodium alendronate. A few studies are stated here. For example, the study by Dutra et al. In 2019 indicated a positive result in the use of alendronate in intrabony defects. It resulted in higher probing depth reduction, higher clinical attachment level gain, higher radiographic mineral density. Similar study by Pradeep AR in suggested again a higher periodontal defect reduction, higher clinical attachment level gain, and defect depth reduction. Whenever we speak of any bisphosphonate, there are always chances of osteoradionecrosis. However, studies by Omar M suggested a very low incidence of osteoradionecrosis or osteonecrosis of the jaw in patients receiving oral bisphosphonates. Thus, to conclude, animal and in vitro studies do indicate a beneficial effect of application of 1% alendronate sodium in intrabony defects. However, randomized controlled trials are very few. Hence, more studies, systematic reviews, and meta-analysis needs to be carried out to determine if 1% alendronate sodium can help in the regeneration of periodontal tissues. Thank you.
Okay. Jaw osteonecrosis is common with oral alendronate or systemic alendronates?
Ma'am, as I saw, studies by Oman have suggested that the incidence is extremely low with oral bisphosphonates. However, with in patients who have got bone tumors where IV bisphosphonates are administered, the chances of necrosis are much higher.
Okay, in which conditions we give oral alendronate?
Ma'am, mainly in patients with osteoporosis, Paget's disease are the various conditions in which you might require bisphosphonates. It has also been used in patients with cancer.
Okay, is there any local drug delivery preparation
A gel
consisting
form,
of?
yeah, a gel form of alendronate can be used as a local drug delivery system as an adjunct to mechanical therapy.
Okay, are there any studies you know about?
Ma'am, there is one study by Pradeep AR et al. Where they have used it. It's the one before the one that I have mentioned, where they have used it as an local drug delivery system in a gel form, and they have found positive results.
Okay.
But
Over
that
to
does
you,
not have any effect on the bone.
Okay. Over to you, ma'am.
What is the mechanism by which this alendronate plus DFDBA works?
Ma'am, alendronate will inhibit bone resorption, as I said, because it will prevent the formation of the ruffle borders on the osteoclasts, whereas it will help the osteoprogenitor cells to form new bone. Now, alendronate alone will not help in regenerating the periodontal tissues. It can only help, and hence it should be used in conjunct with bone grafts or along with the guided tissue regeneration.
When used systemically, are you aware of any drug interactions with the alendronate?
Drug interaction?
The drugs which should not be prescribed along with.
No, I'm not sure.
Thank you. That's it. Next, please.
Thank you.
Hello. Good evening, ma'am.
Good evening. Please start.
Good evening. My name is Dhwani, and my topic for the poster presentation is dermatoglyphics in periodontics. Dermatoglyphics is basically a Greek word wherein derma means skin and glyphics meaning carving. Dermatoglyphics is thus a study of the configuration of the epidermal ridges on palms, fingers, and soles and toes. And here its relation in periodontitis. Periodontitis is basically a chronic inflammatory condition associated with the destruction of periodontal tissues, and it has periodontal disease are basically multifactorial diseases. The Harold Cummins is basically Harold Cummins is known as the father of dermatoglyphics. The various finger patterns are the word loops that comes under that has two subdivisions, that is the ulnar and the radial and the arch patterns. The methodology for recording the fingerprints are the newer methods is the scanning, that is the digitalization. The older methods included ink, that is the ink pad and the staining, and also it included a plastic mold. In a study conducted by Vaidya et al., she reported that the patients with chronic periodontitis had higher number of ulnar loops followed by the whorls as compared to the healthy periodontitis patients. Recently, dermatoglyphics is also linked to chronic inflammatory diseases such as the Down syndrome and the Turner syndrome, etc. The main advantages of dermatoglyphics is it is easy to use, with which it can be recorded. It is easy to store the recorded data, and relatively easy interpretation of the data, and the cost effectiveness as it does not require large equipment or the laboratory investigations. Dermatoglyphics could be used together with other diagnostic methods such as the clinical and radiographic investigations in identifying patients with distinct group of periodontal diseases. Early detection can also lead to early prevention in young children. Thank you.
Okay. Can you predict any oral disorders using dermatoglyphics?
Ma'am, so there were various studies conducted for the linkage of dermatoglyphics and periodontitis, wherein chronic periodontitis showed more correlation with dermatoglyphics.
So other than periodontitis, any other oral disorders? Like caries or some malocclusions? Can these be related?
There are studies undergoing which have been conducted for correlation with caries, but no significant result has been obtained.
Okay. Are there any softwares in this field? Are there any softwares that are being used in this field? Any digital mode or any software?
Yes, ma'am. Digital, the fingerprint scanner.
Okay, over to you, Dr. Komal.
Are the fingerprint patterns same for both the hands?
None, not necessarily. They differ.
What about the fingers? Different fingers.
Ma'am, different fingers have different fingerprint patterns.
Different fingerprints. And any association of these fingerprints with the aggressive periodontitis? Any study you came across?
Yes, ma'am. There are studies that are conducted for periodontitis, but they don't have any significant results as such. Whereas the chronic periodontitis and dermatoglyphics have significant results.
Which is the most commonly found fingerprint pattern?
Ma'am, in this study conducted by Vaidya et al., it was ulnar loops, whereas in other studies conducted by S.S. Satya Karthikeyan, it was the whorls. That was most common.
Thank you. That's it.
Thank you, ma'am.
Next, please.
Good evening. Good evening, ma'am. Am I audible?
Yes, please start.
Myself, Dr. Taranum. Today, I'm going to present. E-poster on ergonomics. It's your body at work. Ergonomic is basically a Greek word in which ergo means to work and nomos meaning natural law. It is way to work harder, smarter by designing tool, equipments, workstation, and tasks to fit the job to the worker, not the worker to the job. Relating to this, when dentists do not follow proper posture and positioning of the patient, it can result in ergonomic injuries like musculoskeletal disorder and cumulative trauma disorder. Musculoskeletal disorder is a work-related disorder of the musculoskeletal system having chronic gradual onset involving muscle, tendons, ligaments, joints, nerves, cartilage, and spinal disc. Musculoskeletal disorders are an increasing healthcare issue globally, being second leading cause of disability. Being a review of international dental literature states that approximately 65% of dentists report with musculoskeletal complaints of pain, discomfort, impediment in functioning, and increased working time. The cumulative trauma disorder, one of the example in cumulative trauma disorder is carpal tunnel syndrome. It is one of the nerve related disorder primarily involving the median nerve of the wrist and can be provoked by exposure to vibrations. Carpal tunnel syndrome has been linked with both repetitive and forceful work. Risk factors includes repetition, awkward posture, vibration, force, contact stresses. Area of ergonomic importance in dentistry is working posture. One should follow the correct working posture and maintain an erect position. Use an adjustable chair with lumbar and thoracic and arm support. Work close to your body. Adjust the height of your body and around the chair to the comfortable level. Position of the patient should be supine. The operator should able to move his leg freely to avoid the twisting and bending of the torsos. The lighting should be good. So the light source should be in patient's mid-sagittal plane. Instrument should be hollow and resin handles, rounded, lightweight, adequate lumen size, null handles, and easy activation and placement. As it is said, prevention is better than cure. Prevention of any disease saves time, money, and pain. Regular exercise and strengthening helps to prevent injuries and combat stress, thereby improving the quality of life. Some of the example of exercise which one follow in day-to-day routine, like shoulder blade, ear-to-ear shoulder exercise, open and closing of the wrist, then back stretch, thumb stretch, back lift, spinal twist, and wrist flexors. The conclusion of the poster is it is important that dentists incorporate these strategies into practice to facilitate balanced musculoskeletal health that will enable longer, healthier career, increase productivity, provide safer workplace, and prevent musculoskeletal disorder. I'm just ending my poster by saying, take care of your body. It's the only place you have to live. Thank you.
Okay. So how does the knowledge of ergonomics help in designing our instruments or designing the dental armamentarium?
Ma'am, the instrument should not be heavy weighted. It should be light weighted, and the shallow halo should be present. Knurling of the texture should be knurled.
Okay, regarding dental chairs.
Ma'am, the chair should be comfortable. The operator's chair should be chair should be with comfortable adjustable chair with lumbar, thoracic, and arm support. And the legs should reach the feet should reach the ground.
Okay, are there any studies you know that it has an impact on the therapy? Improper posture has an impact on the therapy.
Sorry, ma'am.
Any studies on them? Okay.
No.
Okay, over to you, Dr. Komal.
How is ergonomics applied in periodontal practice?
Ma'am, repetition forces are there in periodontics while scaling and while doing scaling. So the instrument should be lightweighted and lightweighted.
What do you mean by neutral neck or neutral back position?
Ma'am, the neck and back should be in straight posture.
Absolutely straight, or some variation is allowed?
Ma'am, no, it should be in straight posture.
Any range or degree or angulation?
145 degree angulation.
145 is too much.
Sorry.
Thank you. That's it. Yes.
Good evening, ma'am.
Good
Am I
evening.
audible, ma'am?
Please start. Yes.
I'm going to present osteogenic action of PVP-coated silver nanoparticles in MG63 osteoblast cell line. Silver nanoparticles have been widely used in bone grafts due to their antimicrobial antiviral properties. Induction of growth of osteoblast and promotion of osteogenic differentiation are important attributes of bone repair material. Nowadays, nanotechnology and nanomaterial are fully integrated in the field of periodontics. The aim of the study to access the effect of the silver nanoparticles upon the cytotoxicity and osteogenic differentiation of alkaline phosphatase osteopontin and RAN-X2 in MG63 osteoblast cell line. Materials and methods used: MG63 osteoblast cell line, testing material less than 100 nanometer cytodiagnostic silver nanoparticles. Cytotoxicity of silver nanoparticles was assessed using MTT assay in different concentrations 0.5, 1, 2, 4, and 8 microgram per milliliter. Results showed maximum viability seen at 0.5 microgram per milliliter of silver nanoparticles, while higher concentrations of 8 microgram per milliliter resulted in decrease in cell viability. Next, to assess the alkaline phosphatase activity after 3, 7, and 14 days of culture using ELISA, alkaline phosphatase activity was increased at 3, 7, and 14 days of exposure. The result of alkaline phosphatase assay showed that exposure to silver nanoparticles can promote osteogenic differentiation of MG63 osteoblast cell line. Third, to assess the expression of bone marker osteopontin and RAN-X2 using real-time quantitative PCR. The expression of osteopontin RAN-X2 in silver nanoparticles exposed cells increased significantly comparing to control. P-value is less than 0.001. And I concluded that silver nanoparticles can promote osteogenic differentiation of MG63 osteoblast cell line at viable concentration of 0.5 microgram per milliliter. So silver nanoparticles can be considered as a promising material for periodontal regenerative therapy. Thank you, ma'am.
Okay, what are other therapeutic properties of silver nanoparticles?
It can be used for implants, ma'am.
Any
For
other
antimicrobial properties.
Okay.
To prevent peri-implantitis and
it's specifically against any particular organisms? Are you aware of any sheets of this, nano silver particles which are used as wound healing?
It can be used in wound dressing, ma'am.
Wound dressing, okay.
Yes,
after the surgery, after periodontal surgery, with the co-pack? Any studies on that? Okay, over to you, Dr. Komal.
Dr. Jasmine, any toxic effects of these on the cells?
Yes, ma'am. Reduced mitochondrial function, ma'am. Increased reactive oxygen species, and in general, argyria, ma'am. It changes.
Are you aware of
color
any
of the
bone
face.
grafts or GTR membranes which are coated with this?
Implants.
What about its antibacterial activity?
It enters into the cell membrane, and silver ions kill the bacteria, ma'am.
Thank you. Next.
Thank you. Thank you.
Good evening, ma'am. I am audible, ma'am.
Yes, please start.
Okay. Good evening, ma'am.
Good evening.
My topic is medical emergencies in periodontal practice. Medical emergency, adrenal crisis. Sign and symptoms of adrenal crisis are collapse, pallor, cold, calm skin. hypotension and dizziness, vomiting and diarrhea. Management include airway, breathing, circulation, disability, exposure, lie flat, administer oxygen, administer hydrocortisone 100 milligram IM. Anaphylaxis. Sign and symptoms of anaphylaxis is sudden onset, urticaria, angioedema, flushing in pallor, respiratory distress, wheeze, hoarseness, hypotension, and tachycardia. Management include make the patient lie down flat with legs raised, oxygen administration, and administer adrenaline. Asthma. Sign and symptoms of asthma includes breathlessness, expiratory wheeze, severe inability to complete sentence in one breath. Principal management of asthma is position, sit upright, airway, breathing, circulation, definitive therapies. Epileptic seizures. Sign and symptom include sudden collapse, loss of consciousness, rigidity, cyanosis, jerking movement, noisy breathing, tongue may be bitten, frothing at mouth. Management include airway, breathing, circulation, safe environment, prevent injury, do not put anything into mouth, do not restrain, administer oxygen. And if prolonged convulsive seizures, then midazolam oromucosal solution can be given via the buccal route in adults as a single dose of 10 milligrams. Hypoglycemia. Sign and symptoms of hypoglycemia is shaking, slurred speech, sweating, tiredness, confusion, unconsciousness. Management includes airway, breathing, circulation, disability, offer 15 to 20 gram carbohydrates. If impaired unconsciousness, then hospitalization. Once consciousness returns, then offer oral carbohydrates. Syncope. Sign and symptoms of syncope is feels faint, dizziness, lightheaded, collapse, loss of consciousness, pallor, sweating, slow pulse, low BP, nausea, and vomiting. Management include airway, breathing, circulation, disability, exposure. Lie flat, elevate legs, loosen tight clothing. Once consciousness returns, then offer glucose in water. Stroke. Sign and symptom of stroke is facial and arm weakness, speech problems, and management include airway, breathing, circulation, administer oxygen, and appropriate position. Thank you, ma'am.
Okay, how will you manage a patient if he develops allergic reaction to local anesthesia?
Allergic reaction, then ma'am, give adrenaline 0.5 milligram IM, or maybe give an epinephrine IM.
Are you going to do any sensitivity test before administering local anesthesia to a patient? Do you do it in your clinical practice?
Ma'am, it's necessary, but in general practice, in every patient, we can't do.
Why? Why can't we do? If a patient is visiting to your office for the first time, shouldn't it be done?
Yeah, ma'am, we should only we take history. After history, we can go.
Okay, how will you manage a patient with hypoglycemia?
Hypoglycemia. Ma'am, firstly, in hypoglycemic patient, basically we give 15 to 20 gram carbohydrate, or we can give, if in consciousness, then we give juices, 3 to 4 teaspoons sugar, a hard candy, and honey.
If the patient is unconscious, then what will you do?
Then, ma'am, I am carbohydrate.
Which carbohydrate are you going to give?
Gluco carbohydrates, ma'am.
Okay, over to you, Dr. Komal.
What is more dangerous, hypoglycemia or hyperglycemia?
Ma'am, hypoglycemia.
And if you are not aware and the patient has gone into syncope, what will you do? How will you treat it?
What, ma'am?
You don't know the patient has has gone into syncope. What will you
Yeah.
treat? Hypoglycemic patient or a hyperglycemic?
Ma'am, firstly, we treat like a syncope and then alternative diagnosis like hypoglycemia.
It is because of that only. The attack is because of that.
Ma'am, in history, we taken like if patient is hypoglycemic or something. If patient didn't give history, then firstly treat like a syncopation. Then fastly alternative diagnosis is hypoglycemia.
Okay. Thank you. Next, please.
Thank you, ma'am.
Good afternoon. Should I start?
Yes, please.
Good afternoon, everyone. My name is Dr. Kasturi Satam, and my topic for today's poster presentation is epigenetics in periodontics. So, to explain in simple terms, epigenetic factors can be considered as an interface between genetic factors and all other factors, which include systemic, environmental, and lifestyle factors. It is defined as the changes in the gene expression that are not encoded in the DNA sequence. So what bring about these changes? These changes are brought about by chemical alterations in the DNA and its associated proteins, which leads to remodeling of the chromatin material. And this in turn leads to activation or inactivation of a particular gene. Conrad Hall Waddington coined the term epigenetics in 1940 and is known as the father of epigenetics. Epigenetic mechanisms involve DNA methylation, presence of non-coding RNA, and histone modifications. So, structural changes like addition of a methyl group or configurational changes of histone proteins or the presence of a non-coding RNA may lead to suppression of transcription factors, and this in turn can lead to silencing of a particular gene. In periodontics, epigenome of the host as well as the oral pathogen is equally important in determining the severity of the compounds like DNA methyltransferase, histone deacetylation inhibitors, and inflammatory cytokines govern these mechanisms. Various factors like genetic factors and environmental factors determine the host inflammatory reaction of an individual. The presence of infection and its subsequent inflammatory response will determine the epigenome or the epigenetic makeup of the organism. And this in turn will tell us if the organism is susceptible, if there is any increase in susceptibility to infection. So to study these factors, it will allow us for a better diagnosis, prevention, and better treatment of the condition. Thank you.
Okay, can you name any DNA methylation inhibitors?
5-acetidine is one of the drug which is used, which is a DNA methyl inhibitor,
And
methyltransferase inhibitor.
It is used in which cases? Which conditions?
It is used mostly for cancer treatments, and for it is used when there is DNA hypermethylation and changes because of that.
Okay, any histone deacetyl inhibitors?
Borinostat is one of the drug which was used initially, and romidespin is also used.
Okay, over to you, Dr. Komal.
What is epigenetic mapping?
Sorry, ma'am, I did not.
What is epigenetic mapping?
Ma'am, the gene structure and the changes in the structure with the when there is interaction with other factors like environmental factors or systemic factors. Ma'am, no.
What about epigenetic therapy?
These drugs can be given like DNA methyltransferase inhibitors or histone deacetylase inhibitors. When they are given, they constitute the therapy.
Which was the first introduced one?
Ma'am, I think Borinostat was the first that was introduced.
Okay. Thank you.
Thank you.
So with this, it's the end of today's session. So on the behalf of ISP, I would like to express our sincere thanks to our chairperson, Dr. Komal ma'am and Dr. Shweta ma'am for giving excellent coverage and who spared time for her busiest schedule schedule to grace the session. We thank you, ma'am, for being with us. Thank you so much, ma'am.
Thank you so much.
Thank you, Dr. Komal.
Thank you, Dr.
Thank you so much.
रविंदर जी,
हाँ जी,
अभी इसके बाद एक 2-3 मिनट के बाद रख के बंद कीजिए।
लाइव है मैम, प्लेटफॉर्म पे आवाज है।
ठीक है।